is growing as one of the largest healthcare chains in India and has 33 hospitals in 17 different cities and international presence at 2 locations, that is Klang in Malaysia and in Lagos in Nigeria. Here at Palam Hospital, Gurugram, we have a state-of-art department with highest and best practices. ATOM, the Association of Transfusion Medicine, is an association with representatives from 20 countries from across South Asia region, and they all have one aim, that is to work together to accelerate the scientific progress and to develop standards in this branch of medicine in all the member countries. So once again, a very warm welcome to all our delegates and guests, and thank you all. And special thanks to Naveen sir, to Dr. Megha ma'am, without whom this event wouldn't have been possible. And also, I would like to extend my thanks to Dr. Gopal, who has been a continuous support throughout. And I hand over the stage for beginning with the productive knowledge exchange. Thank you.
Thank you so much, Dr. Rashmi Sood, for the perfect overview of the CME. So this CME holds a lot of very interesting and phenomenal sessions and panel discussions. Ladies and gentlemen, now let's begin our day with the first session, and I hope everyone is excited for that. So please join me welcoming all the chairpersons for this session. Let us welcome Dr. Nabajyoti Chaudhary on the stage, along with Dr. Nabajyoti Chaudhary and Dr. Gajendra Gupta. They are not here. Let's put your hands together for both of them. Let's welcome Dr. R.N. Makru and Dr. Sangeeta Pathak. Let me introduce both the dignitaries to all of you. Dr. Sangeeta Pathak is the Director and Head Transfusion Medicine, Max Super Speciality Hospital, Secretary General Indian Society of Blood Transfusion, and she holds a wonderful experience of 28 years in transfusion department. She's the recipient of J.G. Jolly Award for the year 2013. And if we talk about the special certifications, there is no count, as there are many. Certificate course in patient blood management and in research and publication by British Medical Journal. She has delivered 19 publications, 5 chapters, 4 editorials, and co-authored a book called Essentials of Transfusion Medicine. Dr. R.N. Makru. Sir is the Chief Medical Advisor, Mitra Industries Private Limited, Managing Director, TNT Consultancy, ex-Director and Professor, Department of Transfusion Medicine, Molecular Biology and Transplant Immunology, Indraprasth Apollo Hospital, New Delhi. We will have a bouquet felicitation. Please, let's welcome Dr. Rashmi Sood on the stage to deliver a floral bouquet. Okay. That's been done already. And now it's over to the chairpersons to welcome the speakers for the session.
Can we have the program? Yeah?
Like, who's the first speaker?
Well, in the meantime, let me first compliment Dr. Rashmi and the team, Department of Transfusion Medicine, Manipal Hospitals, and the management of the Manipal Hospital for giving us this opportunity to be here this morning. Well, I will definitely like to compliment Dr. Rishmi for organizing this wonderful show today. And she has involved doctors not only from Delhi, but from most of the important cities of India for the deliberations for today's CME. Well, not taking much time, well, you know, the organizer, the compounder of this program, because once she came, Ms. Gill, she asked you to put hands and put a clamp. Do you know why we do that? Well, we do like this. You know what is the advantage of it? Primarily because there are pressure points in your arm. And once you do like this, you activate almost all the organs of the body. And that is the philosophy behind clapping. And that is what people do when you get up in the morning. And so you activate all your organs, and so you see that what we have a fruitful, memorable conference. Well, now I will like to present the first speaker to you, is Dr. Abhinav Verma. He is the principal consultant and head of Department Transfusion Medicine at Max Hospital. And the organization is Max Super Specialty Hospital, Vishali, Ghaziabad, NCR, UP. He has a fellowship in Hemopathic Stem Cell Transplantation and Apheresis from St. George's University Hospital, London, and BMJ Research to Publication course from University of California, San Francisco, and received a lot of awards, Award of Excellence from the ISBTI. I have the pleasure to present you Dr. Anubhav. Dr. Anubhav.
Thank you, sir, for the kind introduction. And thank you. Good morning, all. Firstly, I would like to thank Dr. Rashmi and the organizing team for giving me this opportunity to talk on a very important topic of transfusion reactions, a brief overview, and especially on hemolytic transfusion reaction. Now, I'll be covering my presentation under the following headings: introduction, classification of transfusion reactions, acute and delayed hemolytic transfusion reactions, incidence, causes, differential diagnosis, pathophysiology, clinical manifestations and diagnosis, investigations, management and prevention, and in the end, summary. Now, to begin with the introduction, as we all know that blood is categorized as a drug under Section 2B of the Drug and Cosmetic Act 1940. So like all drugs, blood transfusions are life-saving, but may also be associated with adverse effects. So hence, appropriate use and careful monitoring for early diagnosis and management of adverse effects are essential for patient safety. At the same time, it is also equally important to report the complications of transfusions to identify the risk factors. Now, this is a slide which I have taken from the ISBT Working Party on Hemovigilance. I'll not go into the detail of all the definitions, but it is very, very important to identify two definitions, that what is an incident and what is an adverse reaction. And this becomes more important whenever we are presenting our transfusion data in front of our hospital management or quality managers or even the clinicians. Now, incident is defined as where the patient is transfused with a blood component which did not meet all the requirements for a suitable transfusion for that patient or that were intended for any other patient. Whereas an adverse reaction is an undesirable response or effect in a patient which is temporarily associated with the administration of blood or blood component. Now, coming to the classification of transfusion reactions, now it can be classified on the basis of time of onset as well as mechanism, whether it's an immune or non-immune. Coming to acute transfusion reactions, immune-mediated, they can be classified as hemolytic transfusion reactions, febrile non-hemolytic transfusion reactions, allergic, anaphylactic, and transfusion-related acute lung injury. Under the category of non-immune mediated, there can be transfusion-associated circulatory overload or TACO, transfusion-associated dyspnea, transfusion-associated hypotension, metabolic complications, and transfusion-transmitted bacterial infections. Under the delayed category of immune-mediated, there are delayed hemolytic transfusion reactions, delayed serological transfusion reactions, post-transfusion purpura, transfusion-associated graft versus host disease, and transfusion-related immunomodulation. Under the non-immune-mediated category, there are transfusion-transmitted viral infections, transfusion-transmitted malaria, transfusion-transmitted prion disease, and iron overload. Now coming to the incidence. Now the incidence of transfusion reactions varies significantly by institution due to different reporting requirement, but it is estimated to occur in approximately 0.1 to 3% of the total transfusions. The most common types of transfusion reactions worldwide include fever and non-severe allergic reactions with manifestations such as rashes, urticaria, and pruritus. Now, coming to the incidence in India. Now, Hemovigilance Program of India, they did a study for over a 5-year period, and they found out that febrile non-hemolytic transfusion reactions and allergic reactions continue to remain the most frequently reported adverse transfusion reactions in India. As per the ABB technical manual, statistically, worldwide, the greatest risk of morbidity and mortality from transfusion is from the non-infectious complications. In fact, transfusion-associated circulatory overload, TRALI, and hemolytic transfusion reactions are the 3 most commonly reported causes of transfusion-related mortality. Now coming to the hemolytic transfusion reactions. Now by definition, a hemolytic transfusion reaction is one in which symptoms and clinical or lab signs are of increased red cell destructions are produced by transfusion. It is usually a result of red cell transfusion. However, it may also result from transfusion of plasma containing blood components such as FFP, platelet concentrate, or containing red cell antibodies. Hemolysis can also occur intravascularly or extravascularly and can be immediate or delayed. Now coming to the acute hemolytic transfusion reactions. Now this is characterized by the onset of clinical or lab features within 24 hours of transfusion. Now, practically, they occur during the first 15 minutes of transfusion. So it's very, very important that we monitor the patient either by the nursing staff or a doctor, especially during the first 15 minutes. Then there are delayed hemolytic transfusion reactions, which are characterized by clinical or lab features of hemolysis, which manifest between 24 hours to 28 days of transfusion. And they are also classified as very late delayed hemolytic transfusion reactions, which can occur from weeks to months or even years later. Now coming to the incidence of hemolytic transfusion reactions. Now since the national hemovigilance programs have been operated in most of the countries and they have their own programs, it's very easy to find out the incidences nationwide. As per the recent short report of UK in 2023, there were 21,98,270 transfusions, and out of that, 1 hemolytic transfusion reactions was reported every 41,500 transfusions. So a total of 53 cases were included, out of which 9 were acute, 31 were delayed, and 13 cases of hyperhemolysis. Out of that, nearly all the cases were from the red cell transfusions, and major morbidity was in 18 cases and number of deaths in 2 cases. And they found that there is slowly an increasing trend of hemolytic transfusion reactions over the years. Coming to what are the causes of hemolytic transfusion reactions and the differential diagnosis. Now, one of the most common causes of hemolytic transfusion reactions are induced by alloantibody to red cell antigen, which could be accidental, such as wrong blood in tube, patient or product misidentification at the bedside, wrong component issued at the blood center, incomplete or inappropriate pre-transfusion testing, errors associated with manual processes, emergency release of an uncross-matched blood, passive transfer of ABO alloantibodies such as platelet mismatch due to limited inventory, Group A plasma in emergency resuscitation of trauma patients, immunoglobulin products such as IVIG and RHIG, ABO incompatible hematopoietic stem cell transplants such as which can lead to acute hemolysis, especially in cases of ABO-incompatible HSCT and passenger lymphocyte syndromes. Now, at the same time, there are certain coexisting conditions that may confound clinically and lab presentations of hemolysis, such as AIHA, G6PD deficiency, sickle cell disease, drug-induced hemolysis, sepsis, active bleeding, mechanical thrombectomy, and hematoma resorption. At the same time, there can be non-human hemolysis associated with transfusion, such as incompatible fluids co-administered with the transfusion, thermal damage, mechanical factors, improper deglycosylation, and G6PD deficient red blood cell donor. So most clinically significant hemolytic transfusion reactions are due to ABO incompatibility. But however, antibodies to other blood group systems such as RH, KEL, Duffy, and KED are specially implicated in significant hemolytic transfusion reactions and could be fatal. Antigen density varies significantly from different red cell antigens, and its abundance influences the severity of the reaction. For example, ABO antigens are present approximately 200,000 to 800,000 per cell, whereas the RH and KEL antigens are present approximately 3,000 to 6,000 per cell, and a difference of 100-fold you can see in between two. Coming to the pathophysiology. Now, the pathophysiology of hemolytic transfusion reaction is dependent on the type of antigens and antibodies involved, as well as the host factors. Broadly, the mechanism of immune hemolysis can be categorized based on the location of hemolysis, whether it's intravascular or extravascular, or by the timing of onset, that is within 24 hours or more than 24 hours to 28 days later. Now, I'll not go into the detail of the pathophysiology, but there are 4 mechanisms which are implicated in hemolytic syndromes, such as the complement system activation, macrophage-mediated mechanism, bystander hemolysis, and the reticulocyte epithelial activation system. Coming to the clinical manifestations and the diagnosis. Now, in an acute immune-mediated hemolytic reactions, the signs and symptoms are present within 24 hours of the implicated transfusion and may include fever with or without chills, flushing, nausea, vomiting, tachycardia, dyspnea, pain at the infusion site, abdomen, chest, flank, or the back pain. There is a subjective sensation which is classically defined as impending doom, and red or dark color urine significantly signifying hemoglobinuria. It has been traditionally believed that the severity of acute hemolytic transfusion reaction is related to the total volume of infusion and the rate of incompatible blood. And even small volumes, such as 10 milliliters, can produce rapid hemolysis and symptoms. Whereas on the other side, manifestations of delayed hemolytic transfusion reactions appear to be more than 24 hours after the implicated transfusion, typically within next 2 weeks, but up to 4 weeks later due to a delayed amnestic antibody response. The most common signs of delayed hemolytic transfusion reactions are fever with or without chills, in addition to an unexpected hemoglobin drop due to the extravascular lysis of the transfused cells. Hemoglobin degradation leads to an increase in the plasma bilirubin level and may manifest as jaundice 5 to 10 days later after the triggering of the transfusion. Now, here you can see 2 graphs. In the first graph, there is a time course of hemolytic and coagulation parameters in the intravascular hemolytic features, which shows that there is rapid drop of hemoglobin and plasma hemoglobin levels within few hours itself. Whereas in delayed hemolytic transfusion reactions, the hemoglobin falls gradually, and it is also increased where we can see conjugated bilirubin and unconjugated bilirubin 7 to 14 days later. So manifestations of hemolytic transfusion reactions occur within hours, whereas it is occurring few days later. Coming to the investigations, which is a very important case of hemolytic transfusion reactions. Now, at the bedside, the first and the most important thing obviously is to stop the transfusion, verify the patient and the product or the component which we have delivered, report it as incident or a reaction, maintain IV access, draw post-transfusion samples and send to the blood center along with the blood bank. Additional baseline lab tests indicated by physicians such as CBC, LDH level, urine analysis, heptoglobin levels, bilirubin, blood urea nitrogen, creatinine coagulation studies, blood smear, and HB electrophoresis. Interconsultation with renal and intensive care specialists and management of complications are necessary. In the blood center lab, firstly, we have to do the visual check of hemolysis, direct Coombs test, ABO-RH verification, antibody screening in pre and post transfusion sample, evaluate, if possible, antigen typing of units, repeat cross-match with pre and post transfusion samples, and also we have to carry out investigations of non-immune causes such as gram staining and culture, investigations of transfusion technique and blood storage conditions, check the blood bag and tubing and segments for any hemolysis. Now, this again is the slide which I have been taken from the National Hemovigilance Program. We were trained in the hemovigilance program in the NIB, and this slide is very, very important. I'll not go into again the detail, but it's very important to classify each and every transfusion reactions once we upload in the National Hemovigilance Program website. So there is an imputability, which means the likelihood that adverse reaction in a recipient can be attributed to blood or blood components transfused. And the imputability levels are given below, which could be definitive. When there is definitive conclusive evidence that beyond reasonable doubt that the adverse event can be attributed to the transfusion. Probable, when the evidence is clearly in favor of attributing the adverse events to the transfusion. Possible, when the evidence is intermediate or attributing to the adverse event to transfusion or an alternate cause. Unlikely, when the evidence is clearly in favor of attributing to the adverse event to causes other than the transfusion. And excluded, when there is conclusive evidence beyond reasonable doubt that the adverse event can be attributed to causes other than the transfusion. At the same time, we should also, whenever transfusion reaction is reported, we have to classify as per the severity grades. Grade 1, which is non-severe, it means the recipient may have required medical intervention, but due to lack of such would not result in permanent damage or impairment of body function. Grade 2, which is severe, when definitely there is inpatient hospitalization or prolongation of hospitalization directly attributed to the event or persistent or significant disability. Grade 3, which is life-threatening, the recipient requires major intervention following the transfusion and to prevent death. And grade 4 is death. The recipient died following an adverse reaction, and the death is possible, probably or definitively related to transfusion. It's also very important that if the recipient died of any other causes, the severity of the reaction should be graded as 1, 2, and 3 instead of 4. Coming to the management, now an acute hemolytic transfusion reaction is always considered as a medical emergency. The first and the most important thing which we have just discussed is to stop the transfusion and any avoiding further blood component, followed by initiation of the establishment of transfusion reaction response and investigation procedure, which we have just discussed in the previous slide. And the therapy is primarily supportive. For example, if we want to maintain hydration, we have to maintain the urine output at 0.5 to 1 milliliter per kg. For supplemented diuretics, we can give furosemide 40 milligram IV bolus and then 10 to 40 milligrams per milliliter monitor for hypertension. Alkalization of urine, we have to give sodium bicarb, 130 millimole per liter in 5% dextrose or 200 milliliter per hour. Maintain urine pH more than 6.5 and discontinue if it exceeds more than 7.5. Blood product transfusions usually required in cases of DIC, where we have to maintain the platelet count more than 20,000, INR more than 2, and fibrinogen level more than 100 milligrams per deciliter. And glucocorticoids as well as IVIG are required to prevent hemolysis in incompatible transfusion, which can be given at a dosage of hydrocortisone 100 milligram before transfusion, and then 24 hours later 1.2 to 2 grams per kg over 2 to 3 days. So coming to the prevention, so managing hemolytic transfusion reaction requires a cohesive and interprofessional healthcare team to provide patient-centered care. Physicians, nurses, pharmacists, lab staff, and transfusion specialists play a pivotal roles in this collaborative approach. Blood products often require at least 2 different staff members to verify patient and transfusion product to prevent administrative errors. And these 2 different staff members should not only be for verification of the blood product, but also when they're collecting the samples, they should be properly labeled and signed by 2 nursing staff, and both the nursing staff, one should be junior as well as one should be senior, to prevent any wrong blood in tube. proper typing of a donor units, pre-transfusion testing, antibody identification, and cross-matching are critical elements. Delayed hemolytic transfusion reactions that present without detectable antibodies, testing should be repeated 3 months after the event to capture any new developing antibodies and establish the appropriate further future transfusion strategy for each patient. Provision of extended match units, at least for RH and KL antigen, should be provided. Robust hemovigilance system is essential to document hemolytic transfusion reactions, dissect the underlying causes, and implement the appropriate corrective and preventive actions at a system-wide level. National hemovigilance surveillance systems, often coupled with open, periodic data sharing, often have proven invaluable for the global transfusion community and its quest for continuous quality improvement and maximum patient safety. Informed consent for transfusion should include a discussion of the risk of infectious diseases and serious non-infectious complications, mainly of tachycardia hemolytic transfusion reactions. Furthermore, medical staff administering blood components should be well aware of the signs and symptoms of possible reactions. Staff should be prepared to mitigate any immediate episodes through appropriate procedures as well as to prevent future similar reactions whenever possible. So in the end, to summarize, although the incidence of hemolytic transfusion reactions have significantly reduced during the last decade, the prevention of these adverse transfusion reactions continue to be a major focus in the transfusion medicine. Establishment of robust hemovigilance programs and systemic protocols to identify and investigate all suspected hemolytic transfusion reactions remain as central practices. Advances in the understanding of the pathophysiology of hemolytic transfusion reactions continue to provide insights and help guide the management of patients undergoing these reactions. Thank you. So it's always better to prepare and prevent rather than don't repair and repair. Thank you so much.
Yeah, thank you, Abhinav, for a wonderful, overview on the hemolytic transfusion reaction. But I have one thing. I would have loved that the Manipal hospital should have taken the opportunity of involving the clinicians here today, because this was primarily for the clinicians to see, because the transfusion medicine people are aware about it. But primarily, this is very important for the clinicians working in the transfusion, that they should have been involved so that they could have taken back home that how the problem can be, because hospital administrators are here, Dr. Richa and others, because this is what we want to see, that their involvement in preparing such programs. Well, I don't have much to add because you have covered the topic so well.
Thank you, sir.
Well, thank you very much. Thank you.
So we can keep the questions later on. So a very good morning to all of you. And I'll take this opportunity to thank Dr. Rashmi and Team Manipal for organizing a very well, this event. The moment I entered, I felt, no, it's really done very well. And no, it's Kshitij, I thought. No. I'd like to call upon the second speaker of the day, Dr. Anubhav Gupta, and he's an... Kshitij? I thought you were standing, so I called you. So I'd like to call upon Kshitij, and she'll be taking forward again the transfusion reactions, and now she'll be talking upon the non-febrile hemolytic transfusion reactions. And she's an assistant professor from Government Medical College and Hospital, Chandigarh, and has been awarded with Harold Gunson Fellowship and with J.R. Jolly Award. She has multiple publications. She's a member of editorial board of Asian Journal of Transfusion Sciences and an assistant editor of third edition of Transfusion Medicine Technical Manual. And over to you, Kshitij, for your presentation.
So, thank you, ma'am, for the kind introduction. So first of all, I would like to thank the organizers for giving me this opportunity to speak on a very important topic of febrile non-hemolytic and allergic transfusion reactions. So as sir has already specified in his previous presentation, that these are the two most commonly reported transfusion reactions to the blood centers. So these will be the the content of my slides will be definition, the incidence, pathophysiology of these reactions, signs and symptoms, how we can diagnose and treat. And how can we diagnose these reactions, and what are the various treatment and what are the various preventive strategies. So first of all, it is the febrile non-hemolytic transfusion reaction. So febrile non-hemolytic transfusion reaction, it is the most frequently reported acute transfusion reaction. So it can manifest as fever and or chills, and it is, as specified in the name, it is without hemolysis. So coming on to the definition of febrile non-hemolytic transfusion reaction, so it is defined as presence of one or more of the following, that is fever, which is defined as temperature of more than or equal to 38 degrees Celsius or 100.4 degree Fahrenheit oral or equivalent, and a change of more than or equal to 1 degree Celsius from the pre-transfusion value, and or chills and rigors. So these FNHTRs, they usually occur during or within 4 hours following transfusion, and there is no without any other evident cause, such as acute hemolytic transfusion reaction, transfusion transmitted bacterial infection, or patient's underlying condition. So now what is the rationale behind this 1 degree Celsius rise in temperature? Is that it avoids undue concern over smaller fluctuations in body temperature which are unrelated to transfusion, and which further do not justify the discontinuation of transfusion and follow-up of investigation. So coming on to the classification. So classification, so it is classified as mild when the temperature is more than or equal to 38 degrees Celsius and a rise is between 1 to 2 degrees Celsius from pre-transfusion value, and it is without any other signs and symptoms. So moderate is when the temperature is more than or equal to 39 degrees Celsius and a rise is more than 2 degrees Celsius. So with other symptoms such as myalgias or nausea and which precipitate stopping the transfusion. So in addition to severe is, in addition to the above symptoms, when the signs and symptoms, they precipitate stopping the transfusion, prompt medical review, and or directly result in or prolongation of the hospital stay. So for international comparison, only more serious cases of FNHTRs, they are accounted. So FNHTR, it is the most common acute transfusion reaction. So the incidence, it is as reported, it varies from 3.5 to 4.2 per 10,000 blood products transfused. So coming on to the causes, so it is a part of systemic inflammatory response syndrome. It has mainly 2 causes, immune as well as non-immune cause. So an immune cause, it is the infusion of leukocytes that generate pyrogenic cytokines in vivo, which is precipitated by anti-leukocyte antibodies in recipient. So these anti-leukocyte antibodies, they bind to the leukocytes and result in the generation of pyrogenic cytokines. Whereas in non-immune cause, it is the infusion of pyrogenic cytokines or inflammatory response mediators like activated complement proteins or lipopolysaccharides, which have accumulated during storage of cellular components. So following this increase in circulating pyrogenic cytokines, which are interleukin 1 beta, 6, and TNF alpha, they result in the production of PGE2, which further upregulate the thermostatic set point on hypothalamus, resulting in fever. So now this can be what are the various risk factors for FNHTR? So they can be classified as based on patient characteristics, donor characteristics, or the component characteristics. So in donor characteristics, it is the presence of antibodies which are less frequent. So in FNHTR, based on patient characteristics, FNHTR is more frequent in multi-transfused or multiparous females, elderly with pre-existing pro-inflammatory condition, or recipients with genetic predisposition. So coming on to the component characteristics. So first of all, in component characteristics, it is whether the component is cellular or non-cellular. So it is almost always associated with transfusion of cellular components such as platelets and RBCs. Then among cellular components, the incidence is higher for platelets than for RBCs. So among platelets, it is the highest with the platelet concentrates which are prepared by the platelet-rich plasma method, followed by Buffy-coat reduced platelets, and least with apheresis platelets, because this platelets concentrates prepared by this PRP method have the highest number of leukocytes, followed by a Buffy-coat reduced, as the least with the apheresis platelets, which are leuko-reduced and have leukocyte count less than 10⁻⁶ cells per product. So coming on to the duration of the storage, so it is higher with the longer storage time platelets, that is which are more than or equal to 3 days old. And then next, the last is whether that component is leuko-reduced or not. So it is, so FNHTR is higher, incidence is higher with non-leuko-reduced or bedside leuko-reduced platelets as compared to pre-storage leuko-reduced platelets. So now coming on to the difference in the mechanism of FNHTR reported following RBCs or platelets. So the most common mechanism implicated in FNHTR following RBCs is the leukocyte antibody in patient's plasma. Because these RBCs, they are stored at cold temperature, so this has an inhibitory effect on cellular metabolism. So therefore, the cytokine accumulation is too low to mediate significant reactions. Whereas for platelets, it is the passive transfer of pyrogenic cytokines or biological response modifiers, which is the main mechanism implicated in FNHTRs. Why? Because platelets being stored at room temperature and agitation, it activates the leukocytes and platelets to release cytokines. Now coming on to the clinical considerations, so these FNHTRs, they're usually benign without any sequelae. Why it is of concern? Because the initial presentation is similar to more adverse reactions such as acute hemolytic transfusion reaction, and they can aggravate pre-existing cardiac, pulmonary and cerebrovascular insufficiency, as 1 degree Celsius increase in temperature leads to 13% increase in oxygen demand and consumption, and shivering can also lead to 300% increase in oxygen demand. So FNHTR is always a diagnosis of exclusion, so we need to exclude other causes such as acute hemolytic transfusion reaction, transfusion-transmitted bacterial infection, patient's underlying condition or drug history before labeling the reaction as FNHTR. So coming on to the treatment, we need to stop the transfusion immediately, IV line to be kept open, the patient should be administered with antipyretic agents. Aspirin and non-steroidal anti-inflammatory drugs, they are contraindicated in recipients receiving platelets. And antihistaminics, they are not indicated unless the patient has signs of an allergic reaction. So coming on to the prevention, so patients with history of FNHTR, they are at 15% risk of recurrence of reactions. So therefore, prevention should be considered only if patient had more than 2 episodes of FNHTR. So why prevention should be considered is because that though it is self-limiting and benign, but FNHTR can precipitate cardiopulmonary complications in elderly and previously compromised patients. So now what are the various preventive strategies? It includes pre-medication, slowing rate of infusion, removal of supernatant plasma from platelets, fresh platelet concentrates, or leukocyte reduction. So coming on to the first preventive strategy, pre-medication, it should be only used for patients with a history of FNHTR and has to be used with caution, as antipyretics, they could mask fever due to more serious reasons. And steroids, they should never be used for prevention, as they can slow the onset of any hemolytic reaction, as well as they can also expose the patients to undesirable side effects. So slowing the rate of infusion, it avoids a sudden bolus of toxins or cytokines, so it can be used as a preventive strategy. So removal of supernatant plasma from platelet concentrates, it also lowers FNHDR rate by decreasing cytokine levels. However, this requires an additional centrifugation step and rest period. So fresh platelet concentrates less than 3 days old, they are also associated with less incidence of FNHDR. So coming on to the leukocyte reduction, so it can be either pre-storage or post-storage. So pre-storage leukoreduction, it is effective in preventing antibody-mediated reactions. So reactions from cytokines released from leukocytes during storage. However, it is not effective in removing reactions which result from platelet-derived mediators. So therefore, it is more effective for platelets, as we've already said that cytokine production, it continues at room temperature. Coming on to the post-storage leukoreduction. So post-storage leukoreduction, it is effective only in preventing antibody-mediated reactions. So it is not effective in preventing reactions by both leukocyte as well as platelet-derived cytokines which have been accumulated during storage. So it suffices for RBC transfusions. So this is a publication where the authors, they observed that there was a significant decrease in the frequency of post-transfusion FNHDR, but not allergic transfusion reaction for RBCs and platelet concentrates when they introduced 100% universal pre-storage leukoreduction. So coming on to the allergic transfusion reaction, so it is an immediate type 1 hypersensitivity response, which consists of transient localized or generalized urticaria, erythema, and pruritus. So it is an acute immune complication of transfusion. It occurs following transfusion of plasma-containing blood components. Atopic individuals, that is those with known other allergies, they are at greater risk of allergic reactions, and allergic and anaphylactic reactions, they are a part of a continuum. So an allergic reaction, it is defined as it may be present only with mucocutaneous signs and symptoms such as morbillium rash, with pruritus, urticaria, localized edema, edema of lips, tongue and uvula, periorbital pruritus, erythema and edema, conjunctival edema. It also occurs during or within 4 hours of transfusion. So coming on to the classification, allergic reaction is classified as mild when it is transient flushing, urticaria or rash. Then it is moderate with wheeze or angioedema with or without flushing and urticaria, but it is without respiratory compromise or hypotension. Then coming on to the severe, it is with your respiratory compromise, that is bronchospasm, stridor, angioedema or circulatory problem, so which requires urgent medical intervention or results in prolongation of the hospital stay. And anaphylaxis is a severe life-threatening generalized hypersensitivity reaction, so with rapidly developing airway or breathing compromise and circulatory problems, and it is associated with skin and mucosal changes. So it is the allergic transfusion reactions, they are the most common adverse reactions. The incidence range from 1 to 4%. So their incidence, it correlates with the amount of plasma proteins and blood components. So therefore, it is more common with plasma and platelet transfusions. So coming on to the pathophysiology, it can be allergen dependent or allergen independent. So in allergen, it can be IgE or non-IgE dependent. So whereas in allergen independent, these are dependent on the biological response modifiers. So the various allergens can be either the normal endogenous plasma proteins, for example, immunoglobulin A, haptoglobin, and complement. So severe allergic reactions, they have been reported, we know, in IgA deficient and haptoglobin deficient patients. So exogenous compounds in donor plasma, such as chemical allergens and food allergens, they can also act as allergens. Now coming on to the pathophysiology, so on exposure to allergen, so the allergen is engulfed by the antigen presenting cell, that is your dendritic cell. It is presented to the T helper cells. So T helper cells, they get activated and they activate the B cells, and there is a class switching, IgE class switching in B cells, resulting in the production of IgE. So now this IgE, then it binds to the Fc epsilon receptors on mast cells. So when there is a repeat exposure, so there is cross-linking of these, binding and cross-linking, resulting in the activation of the mast cells and the release of various mediators. So in IgG-dependent pathway, it is the IgG, it binds to the low affinity IgG receptor, that is Fc gamma R3, but significance of this in humans is not well established. So coming on to the allergen-independent pathway, so they are biological response modifiers, that is the inflammatory cytokines and chemokines, for example, CD40 ligand, platelet factor 4, they can accumulate in blood components during storage, so they can recruit and activate basophils and stimulate histamine release. So this diagram shows, in the top you can see the allergen-dependent pathway, can be the IgG or IgE, and down they have shown the allergen-independent pathway, that is the biological response modifiers. So they activate either the mast cells and basophils, resulting in the release of the vasoactive amines. So now the risk factors for allergic reaction, it is the atopic predisposition of recipients. So 6-fold higher median IgE has been reported in subjects who experience allergic transfusion reactions as compared to controls. So this is a publication where the authors, they observed that the allergic predisposition of the transfusion reactions of the transfusion recipients was associated more strongly with allergic transfusion risks, whereas the infusion rate, that is the transfusion component specific attributes such as infusion rate, volume, component age, pre-medication, it showed no significant association with allergic transfusion reaction risk. So coming on to the diagnosis, so it is very important to rule out urticarial drug reactions. So therefore, careful attention should be given to the timing of onset of urticaria relative to transfusion. And how can we differentiate anaphylactic from acute, hemolytic and septic is by the cutaneous signs and symptoms and rapid onset. So now these are the various lab tests which can be done. For example, tryptase test, which is a marker of mast cell granulation, basophil activation test, or the selective deficiencies test for IgA and haptoglobin deficiency, they can be performed. So coming on to the treatment, so first is we need to stop the transfusion immediately. Antihistamines, they should be given. So if anaphylaxis, it is a medical emergency and supportive management to be provided to these patients. Now coming on to the strategies to prevent allergic transfusion reactions. So first of all, it is the application of evidence-based transfusion thresholds. Then is pre-medication antihistamines, and steroids should never be given as a pre-medication. So plasma reduction, which can be saline washing or volume reduction. Use of platelets suspended in platelet additive solution. So use of components from allergen deficient donors, for example, IgA deficient donors in case of cellular component transfusions, and in case of plasma transfusions, it can be use of solvent detergent treated plasma. And last is desensitization. So first is saline washing. So it is performed on cellular blood components, that is your RBCs and platelets. It removes cell-free fluid and associated plasma proteins. So it is performed in IgA or haptoglobin deficient recipients to prevent severe allergic transfusion reactions and anaphylactic reactions. And for IgA deficient patients, the IgA levels, they need to be reduced to less than 0.05 milligram per deciliter. So washing it significantly decreases the incidence of allergic transfusion reactions for platelets. So the incidence was found to decrease from 5.5% to 0.7%, and for RBCs from 2.7% to 0.3%. So then is the volume reduction. It refers to the removal of excess cell-free fluid via centrifugation for patients at risk of repeat severe allergic transfusion reactions. So this is usually utilized for platelets. So this may cause platelet activation, decrease in platelet function. So post-volume reduction cell recoveries, they have been reported to range from 79 to 95% with variable impacts on corrected count increments. So volume reduction has been found to significantly reduce the incidence of allergic transfusion reactions from 5 to 1.7%. So coming into the use of platelet additive solutions, so these are the balanced electrolyte solutions which are used to suspend platelets and decrease the quantity of residual donor plasma. So significant decrease in allergic transfusion reactions have been observed with the use of past suspended platelets. Although CCI at 1 hour has been found to be lower in past suspended platelets, but their hemostatic efficacy was not found to be altered. So this is a key recommendation from a short 2020 report. So over there, they have suggested to use pooled platelets suspended in PAS associated with reduction in allergic response. And if available pooled platelets, if still the reactions continue despite antihistamine cover, then platelets resuspended in 100% PAS can be supplied. So now in this, so there was one, this is a case report. In a case where the authors, they successfully desensitized the patient to IgA. So that was an IgA deficient patient with anti-IgA. So they used continuous infusion of IgA-enriched immunoglobulin preparation with gradual increase in concentration. A state of unresponsiveness was achieved as no anti-IgA antibodies were detected either immediately or 1 month after desensitization. And patient received standard components with no complication. So the mechanism was that IgG, it binds and cross-links inhibitory receptors, that is your Fc gamma R2b, to activating receptors, Fc epsilon receptors on target cells, thus controlling basophil or mast cell degranulation, and anti-IgA was neutralized by immunoglobulin A. So just to summarize, this is the key recommendations from SHORT 2023, that one treatment does not fit for all the reactions. For febrile, it is your paracetamol, and for allergic, antihistamine and steroids, this should not be used routinely. If it is anaphylaxis, adrenaline is essential. And for prevention, for allergic, if there is a previous reaction with apheresis platelets, then try pooled platelets suspended in PAS. If still the reactions continue, give pre-transfusion histamine. If still continue, we can consider washed platelets or red cells, and for FFP, try a pooled component, for example, solvent, detergent, treated plasma. So thus, by being more prepared, proactive, and being smart, we can reduce the risk of these commonly reported reactions. Thank you.
Thank you, Kshitija, for such a lucid presentation on this topic, because both FNHTR and allergic reactions are just taken for granted.
Yes,
सबसे ज़्यादा होता है. It is
but
the
these are the
highest.
most, yes, frequent.
And we hardly even look at it because ये तो होता है, isn't it? And the simplest method of avoiding is leukoreduction. And I hope every one of us are doing the leukoreduction, because सबसे means the best way to prevent is that. And what I see even in the practice, not at least in my hospital but others, there's a bedside leukoreduction, which I feel, how useless is that? आप एक means you are trying to even give means you are trying to use something which at that moment is not useful as well. So we should all know that the bedside leukoreductions do not play any role. Thalassemics को हम लोग देख रहे हैं, they are saying हम तो bedside leukoreduction करते हैं. What for? The cytokines are already released into the system, and they will not do anything except adding to the cost of the patient. Nothing else. So as blood bankers, we need to teach every one of our clinicians that at least that concept. That's the highest FNH means the highest transfusion reaction, FNHTR, can be prevented by a simple leukoreduction, which has to be done in the blood bank itself.
And it's very important that only we can prevent FNHTR, not allergic. So which is where the clinicians, they can
And allergic also is being taken for granted. In my times when I was a JR with gynae, so when we used to have these allergic reactions, we used to give a pre-medication. The pre-medications were done at that time. Nowadays, we don't do that. Yes. And that's a very good practice that we have stopped giving the pre-medications before the transfusion, because it happens, but it only delays. So at least it happens in front of us at that time. That is much better. And anything and everything, I always teach to my ward staff also, anything and everything which is happening to a patient, which was not happening prior to a transfusion, is a transfusion reaction. So don't put your heads into it, kya hai, because they don't understand anything. It's only we that we will put it. So that's what it should be, put it that way. And thank you so much for presenting it very well. Thank you so much.
Okay.
Lead it. That's what she said that.
Dr. Mittal, well, I have...
Yeah. Patient and for the blood bank also, that the patient died because of anaphylaxis.
An excellent lecture. Well, I'd like to know what is the percentage of the red blood cell, blood you are subjecting to leukoreduction in your hospital?
So basically, we are only providing the thalassemics with leukoreduced blood.
Now, what about basically the thing is, you are thalassemic. So when thalassemia comes, so how you know, for example, you have an O-negative thalassemic, he lands in your hospital and he comes to transfusion. So what you do at that time?
So we have already we have enrolled around 200 thalassemics. They are enrolled with us. So we get a list. So one week prior, we get a list of this.
No. Basic reason why I'm asking this thing, because we are here primarily transfusion medicine people. Why we are not advocating universal leukoreduction back home in our place? Because you, the people, those which are coming from the premier institutions like the medical college or from the AIMS or from the corporate hospitals, and we are teaching others. And if we don't do ourselves, we have no right to preach. So I will only tell, because when you people come, for another thing, what I would have loved to see that you told about the short study. I think you should have gone for the hemovigilance program, and you should have told us what is the prevalence over there. So when we talk about this thing, the basic idea of these CME programs is the carry home message is that we have to do, well, in case everybody tells me, well, because once I entered this hall in the morning, we don't have money. Well, you have, your institution is a premier institution. And I think you get back and tell to Dr. Kaur that we need to implement it, and you ask for it, because nobody is going to provide you unless you ask. Because you will tell, no, we don't need it, we need only for the multiple transfusion patients. So this is a carry-home message.
Buffy coat removals should be done for the entire products that you're giving out to the patients.
So this was also a big task to shift from Buffy coat from normal PRBCs to Buffy coat reduced and then to this pre-storage leukoreduced.
No, you yell, go for the, why don't you can do both the things together. You.
No, that isn't.
Yes. I think I.
For doing something good.
Yes, please.
So that is what we every time hear ki.
Hello.
It's a government setting and the numbers are huge. I don't agree to that.
No, ma'am, it is not about the numbers, ma'am. Basically, itni literature available hai. I will just quote one paper in which the role of leukoreduction, what Dr. Makru sir was saying is I think Dr. Sharma paper it is, ki the role or indication of leukofiltration is when in FNSTR, when it is recurrent and severe. And there are multiple papers which says that if you are having a single episode of FNSTI, you are not going to just leukoreduce it. So I wonder ki there are multiple literatures. So sir, any comment on this, sir?
So basically,
yes, very good question. Well, Dr. Bino, the thing is, one patient, consider it is me, who have been transfused and I get this rejection. It is not that it is always the multiple transfused patient they get it. There is a possibility that somebody can react. Or it is also possible because tomorrow, this particular patient, whom you have transfused this blood, well, he goes for the transplant. Well, he produces HLA antibodies. And well, he has a true donor available, but we don't find him. You are not in a position to do the transplant if there are already HLA antibodies. Because primarily we have to take care of the patient because the basic idea.
Sir, this is the only question, sir. When if we are doing the universal selective, we should opt for the universal leukoreduction or a selective leukoreduction. For example, if you are in a trauma hospital, sir, which is a 300 or 500 bed hospital, what is the role of leukoreduction in that group of patients?
Basically,
it should be catered to the patients who are multi-transfused like thalassemics. It should be for the transplant patients,
and it should be for the, actually it falls with the multi-transfuse patients only, sir.
See the idea, why we are trying to stimulate people. Because unless we ask for the things, because we, the transfusion medicine people, keep on telling that why we are not improving the transfusion services. Primarily because unless we speak about the universal leukoreduction, the things will not come in your way. The thing is, unless we keep on hitting the nail on the top, again and again, the things will not improve and the transfusion service of the country will not improve.
Secondly, the inventory of leukoreduced and non-leukoreduced is also so difficult to maintain.
So it's very difficult.
And when a leukoreduced person needs leukoreduced blood, you don't have it. So what's the point of maintaining two inventories? And when you know that a leukoreduced blood is always better than a non-leukoreduced. So having a debate on this, I feel is even, we should have it.
Well, Dr.
We should.
Dr. Ketubal.
Adding to the debate of leukoreduction, universal or selective, at our hospital, I'm from Artemis Hospital, Gurugram, which has got the bone marrow transplant center, and all kinds of transplants are happening there, in addition to other kinds of cases. So we can't have different inventories. We are following universal leukodepletion at our center because we are using inline filter bags for red cells. But when it comes to platelets, we can't leave it at 1 log leukoreduction because we are making platelets using the Buffy-Coat method, which is just 1 log reduced. So if we are giving 4 log leukoreduced red cells to the BMT patient and 1 log leukoreduced platelets to the same BMT patient, we can't justify. So we are using platelet filter also to make it 4 log leukoreduced platelets, 100%. And we can't have different inventories. For this patient, 1 log will be okay. For other patient, 2 log will be okay, or 4 log will be okay. So it has to be one inventory which serves the purpose, easy to maintain, and 4 log leukoreduction is always better, be it for platelets or for red cells, and for any kind of patient.
Thank you. And let me tell you, well, I introduced leukoreduction 1 log in 97 and 2097, and I introduced 3 log leukoreduction in 2007. And so I feel there's a long, almost now 2 decades, but still we're talking on the debate, universal non-leukoreduction.
And only one submission,
But still, sir,
one more
we have
submission.
moved to selective leukoreduction.
No, wait, I have one more submission to my people who are from the government sector. And the government sector, what I see, when I ask for equipments, suppose I ask for an Optia नहीं है उनके पास, क्योंकि 6 Optia रखी हैं एम्स के अंदर, पर मेरे पास देने के लिए Optia नहीं है उनके पास, है ना? So please divert your funds properly. आप buy करते हैं उन equipments को और उनको खड़े रखते हैं. So you have to divert your funds properly and don't say हमारे पास पैसे नहीं हैं leukoreduction के. आपका vision होना चाहिए how to use that fund. 7 equipments रख के और उन्हें use नहीं करोगे और leukoreduction नहीं करोगे. So please do that. That's my submission to each of you who are from the government sector. We at the corporates are hardbound on many things, but still हम manage करते हैं उसको. But thank you so much, Kshitija.
It is not a debate between the government and the private. It is primarily we have to improve the time. We want to see that.
I'm trying to. This is my experience, huh? जो मैं अभी बहुत experience कर रही हूँ इन दिनों. So I'm just trying to tell my friends who are from the government sector to use that funds properly.
Thank you.
इधर बहुत debate हो गया.
वो देखा आपने अपना hemovigilance program में कितनी?
Sir, I have mentioned there.
Okay. So anyway,
I think we should go to the next speaker.
And the next speaker, I think.
Thank you.
And Dr. Anubhav, well, he is an associate professor at the All India Institute of Medical Sciences, Jodhpur, Rajasthan. He has done his MD Transfusion Medicine from PGI Chandigarh. He is an author of multiple original articles and multiple case reports in the peer-reviewed international and national journals, and co-coordinator IIT Delhi lead consortium of setting up the Center of Excellence in Artificial Intelligence. Well, it is a debatable topic these days, And it is not only in India, also in these days today, this, I was seeing in the morning newspaper, even in the United States, the two presidents are fighting on artificial intelligence. The recipient of the Harold Johnson Fellowship, International Society of Blood Transfusion, 2021, principal investigator for the multiple funded projects at the AIM Jodhpur, active member of the international and national societies in transfusion medicine, and he is key contributor to process improvement, including CPOE implementation at the AIM Jodhpur, Apherisis, innovative approaches in clinical transfusion, and embedded artificial intelligence in transfusion medicine. I present you, Dr. Abhinav, please.
Thank you so much, sir. And thank you, organizer, for giving us the opportunity to present our work and sharing our knowledge on this platform. So, coming to the topic, basically, adverse transfusion reactions are not always mild. They are capable of killing a patient. They have the capacity, basically. So, like in FNSTR, which we have just discussed, for every degree rise in temperature, the oxygen consumption can increase from 100 to 300 folds. So imagining a patient who develops a sudden onset of breath and hypoxemia shortly after taking a blood transfusion can lead to, the patient can be collapsed. The results may be multifactorial, but we should know the rationale behind these adverse transfusion reactions. So adverse transfusion reaction can be defined as the transfusion reaction which has the undesirable response or undesirable effect. So undesirable response means it should have the acute reaction should be directly related with the transfusion. That is, the imputability should be very high or should be certain. By undesirable effect in a patient means that the complication that occurs as a result of the transfusion has a imputability of possible or probable. But in all these, there should be a temporal relationship and with the administration of the blood and blood components. So are these pulmonary complications so serious? Yes, definitely. The pulmonary complications of transfusion remains a leading cause of transfusion-related mortality and morbidity. They contribute up to 50 or more as per the SHORTS 2023 report, which has just displayed. So the transfusion reactions which has pulmonary symptoms. So basically there are many symptoms, there are many signs which overlap with different kinds of adverse transfusion reactions. The circulatory overload, which occurs in about 1 in 700 of the transfusion recipients, have the higher risk in older patients, though with a severe anemia, renal failure, and underlying cardiac disease. The symptoms may include from the dyspnea, tachycardia, and to the tachypnea. And the bacterial contamination may be the problematic in patients due to the room temperature storage, which can cause the sepsis, ARDS, and death. Hemolytic reactions like the intravascular hemolysis may be due to the antibody-antigen reactions and can cause dyspnea and is likely to be due to the complement activation. Emboli, air emboli. Previously in the era of bottles, the air can rapidly travel to the pulmonary artery and can cause cyanosis, hypotension, tachycardia, and respiratory failure. The risk is markedly reduced by shifting to the platelet containers, but not yet has been eliminated. Particulate matters. The aggregates of leukocytes, platelets, and fibrin can cause from the different storage, but thankfully to the modern leukocyte reduction, which prevents the particle formation. However, massive transfusion, that is the transfusion of units more than 10 in the first 24 hours, still remains a higher risk for the ARDS. Allergic reactions, which range from mild urticaria to severe anaphylaxis. The antibodies to the IgE, Ig are the most common cause of anaphylaxis or anaphylactoid reactions respectively. I would like to mention for the granulocyte transfusion, in which the recipients frequently experience the shortness of breath, fever, oxygen desaturation, especially if they are alumnized. Amphotericin B, which is commonly prescribed in these kind of patients empirically, should be ideally be administered within 4 hours of transfusion, and there should be at least a gap of up to 4 to 12 hours between the granulocyte transfusion and amphotericin B, because it leads to the stasis of these neutrophils, small neutrophils in their lung alveoli. So among the immune causes, which can be because of donor or recipient antibodies, because of biolipids, because of CD40 ligands, these are all implicated in causing the TRALI. So how will you approach a patient who presents with a pulmonary transfusion reaction? So when a patient experiences a sudden or difficult breathing within the 6 hours of receiving a blood transfusion, the initial concern is whether the patient's signs aligns with the acute transfusion reaction, that's a dyspnea, which is the most important symptom which is seen with the pulmonary transfusion reaction. It is characterized by the arterial oxygen saturation to the fraction of the inspired air ratio of less than 300 or an oxygen saturation of less than 90% on the room air. If these criteria are met, the next step is to identify the evidence of bilateral pulmonary edema which is visible on the imaging, that is through the chest radiograph, chest CT or on the ultrasound. If the imaging confirms the presence of bilateral pulmonary edema, the clinical investigation shifts through for the evaluation of the possibility of fluid overload, either from the signs which the patient may have or from the laboratory markers like BNP, anti-BNP, which may be increased because of the cardiac stress. If the fluid overload is indeed present, then it is the diagnosis of TACO can be made as ascertained. This condition is particularly suspected in patients with a history of heart failure or those who have basically received the excessive fluids, especially in the case of renal impairment. However, if the investigations does not support the fluid overload, then the focus should move to considering whether these conditions should be because of and the cause of acute lung injury like Trally type 2 or acute lung injury because of shock, sepsis, etc. Trally type 2 especially is relevant in patients whose respiratory status was stable prior to the transfusion, but the symptoms has been persist. If the symptoms persist and there is no cause has been found, the Trally type 1 could be a strong consideration in these kind of patients. The Trally type 1 is more likely if the patient presents with a specific marker such as the new onset of neutropenia or the laboratory markers showing the monocytopenia. And if the transfusion involves the plasma-rich components like FFP plasma, SRAP, etc. In these cases, when there might be also a copious frothy yellow or pinkish tracheal exudate may be present, which may point to the diagnosis. In some cases, the symptoms do not fit nearly to this category. For instance, if the dyspnea occurs within the first 24 hours of the transfusion but does not align with the TACO, Trally, then a subclass may be classified, then the diagnosis may be made of the transfusion-associated dyspnea. So other possible causes which should be considered apart from Trally, TACO, TED should be should be transfusion-related reactions like bronchospasm, anaphylaxis or shock we have just discussed in our allergic and anesthesia session, or non-transfusion-related factors such as infections, pulmonary embolus or myocardial infarction. So basically, Trally is a clinical syndrome. It is not a disease, it is a clinical syndrome. There is a sudden deterioration of the lung function which is temporarily related to the blood transfusion. So there is a constellation of symptoms of dyspnea and bilateral pulmonary edema that usually develops after the cessation of the transfusion within the first 2 hours of the transfusion and should always be within the first 6 hours. The onset may rarely and very rare, and maybe because of the variancy of the Trally reporting system, it may be delayed up to 12 hours or more after transfusion. It is most significant contributor to acute lung injury, and the component which is more commonly related with the Trally are the plasma-rich components followed by the cellular components. So by definition, Trally can be categorized as type 1 and type 2. The type 1 patients have no evidence of acute lung injury prior to the transfusion and they have no risk factor for the ARDS, but should meet the following criteria which should be graded, or the criteria should be characterized as 1, A, B and C. In the A criteria, the symptom should be, it should be the acute onset. There should be the preponderance of hypoxemia, that is the arterial oxygen to the fraction of the inspired air should be less than 300. The normal values range from 300 to 500, and if it is less than 300, that is about 200 to 300, it is mild, and if it is more than fall from less than 200, it comes under moderate to severe category. The saturation of the oxygen should be less than 90% on the room air. There should be clear-cut evidence of the bilateral pulmonary edema on the imaging. There should be no evidence of the left arterial hypertension, or if it's present, it should not be the main contributor to the hypoxemia. The onset should be of the Trally type 1 or type 2 should be within the first 6 hours of the transfusion, and there should be no temporal relationship to any other alternative cause or risk factors associated for the ARDS. And for the type 2 trally, the risk factors for the ARDS may be present, the ARDS may not have been diagnosed, or the ARDS may be present as a baseline. That is, the arterial oxygen to the fraction of the inspired air can be between the 200 to 300, but the respiratory status deterioration is just to be due to the transfusion based both on the criteria A and B, just like in type 1. The major differentiation between a type 1 and type 2 lies with the that the patient is stable, that the patient has stable respiratory status in the 12 hours before the transfusion. So we have a case of 45 years old male who presented with a progressive bilateral lower extremity weakness, paresthesias over the past week. Neurological examination revealed decreased power 2/5 in the both legs, the absent tendon reflexes, AC ratio dissociation was seen, and a diagnosis of GB syndrome was made. From the clinical side, we received the request, we planned the plex. We used FFP as a replacement fluid because of the logistic issues. And within the first few minutes of starting the third plex session, the patient developed acute dyspnea, hypoxemia, SpO2 of 83% on 100% of fraction of the inspired air, fever, increase in the temperature, hypotension, BP of 85/50, chest auscultation reveals bilateral crackles. A chest X-ray was done, which shows the new bilateral or the new pulmonary infiltrates consistent with the pulmonary edema, and the central venous pressure monitoring did not indicate any fluid overload or cardiogenic edema. So a diagnosis of trally was made. So the pathophysiology of the trally may include the immune-mediated reactions of the HL antibodies in the donor with the white cells in the recipient. The leukoalgolutins or the anti-HL antibodies may be the culprit, which may activate the granulocytes, which causes the neutrophils to migration to the lungs. They causes the binding of capillary cells with the adhesion molecules, liberation of the proteolytic enzymes, and the destruction of pulmonary architecture, leading to the capillary leak syndrome, ultimately leading to the pulmonary edema. So, lung injury following the transfusion can be because of, I will just discuss this in brief, because this will ultimately take the whole time. It can be because of the neutrophils in the lung injury, the role of neutrophils, the leukocytes, the bilipids, the CD40 ligands. So basically, in nutshell or in brief, the neutrophils activation and subsequent release of the toxic agents like reactive oxygen species are the central to the pathogenesis. Neutrophils can be activated directly or indirectly. The direct activation is because of the binding of the HNA or HLA class 1 molecules, which are just transfused, which are present in the transfused bloods and just attack the neutrophils. Indirect activation is thought to be the class 2 molecules, which are just implicated. Class 1 molecules or antibodies can bound to the lung endothelium, recruit and activate the neutrophils via Fc receptors. And there may be a role of complement C5a, which causes monocytopenia, neutropenia, interstitial edema, and hypoxemia. And this classical case of complement activation may be seen in dialysis patients who frequently presents with the monocytopenia, neutrocytopenia because of the activation of C5a. But in some cases of the trally, the transfusion of bilipids like phosphatidylcholine that accumulate during the red cells and platelet storage prime the neutrophils and enhancing their production of reactive oxygen species, which causes the damage to the pulmonary endothelial cells. CD40 ligand, again, which are released by the platelet increases during the storage. They causes the lung injury, and blocking of this interaction prevents some kind of lung injury. This is to especially mention that apart from the neutrophils and leukocyte antibodies, bilipids and the CD40 ligands are not so potent that they directly interact with the neutrophils. They need the mediators to get into or to get the chemo, to have the to initiate the property of neutrophils to sit down in the alveolus and cause the symptoms. So the clinical presentation of TRALI can range with the onset to the recovery. The onset can be typically within the 30 minutes of the transfusion, and it can range from 1 to 2 hours. The recovery may start as soon as the 6 hours of the symptom, but in some certain patients, the deterioration may continue for up to 24 hours or beyond. Very specific symptoms of TRALI may include the chest tightness, shortness of breath, the dry cough, and some variant or non-specific symptoms may be nausea, dizziness, even TRALI may present as just rigors and fever. On examination, the patient may have hypoxia, hypotension, tachypnea, and tachycardia. But hypotension may again be a symptom of TRALI if the patient has been on some drips or has been on normal saline or has been on crystalloids or colloids. So on auscultation, there may be the widespread crepitations on the chest auscultation, and on mechanically ventilated patients, a patient may complain of the copious frothy tracheal exudate, the resembling the white egg whites. So arterial blood gases shows the separ hypoxia, may show the hypercapnia. The chest radiograph may show the bilateral infiltrates in a bat wing pattern, which may be because of the patchy or nodular shadowing. They may be the patchy or nodular shadowing, which particularly in the peripheral fields. There are typically the sparing of Apheresis and the CP angles, the costophrenic angles. And the bronchograms may show just a whitish lung, or there may be a complete whitish lung fields if the disease progress. So talking about the laboratory test, there may be changes in the circulatory leukocytes. So 2 laboratory tests are particularly very interesting: the degree of neutropenia and the monocytopenia. If we club together the degree of leukocytopenia, so leukopenia may be observed within the first hour of the transfusion or before the clinical signs or lung injury, which favors the transfusion over the other causes of ALI. Patient may have neutropenia, which is likely because of the neutrophil-specific antibodies like HNA2, because of neutrophil agglutinating antibodies like HNA3A, etc. Monocytopenia alone is most likely to be seen in class 2 antibodies. Apart from these cells, there may be an increase or decrease of BNP or anti-pro-BNP and edema to cell protein ratio. So serum BNP less than 250 picogram per ml is consistent with the LI rather than the cardiac failure. But a low BNP is neither specific nor sensitive, as many patients with LI may have. Ma'am. Ma'am? Okay. Okay. So a low BNP is neither specific nor sensitive, as many patients with ALI are also have cardiac dysfunction. Protein concentration in pulmonary edema to the serum protein ratio can be greater than 70%, which favors a strong possibility of capillary leak syndrome. So management of TRALI includes the mainstay of the treatment includes the supplementary oxygen, the CPAP, and mechanical ventilation. Fluid replacement should be considered only if their features of hypervolemia are present. They should not be the fluid should not be given as empirical therapy. The severe cases may require the central venous pressure monitoring or left arterial or hypertension monitoring. Additional strategies may include the higher frequency of ventilation, and patients should be kept in the prone positions. Diuretics are contraindicated and are basically of a very limited value, and there are no concrete evidence as present to the use of corticosteroids in TRALI basically. So same case is the plasmapheresis, which are utilized to remove the causative agent, but no evidence is present till date. So ECMO can be used in intractable cases, and if the patient needs any further transfusions, and if it is clinically warranted, then plasma-rich products from the plasma donor, female donors should always be avoided. So this was the study which was done by my junior as a part of thesis in PJ Chandigarh. In which the author basically compared saw the prevalence of anti-HLA antibodies in Paris female blood donors. So the author reported on a gender-based comparison that about 20% of the donors, male donors, as compared to the 50% of female donors were tested positive for the HLA antibodies. And the author concluded that the Paris donors that the donations or the plasma from the Paris donors have a higher risk of chances and containing of anti-HLA antibodies as compared to the male and nulli Paris females. Now coming to the TACO. So the TACO is defined as the acute TACO is defined as the acute or worsening of the respiratory compromise with or without the acute or worsening of the pulmonary edema which occurring during or within the 12 hours of the transfusion, with additional features including the cardiovascular system changes which cannot be explained by the patient's underlying medical condition. There can be the fluid markers like NT-BNP or pro-BNP which can be done, which can be added to define the TACO. The risk factors may include the small patient, the elderly patient, the impaired cardiac function, the renal failure patients, the obstetric cases which are often missed maybe because of the increase in the blood volume in the pregnancy or the cardiac effects directly related to the preeclampsia. The severe chronic anemia can also lead to TACO, especially if worth mention to the vitamin B12 deficiency or the hypoalbuminemia. Excessive rapid transfusion of greater than 5 ml per minute to a transfusion to a low body weight patient may also precipitate TACO. Pre-existing fluid overload which can, if overlooked, can again precipitate TACO. So TACO is basically characterized by the following. Patient may complain of acute respiratory distress, tachycardia, increased blood pressure, or acute or worsening of the pulmonary edema on frontal chest X-ray, and the evidence of positive pressure. So this is again a case study from a 25 years of female antenatal patient weighing 52 kg with a hemoglobin of 4.8 gram per deciliter. So patient was diagnosed case of acute fatty liver of pregnancy which was complicated by the preeclampsia and precipitated and presented with the anemia, sepsis and peripheral edema. Patient was on diuretic as advised by the clinician to manage peripheral edema. Clinicians requested for 2 units of red cells, but the patient was not actively bleeding. The first unit of the red cells was transfused with a complaint of mild dizziness after completion of the transfusion in 2.5 hours, which goes unreported. Second unit was started 4 hours later without a clinical review, and during the transfusion the patient complained of ghabrahat type of symptom during the initial 15 minutes and becomes acutely unwell in the first hour, and an emergency team was called out. Patient developed the dyspnea, tachypnea, oxygen saturation dipped to 90% from the normal level. There was tachycardia, systolic hypertension. Patient has post-transfusion X-ray which shows the significant pulmonary edema. Anti-pro-BNP was done which was raised, but though no pre-transfusion value was available. Cardiologist was called up and an echocardiogram was done, and which shows a moderate left ventricular systolic dysfunction which has not been reported previously. So though the multiple doses of furosemide, which is a diuretic, was given, which resulted in some diuresis, not all, but the respiratory symptoms remains unchanged and the patient ultimately died. So basically this case depicts that there is a death of not only one patient, there was a death of a maternal and perinatal mortality. So for the sake of surveillance, the TACO can be defined as a should exhibit at least one required criteria and the onset within the 12 hours after transfusion, and there should be at least 3 or more criteria from A and B. So from the required criteria, it includes the acute or worsening respiratory compromise or the evidence of acute or worsening edema based on either the clinical examination or on the imaging. Additional criteria includes the evidence of cardiovascular system changes which cannot be explained by underlying medical conditions, and the evidence of fluid monitoring which are including a positive fluid balance or a clinical improvement following the diuresis, and supportive results of the relevant biomarkers, that is the increase in BNP or anti-pro-BNP, or an increase from the 1.5 times from the pre-transfusion value. So the differential diagnosis involves that the TACO frequently is confused with the TRALI, but the main differentiating feature is the hypertension in case of TACO, because the hypertension ensures in case of TRALI. But this is not always the rule of thumb. the TACO and TRELI may be present, the TACO may be present as hypotension and TRELI may be present as hypertension in case of hypovolemia. Furthermore, rapid improvement of pulmonary edema after diuresis is consistent with the diagnosis of TACO. The BNP is usually elevated in cardiac failure patients, and the post to pre ratio of more than 1.5 has a sensitivity and specificity of greater than 80% in a case of TACO. So WBC counts are basically unchanged in TACO as opposed to the TRELI, which shows a leukopenia, neutropenia, and monocytopenia. And on auscultation, the clinicians may heard of S3 Gallop, which indicates a transition from a rapid to slow ventricular filling and indicates a cardiac failure. The management includes stopping the transfusion. Just stop the transfusion and administer the diuretics. Place the patient in Trendelenburg position and with a supplemental oxygen. The prevention is, though the management is not in our hands, the prevention is in our hands. The prevention is with the transfusion medicine experts. Avoiding the unnecessary transfusion or adopting a policy of single unit transfusion. Considering the weight-based red cell dosing for the patients of low body weight, including the children's. Avoiding the transfusions in excess of recommended infusion rates. Administering of the diuretics when appropriate and monitoring the vital signs. So basically, avoiding the transfusion excess or the recommended infusion rates is the most important, and we should be taught in, as case or, on the case-to-case basis, and should be known to every clinician. Okay, what is the actual rate of transfusion and up to what time did the transfusion should go hand by hand. So UK has just issued in 2024, April 5th, a national patient safety alert on reducing the TACO risk, because the UK SHOTS 2023 reports has documented an increment of TACO reported cases and an increase in mortality in the last 5 years. So they have adopted or prepared a TACO pre-transfusion risk assessment, which AIIMS Jodhpur Department of Transfusion Medicine has also tried to adopt and has been circulated to the clinicians. So UK SHOTS has introduced a formal pre-transfusion assessment for the TACO, which should be undertaken whenever there is a possibility that all patients receiving the blood transfusion, especially if the weight of the patient is greater than if the weight of the patient is less than 50 kg and age of the patient is more than 50 years. Because the TACO is more commonly seen in the hemovigilance reports in this group of patients and in age groups. It assesses the risk associated with the heart, the lung, and the fluid. It assesses the status of the cardiac status, the lung status, and the fluid status. If the risk is identified, the clinicians have the option to defer the transfusion and put the patients on hematominics if the transfusion is not so urgent. In case the transfusion is required and cannot be omitted, that is the risk to the benefit ratio is more. The benefit to the risk ratio is more. That transfusion can be given as per the dose formula, taken the organ status into the consideration. Lastly, taking about the TED. So the TED is the transfusion-associated dyspnea, which is characterized by the respiratory distress occurring within the first 24 hours of the transfusion that doesn't meet the criteria of the TRELI, TACO, or allergic reaction. The respiratory distress should be the most prominent clinical feature of the TED and should not be explained by the underlying patient condition or any known. So again, we have a case of a 51-year-old male patient with a decompensated liver disease with an impaired left-right ventricular function with a low albumin. He was planned for PLEX with plasma as a replacement fluid for ALF, which is ASFA category 3. He developed respiratory distress crepitations during the first cycle. The chest X-ray showed the increased consolidation in the left lower lobe. The risk of fluid overload was noted prior to the transfusion, and there was no immediate response to diuretic as the time of reaction, but the patient was given for the diuretics in the ICU in a hope and in a view that the patient might have a TACO. So the patient was ventilated overnight and improved by the morning. The patient was classified at TED since there was insufficient criteria was present to classify as TACO, because for the TACO there is no accountability of taking the patient as not any accountability of taking the pre-existing risk. So this is the hemovigilance data of India from 2013 to 17, which in very good sense and very explicitly demonstrate a rising trend of the number of transfusion reactions from the 0.6 to 1.34, which has just doubled. We have a data of from the SHOS 2023 in which 205 reports were because of the transfusion, because in which there were total 205 incidents were reported, and among those 205, 172 were alone because of the TACO, and remaining were because of the non-TACO complications depicting the TRALI and TED. So the number of reported events because of these pulmonary reactions were 205, and the deaths because of these pulmonary reactions were 20. And the TACO alone comprises of the 15 reactions. So you can check how the significant or what is the or how harmful effect or fatal implication of the TACO have, which shows the mortality of more than 50% in these kind of cases. The more demographic, if we check the demographic data, we can see the more preponderance of these TACO cases, of these pulmonary complications in the female patients, and the most implicated blood component is not the plasma but the red cells. So I've just discussed it. So in which we have seen that total number of TACO mortality were 15 out of the 20 mortalities. 20 mortalities, and the keynotes or the take-home message includes that the pulmonary complications are a leading cause of transfusion-related mortality and morbidity. They should not be considered as a simple transfusion reaction. Multiple transfusion reactions may have overlapping pulmonary symptoms like dyspnea, fever, hypotension. Every effort should be made to recognize, to document the adverse transfusion reaction. At least we are in our hemovigilance register, and adverse transfusion reaction can be the question of your patient's life and death. Thank you.
Thank you, Dr. Anbog, for a very lucid presentation. And well, this is gaining importance because these two, the TRALI and TACO, is catching up in the list of the blood transfusion reactions, and primarily being made by the clinicians, and they report to the transfusion medicine experts, and well, they get involved and debate, discuss again. Well, any questions? Well, Dr. Ketpal, well.
Yeah, it's not a question, but I'll just like to mention that when we say TRALI, it means we have ruled out other causes of acute lung injury in the patient. But if a patient of acute lung injury requires transfusion, and during the transfusion he gets all these respiratory symptoms, clinician would like to call it TRALI. So it has to be in the absence of pre-existing ALI. If such symptoms develop, then only we can call it as TRALI. But any patient who has already got ALI, like pneumonia, and is on receiving transfusion, and if we get symptoms like this, we cannot call it TRALI. But it is commonly called by clinicians as TRALI.
They just want to put the blame on blood bankers.
See,
अपनी सरदर्दी कुछ नहीं है, पेशेंट को कुछ भी हुआ तो definitely the transfusion medicine department is handling.
The most vulnerable department in the hospital.
Well,
and definitely, मैम ये department ऐसा है जो accept भी करता है कि हाँ ये हो सकता है, because there is a clause of possible TRALI.
and this is what is important, because once I came and this was discussed, that the transfusion medicine people have now to take, well, they have to be the transfusionists. They have to get to the wards, get involved in the transfusion. For example, we are talking of TRALI. There's another word now called reverse TRALI. Well, it is not only in the plasma of the multiple pregnant patients, ladies and all that, but there can be an antibody in the patient itself, well, which can react with the patient or the donor's plasma once we have the antigens in that. So that is also to be taken in mind. This needs, these are debatable type of the things, but I think in the coming days, the transfusion experts have to take and the role of a transfusionist. So they have to get into the wards, and maybe tomorrow, in case somebody needs a transfusion, they should get a consult. They should get into the ward, say, put it, well, whether he needs a transfusion, follow it up, monitor the patients. Like that, they can tomorrow we can get involved, and that will
yes,
be
sir, definitely, sir. Basically, it will be
two-way
communication, not from the transmedicine specialist, also from the clinician side, sir.
This is very, very important. I remember when I went to the Apollo hospital, there was one of the clinician, and he was an Apheresis consultant. And then I asked him, well, what you are going to do? I am going to do the Apheresis. Well, he had one hemolytic MCS3P. That was the first after the S30. He was carrying it along. And when I saw this in the ward, I asked my DMS, what is this? He's going to do Apheresis. Manika, this is over in our domain. I had to stop him. So this is what is basically, otherwise, in case you will not do it, start doing it today, and you will continue it tomorrow then. Thank you.
Thank you so much, sir.
Certainly an enlightening session it was, and I would like to say that all the speakers, their throughout attention and care has made the understanding of the topic very clear for all of us. Now, without further ado, we have a felicitation ceremony. And to acknowledge the efforts of our speakers, we want to honor them with a token of appreciation in a form of memento. Can we please invite on stage Dr. Abhinav Verma to come and receive the memento from our chairpersons. Now may I request Dr. Shitja Mittal to make her way to the stage. Let us invite on stage Dr. Anubhav Gupta. Now may I request Dr. Rashmi Sood to present a memento to our chairpersons. We have with us on the stage Dr. Sangeeta Pathak. Now, on behalf of Manipal Hospital, Gurugram, we will felicitate Dr. R.N. Makru. A beautiful memento as a symbol of recognition. Thank you so much, Dr. Rashmi. Thank you so much, chairpersons and the speakers.
So we have a 20 minutes break for the tea. We'll join for the next. Okay, 10 minutes break for the tea, and we'll have brainstorming lectures session again. Thank you.
Thank you so much. Doctors are so cooperative. Thank you so much. A 10 minutes tea break, and right after 10 minutes, we will reconvene here and begin with our session 2. Thank you so much. Thank you. Welcome back, ladies and gentlemen, all our respected doctors. After a very refreshing tea break to the CME on transfusion medicine. And now, before we could begin with our session 2, we'd request each one of you to kindly settle down. Please relax. Sit back, relax, take a deep breath, inhale and exhale, and bring that wide smile on your face. We are going to commence our session 2, and we will now welcome our chairpersons on the dais. Let us welcome Dr. Anil Khetrapal, Dr. Bharat Singh, Dr. Sadhna Mangwana will be joining us virtually, and Dr. Tulika Chandra. A very warm welcome to our session 2 chairpersons. And Dr. Rashmi Sood is here on the stage. She will be felicitating our chairpersons with a bouquet each. Ladies and gentlemen, Dr. Anil Khetrapal is the chairperson, Transfusion Medicine and Blood Center Organization, Artemis Hospital, Gurgaon. Over 35 years of experience in the practice and teaching of transfusion medicine in various military hospitals of the country, expertise in stem cell harvest and therapeutic apheresis for various indications, instrumental in getting NAB accreditation of blood center and national marrow donor program for Artemis Hospital. Sir is a NAB assessor for blood centers, a rich experience in regenerative medicine. He has presented papers and posters in various national and international conferences, recipient of Sena Medal, Army and United Nations Peacekeeping Award. Dr. Bharat Singh is the professor, ESI Model Hospital and PGI MSR, Basai Darapur, Delhi. Formerly Director, State Blood Transfusion Council, Government of NCT of Delhi, Consultant Blood Transfusion Services, Director, Professor, GTB Hospital and University College of Medical Sciences, Delhi, NAB assessor, assessed more than 80 blood centers in India. He has published more than 50 papers in different journals in blood banking, attended more than 150 conferences, seminars, workshops in India and abroad. He has published a book named as Handbook of Transfusion Medicine. Our next speaker, Dr. Tulika Chandra, ma'am is the professor and head for Department of Transfusion Medicine, King George Medical University, Lucknow. She's the president of UP chapter of ISBTI, has published several national and international publications, published a book and a book chapter, reviewer of many journals, conducted many training programs, first to start NAT testing in UP and pathogen reduction in Asia, established the first plasma bank in Uttar Pradesh. Dr. Sadhna Mangwana, Director Transfusion Medicine and Immunohematology. Organization is Sri Balaji Action Medical Institute, New Delhi. She has 36 years of rich experience in practice and teaching of transfusion medicine. Executive Committee Member, National Hemovigilance Program of India, Chair AATM Atom, PBM Wing, Co-Chair Atom Quality Wing, Treasurer Atom India Chapter. Ma'am has authored books like Citation in Patient Blood Management, Global Perspectives and Practices in Transfusion Medicine, Bethesda, Transfusion Medicine for Medical Laboratory Technologists, 2023. Has published more than 50 plus papers and guest faculty in international and national forums she has been. Please welcome our chairpersons for the session 2. they will be welcoming our panel, the speakers for the session 2. Over to you.
Thank you very much for a nice introduction. Now, at the most, I thank Dr. Rashmi for inviting us to attend this session. Now, after tea, first speaker is Dr. Nidhi Bhatnagar. She is the professor and head at BJ Medical College, Ahmedabad. She is NABH assessor for blood banks. She is a PG teacher, reviewer of many journals, member of Technical Resource Group NVTC, invited faculty for National and International Congress, and conducted many training centers. Dr. Nidhi Bhatnagar will be speaking on enhancing transfusion safety, safe blood, bedside transfusion practice. Dr. Nidhi Bhatnagar.
Thank you, chairpersons. Thank you, Dr. Rashmi Sood and Manipal team for inviting me to this August CME. As Dr. Makru sir also pointed out, that I think the take-home message today would be, as sir already pointed out, that the next time let us have more clinicians in the audience. And because the topics are such. And previously, the session previously discussed about the transfusion reactions and somewhere how to prevent them. So in continuation with that, so my talk would be what are the safe transfusion practices, and I'll quickly go through what I'll be taking and few points on what, again, basically it is more on, I would have loved if the clinicians would have been the audience, but still, I hope I do justice to my topic. Should I continue from here only? So my table of contents is introduction, pre-transfusion best practices, transfusion best practices, then monitoring and documentation, which is very important, and conclusion. So coming to the introduction. It's not moving. So clinical transfusion practices, basically, they should be evidence-based. Basically, the steps are, first, there is a decision to transfuse, proper collection of samples by proper identification of this patient, compatibility testing, patient identification, appropriate use of blood products, and adverse event reporting. And while ensuring blood availability for the needy patients, it is also important to use the blood judiciously. That is what we usually propagate, and we usually tell our clinicians in our own institutes. And I would like to share also that every year, last 20 years, we are doing a small CME, a 3-day CME for the newly admitted resident doctors of the medical college. And because it's a PG institute and a big government hospital. And so every year the new PGs, how they have to collect the sample, how they have to administer the blood, what are the indications, why we have to stop the unnecessary transfusions, all this we are taking. So it is our duty, to make them aware about these things. So what are the laws? We already know the laws governing the transfusion in India. That is the Drug and Cosmetic Act 1940 and the Rules 1945 and amendments. The legal aspects and the informed consent. When we talk about safe transfusion practices, bedside, informed consent plays a major role. And according to Article 21, the patient, or anybody has the right to, autonomy, that whether he has to take the blood or not. So he has to decide. So, but for that, he has to be made aware. He has to be informed about the pros and cons, about the benefits and the risks, both. So this is the duty of the clinicians, and documentation of the consent is also very important. And usually in the case papers, there is a sheet of the informed consent. So again, just to outline, first there is a request from the clinician. Then sample is taken, sample is received in the blood bank. Testing, we do the TTI, we do the blood grouping and antibody screening, compatibility testing. We select the component appropriate. We do the labeling and component collection that is in the blood bank. The prescription is there that how many blood units are needed, when it is needed, which component is needed, and the administration. Coming to the pre-transfusion best practices. First, as I already said, there is a decision to transfuse. The decision to transfuse must be based through a clinical assessment and individual needs. So the risk and the benefits have to be weighed. The benefits have to be more than the risks. And patient evaluation, as previously we discussed about in the last talk about TRALI, the pulmonary symptoms, complications of transfusion. So if there is a baseline assessment of the patient and it is documented, it is good for us also, for blood bankers also, that previously the patient did not have any pulmonary symptoms, okay, now he has developed. So that if he has previously pulmonary symptom and it is documented, so it is, we can avoid the litigations and so on. So it should be documented in the patient's file. Patient information and consent, I already talked about this. We have to talk about the risks involved and alternatives also explained to them. If the patient is a pediatric, then the parents have to be, they have to be made to be understanding. Then valid consent has to be obtained and documented, and written authorization. So blood is a drug. Still, it is considered a drug, though we are trying, the people in the policy makers, in the nationally, they are trying that a separate blood law should be made, and it should be, it's not a drug, but it's a liquid tissue. So, but then let's just see whether it sees the light of the day. So components are authorized by the trained person. So whoever is taking the decision to transfuse, he has to give a written prescription. So this is briefly I wanted to make a A to E decision tree to facilitate the decision making in transfusion. A is assess the patient, any avoidable blood loss has to be managed first. Suppose the patient is bleeding, bleeding PR is there, so that has to be corrected. The cause of the bleeding PR needs to be corrected. Then B is blood results, best treatment option available, if there is any other treatment option available like iron and B12. Consent, communication, correctable factors need to be first addressed. D is do not forget other measures like vitamin K, tranexamic acid. Do not hesitate to question the colleagues about the rationale. Do not forget to document the patient's notes, the consent and the discharge summaries. Ensure timely communication to the labs. Ensure all relevant transfusion checklists, including TACO risk assessment, evidence-based decisions, and ensuring the patient receives adequate post-transfusion information if the patient is given a transfusion, which is daycare. So the request of the blood components, what is needed in the request form? 2 identification details of the recipient, maybe an ID number or a full name of the hospital, the patient details, the ID, or the treating clinician, whether it is routine or emergency, whether it is a planned OT, diagnosis, the reason for transfusion, so history of the previous transfusions. So all these need to be documented in the patient's demand or request form. And at the end, there should be a legible signature about that, who has taken the sample of the patient and who has sent the sample and who has sent the request. So positive patient identification before the blood collection is again very important step. This is where, it is not under our control, but WBIT, wrong blood in tube, which is the most common cause of fatal reactions. So this is where it can be avoided. So checking the IDs attached to, patient's identification or the patient's file or a wristband, as these days in many hospitals it is there. 2 marks of identification and documentation that you drew the blood. Sample collection, again, very important. Do it at the bedside. Again, patient's recipient's full name should be labeled on the tube, the hospital identification number, hospital board, treating physician, date and time of collection. So a very qualified person from the blood sample, when we are receiving it, we need to check although whatever sample is given to us, we have to accept it. We have to just tally with the form which is accompanying it. So at the time of transfusion, so what is the commonest cause of transfusion reactions? Already discussed in the previous sessions. It is basically incorrect unit of blood which was intended for somebody else. So this is avoidable, very much avoidable. So written documentation should be received. Whenever there is a demand of blood, written documentation needs to be received. Again, the matching, usually in our hospital, what we do is we ask the case paper. So whenever there is a demand of blood, we ask the case paper, and then we tally the blood unit with the case paper, the ID and everything, full name, and then we issue the blood. So how do we transport? During transport from the blood center to the patient area, it should be in a well-insulated transport boxes, which are validated to maintain the required storage temperatures. For red cells, the transport temperature is 2 to 10. I think basically all need to be transfused as early as possible, and minimum time in the transport should be taken. So again, the good practices in the clinical area, when the blood components reach the clinical area, then again we have to transfuse as soon as possible. The usual practice in my government government hospital is that they store in the domestic refrigerator. So these are the wrong practices which are happening, and suppose it is not used, they do not send it back. So like that, we can, if we keep a check, we can avoid the wastages. So again, the clinician needs to be told that the red cells should not be kept in the freezer compartment, and or the chill tray. Then platelet concentrates need not be refrigerated. So they need to be told that within 30 minutes, they should be transfused. So again, return of the blood components, you can have your own institute policy, whether you need to take it back or accept it or not. Usually the policy is that within 30 minutes, if it is returned back to you, patient expired or not required to the patient, not transfused, then you can receive it back. Again, at the time of receiving, again, when a return unit is there, you need to check whether it's in a good condition or the cold chain was maintained or not. And definitely you need to have SOPs for the same. So administration of components, this again, the ward side or the OT side or the clinician side, routinely the 18 to 20 gauge needle is there. And in emergency, maybe when you have to do a massive transfusion, you can have a large diameter and additional IV access can be used. BT set, again, priming can be done with the normal saline, and no medications or any other fluid should be there. Infusion devices, again, as I said, in massive transfusion, we can have infusion pumps and syringes, which will, in neonates, when you have to put a very controlled or you need to monitor the rate, the flow rate, you can use the external pressure devices in the massive transfusions. Blood warmers usually not indicated, but again, in the massive transfusion, it may be used in the following conditions like exchange transfusions, or patients with clinically cold antibodies, or rapid transfusion of large blood volumes. So concomitant fluid, as I said, normal saline is compatible, but again, the ringer lactate or the dextrose is incompatible and should not be mixed with the blood or the components. The rate of transfusion, again, it depends upon the blood volume, the cardiac status of the patient, and the hemodynamic condition of the patient. Most RBC's recommendation is transfused within 4 hours, maybe initial 10 minutes slowly, and then it can be increased. So the administration rates are calculated by counting the drops per minute, and the initial infusion 2 ml per minute in the adults, and maybe 1 ml per minute in the pediatric patients. Later 4 ml per minute can be maintained. So bedside checks. Again, whenever the blood is received in the ward side or OT side, again there is a recheck for the identification of the patient. We recently had, just last week we had a wrong identification, and then it was a resident doctor, junior resident doctor, and he didn't admit, but you know, that there was a wrong transfusion, and ultimately the patient has to suffer. So for the blood group, again, you have to check the blood unit, and again the case paper, and the cross-matching compatibility form. So the name, registration, unit number, prescription, label on the bag, time of issue, everything needs to be checked and documented. Expiry date of the component also needs to be checked. So at the time of transfusion, with clean hands, venous access should be established. Ensure skin antisepsis, use 18 or 20 gauge needle. If pre-existing line is to be used, we check for patency, signs of infiltration, inflammation or infection. After the final patient identity check, then the blood unit check, a baseline medical check, then we start the transfusion. And immediately before the transfusion, we just mix gently the blood unit and check for if there are any clots or something, any other thing. Monitoring is very important. As they say, if you have not documented it, you have not done it. So during transfusion, closely you have to monitor the patient, and every 5 minutes for the first 15 minutes, then every 15 minutes till the transfusion is complete. If there are any signs and symptoms of transfusion reaction developing, immediately you have to stop the blood transfusion and inform the blood center. It's not moving. Okay. So after the transfusion, again we have to monitor the patient for signs and symptoms of transfusion reaction, like fever, chills or sudden hypotension, chest tightness, allergic skin reactions, or cola-colored urine, jaundice, maybe to check for hemolysis, and it should be recorded in the case file. So if there is a suspected transfusion reaction, I think already it was covered in the previous session. So how we have to document it and how we have to double check for any administration errors or any clerical errors, and then we have to start the investigation. So before transfusion, what we have to record: valid indication, relevant investigations, doctor's prescription, valid sign and informed consent, or refusal, it could happen, the correct date and time and the signature of all of the above. During transfusion, the signatures and identification of the healthcare worker, maybe nursing staff is administering the blood, starting date and time, vitals during the blood transfusion, any adverse reaction or any medication which is concomitantly administered. After the transfusion, the completion date and time, and vitals at the finish, and after 30 minutes and 60 minutes, completed transfusion reaction form. And it's a good practice to send the unit, transfused units, completed units, empty bag back to the blood center. I don't know how many of in your centers you are following this. Anybody following this? Are you receiving the bag and then you are discarding the bag? And so is there a slip that transfusion is completed safely? So that's a very good practice. So at the time of discharge, or the date and time of each unit was completed, maybe multiple units were transfused. So each in my hospital practice, the clinician, they do is they take out the label and they stick it on the case paper. So the issue label is stuck on the case paper. So all these we've already talked about. So sorry for this. I don't know. So just an overview. So decision to transfuse, I've just summarized it, that how there is a decision to transfuse, patient information and consent, very important step. Authorized prescription should be there. request for transfusion, positive patient identification, blood sample for pre-transfusion testing, collection and delivery of the blood component. Who has taken the blood unit also needs to be documented, administration of the blood component, monitoring the patient, and then completion of the transfusion and documentation. So by adhering to the strict guidelines and protocols, it's our duty, the blood center's duty, our staff, to make the clinicians aware of the intricacies involved in the blood transfusion and what harmful effect it can happen if we do not monitor the patient or if we do unnecessary transfusion. So the key elements are verifying the patient identity. So check the patient identity, check the patient identity. You have to emphasize that patient identity needs to be checked at the time of sample collection and at the time of administration. Again, regular training to the healthcare staff of the institute is very important, and open communication and reporting the near miss or errors also will help you to prevent it further. So, thank you so much. These are the references.
Thank you, Nidhi, for nicely presenting the bedside practice. I hope the clinicians would have been there. And I recommend that this type of lectures should be taken when the batch of interns join in the hospital or the new PG join. So in my medical college, whenever the new PG set comes and the interns come, we used to have a orientation program.
Yes, sir. We are having last 20 years in BJ Medical.
So
we are holding this.
Very good. And one more thing I want to tell, that we have actually followed earlier that pre-labeled tube. That is very dangerous. We should not label the tube. Tube should be labeled when you are with the bedside. And the storage temperature. Sometimes we should ask the clinician that you need blood. Whenever you need blood, you ask whatever amount you want to transfer.
They are scared because they feel, it will delay.
Lага के रख लेते.
So they just keep अपने पास रख लेते हैं.
Sometimes what happened that in one of the very big nursing home, they asked for 2 units of blood. One transfuse कर दिया, दूसरा sister को बोल दिया रख दीजिए. And she has kept that in the refrigerator, deep freezer. That led to, and that's to transfuse the later. That led to the kidney failure. So this type of, we should avoid this. And it was a nice presentation. Thank you.
First of all, I would like to say, it is like reliving our problems. What Dr. Nidhi has said, we all face such a lot of problems. And I would like just to share one of our experience. Recently, I think so within the past 2 weeks, we are facing a problem. There's an inquiry of a medical ward patient, and she was on dialysis, and she was transfused blood. The blood was kept on a refrigerator, which was on the first floor, and the patient was admitted on the ground floor. And the blood was taken out, and we say it's only 30 minutes, the blood comes to its normal temperature after taking counter BBR. And then it was transfused, and the patient deteriorated after 24 hours and ultimately died after a month. She went into a renal, then she went into ICU. And there's been a case from the attendants, and they feel that the hospital has intentionally given cold blood, and that is why the patient has died. And the basic problem we are facing is there are no documents from the clinical side. No consent for transfusion is there. You know, whatever happens, you have consent for everything. You have a consent for dialysis, for treatment, for everything. But there is no consent for blood transfusion. So it becomes a deterrent for us to save the system as well as us. Even though we know it's not our fault because the patient was already critical. But it's the patient attendants lookout that they want to correlate it. So this documentation which you're saying is really, really important, which we've been trying to emphasize to the clinicians. And what sir is saying about the PG, what happens, in our setups where we have postgraduates, every year there is a new set of postgraduates who have graduated from different parts of the country. And they come with their own firm fixed ideas according to what was taught in the undergraduate level. And by the time they come to the second year and they learn, they have already committed a lot of mistakes. Because most of the time the transfusion is by the JR1s.
And they are taking it so lightly that, these are practices in which we are also seeing, though we are taking the training of the postgraduates every year for 3 days, हम उनको खिलाते पिलाते हैं और फिर आके वो सो जाते हैं, first years होते हैं, but still they feel कि O positive पड़ा है, extra patient को चढ़ा नहीं है, तो ठीक है O positive sister fridge में रख दो, दूसरा कोई patient आएगा O positive इसको दे देंगे. So that is the level कि वो दूसरे patient को O positive को दिया जा सकता है. बिना compatibility के.
Excellent presentation, Dr. Nidhi. I'd like to add one thing, that we should also always insist on two sample policy. That is one sample at the time of when the request comes, and the second sample at the time of issue.
Demand, okay.
Demand. So unless we insist on two sample policy, there could be errors based on a single
Very
sample.
difficult to implement, but because again sample, बार-बार sample मंगवा रहे हो आप, so वो भी,
It's good at times when the patient is in the OT or for a neonate, it's difficult to get a sample. But then as far as possible, we should insist on two sample policy. Other thing is, at times when the blood is demanded from the department, it goes to the ward. It remains in the ward or it comes back to you saying that the patient has developed fever. This they should have noticed before sending the request for issue. If the patient has fever, you are trying to delay the transfusion. It may take 2 hours or 3 hours for the fever to settle down. Till then, the blood is kept outside, or they will like to send it back to for temporary storage to the blood bank. So they should see if the patient is ready for accepting the transfusion or not. At times they say that we are trying to get the vein, but we are not able to get it. So the blood is lying in the ward because they are not able to do a phlebotomy.
And I think we can implement our policies, whatever we want to, by the hospital transfusion committee. So if that is in place, then maybe things are easier.
Other thing is, we see that most of the transfusions are happening at night. The daytime transfusions are happening at night when there is meager staff available, and chances of errors. They increase both at the department level because they have to issue blood, lot of blood, which actually should have happened during the daytime, but is happening at the night.
That is same with our hospital. That's
another issue which is there. And then the concept of transfusion nurse or hemovigil nurse. We talk about it, but I think
it's not implemented. How many institutes having the transfusion nurse? We don't have. Yes, Dr. Sadhna wants to say.
We are having hemovigilance nurse. We have dedicated one nurse who is a ANS or whosoever is in the round-the-clock duty. So bedside, that apart from the team leader or the assigned nurse, personally they go and see along with the resident doctor, and we have made a protocol for our hospital that they have to post a bedside verification picture. So that in that WhatsApp group, we have all the administrator, nursing, as well as the blood bank team. So it is seen that it is verified on the bedside. And of course, taking precaution of the confidentiality and privacy of the patient being maintained, that the patient's picture is never taken. But yes, we are having kind of that arrangement for a hemovigilance, for bedside verification and everything. And yes, what you asked about discarding, yes, we are receiving all the empty bags in the blood bag. Of course, not in the premises of blood bag, but straight into our autoclave room or the discard room, and where they are put together and autoclaved. So we ensure that they are being discarded here only,
not
and
wasted,
not
wasted at least.
Biomedical waste.
One more thing I would like to add, according to two sample. What we are promoting now is that when the patient gets admitted, everyone has a CBC done. That's a mandate for everyone. And so in the CBC, when the blood is withdrawn, that ADTA while get the blood group done. Make it a mandatory. It's difficult, we know, but that is what we're trying to advocate. Now, Dr. Makru wants to speak something.
Well, there are no clinicians here. I present myself as a clinician to you. Well, you have taught me what is saved blood and all that. And I'm taking consent from the patient. I explain the patient about what is saved blood and everything, and he understands. And after that, I make the request form, the prescription, what you said. I write in the prescription, please provide 2 units of NAT-tested leuko-reduced blood to the blood bank. Now the request has gone to the blood center, and the blood center does not have neither NAT-tested, neither leuko-reduced blood. What you will do in that?
So usually the blood center, suppose it is, I give my example. Suppose whatever facilities or services are available in my blood center, that would be already known to the clinicians, my doctors.
See, the thing is, patient, because patient has a right to refuse the blood, as you know, because once you are taking the consent, the patient the doctors, because we teach doctors. For example, there would have been a doctors here, and they will get to know that what is a safe blood. We tell them that to narrow down the window period, we need to do the NAT testing. To prevent the transfusion reactions, we should have leuko-reduced blood. So they get to educate it. And once they get educated, they want to implement back home in the center where they are preaching the medicine. And then they feel that this will be available. They don't know. For example, drug, once we say blood as a drug, and once we prescribe a drug, and we write the prescription. So he has written a prescription. He sends to your blood center, which is a shop, which is dispensing the blood.
And we don't have.
Well, you don't have. What you will tell the patient?
So we refuse that. We don't have this facility.
Can you refuse the blood? So this is what is the situation, and because it is there where the patient get into the court of the law. What you will do? Because here, the transfusion medicine expert, what we are here, we will be liable.
I think we can discuss this.
This is something which is thought-provoking, because the clinician, had the clinician been here, they would have posed this question.
We agree, sir, we agree. And I think we should stop discussion. We can go for the. Thank you, Dr.
Thank you. Thank you. Thank you so much.
Next speaker is Dr. Gopal K. Patidar, and he's an additional professor in the Department of Transfusion Medicine, AIIMS, New Delhi. And he's a recipient of Dr. Harold Gunson Fellowship by ISBT, Award of Excellence by ISBTI, and the Young Scientist Award by ISTM. And his international achievements are, he's a chairperson of Wikipedia subgroup of ISBT, secretary of Hemovigilance Working Party of ISBT, and the secretary of Hemoglobinopathy subgroup of ISBT. And national appointments, he's a chairperson of ISTM SIG on TTI, and subject expert for National Donor Hemovigilance Program, and has got more than 50 publications. And we would love, and he's going to speak on global perspective, evolution and impact of hemovigilance program. So go ahead.
Thank you. Thank you so much, ma'am, for kind introduction. And thank you, Dr. Rashmi, for inviting me. So my topic today is the global perspective of evaluation and impact of hemovigilance program. So it is kind of the whatever we are listening since morning, adverse transfusion reaction, different kind of the reactions. So it's just a reporting of that reaction and surveillance of that reaction in this thing. So what is hemovigilance? Hemovigilance is a critical part of blood transfusion service designed to monitor and improve safety throughout the entire process from donation to the transfusion. It's involved the tracking as well as analysis of the adverse events, and finally prepare a safety guidelines and improve the quality of the blood products. So WHO defined, which is the most acceptable definition of the hemovigilance. It is a set of surveillance procedures covering the whole transfusion chain from the collection of blood and its component to the follow-up of the recipient, intended to collect and assess the information on unexpected or undesirable adverse event. As well as there is the analysis and the prevention of the occurrence and recurrence of this adverse transfusion reaction. So what are the aim of hemovigilance? The aim of hemovigilance is to collect the data on adverse event, to improve the safety of transfusion process, to inform in policy or developing the policies, and improving standards and adding in formulation of the guidelines. So in the evaluation of the hemovigilance, when the concept of the hemovigilance arises, so if we see in 1980s, there was a thought that there should be some kind of the system when there was the increase in numbers of the HIV or hepatitis B in the world. So they thought that there should be some kind of the surveillance system, there should be some kind of the reporting system, so we can prevent this kind of the infections. Then in 1990s, the concept of hemovigilance, France seriously took this concept, and they thought that yes, we should have. In 1991, they used the term hemovigilance first. Before that, there was the pharmacovigilance, so they used the hemovigilance for the blood in 1991. In 1993, they developed a law. They developed a mandatory law to report all kind of the adverse transfusion reactions in the French network or French blood systems. Then in 1996, the United Kingdom developed a serious hazard of the transfusion, which is almost equivalent to the French hemovigilance system, but it was a voluntary system. It was not a mandatory system as the French. Then in 1998, all the European countries merged and developed a European network or European hemovigilance network. Then in 2012, almost after the 20 years of the initial concept of the hemovigilance, in 2012, the hemovigilance program of the India is developing these things. So if we start with the French hemovigilance system, the French hemovigilance system is a national system created in law in 1993. It is a mandatory system to report all kind of the adverse transfusion reaction. It is some of the 2,000 correspondents coordinated by 24 regional coordinates and send transfusion incident reports that are ultimately analyzed to the services and hemovigilance cells. For the data analysis, there are some physicians also, as well as statistician or epidemiologist in them. And nearly 4 years after the founding, hemovigilance has reached its cruising speeds and almost covered all the French network of the blood systems. After that, the serious hazards of transfusion, or SHORT, is developed in 1996 by the United Kingdom. It was a voluntary system in the United Kingdom. It is almost same as the French system, but it is voluntary, and they identify the risk and problems are identified, and they produce the recommendation based on this. And the recommendations are put into the annual report, and SHORT can also monitor the effect of these implementations. Then the SHORT, nowadays SHORT is very much developed, and they are creating some kind of the cartoons and creating more and more awareness into the UK systems. Then the European Hemovigilance Network was developed in 1996. It was developed initially by the 5 countries, the Belgium, France, Luxembourg, Portugal, and the Netherlands. These 5 countries collectively collect the data of the adverse transfusion reactions. They analyze and they try to develop more guidelines and the policies based on these things. Then International Hemovigilance Network was developed. It is not other than the European Hemovigilance Network developed globally. They convert this European Hemovigilance Network into the globally. They include the almost 40 countries in the global and develop a common network for all the worlds. It was developed in 2009, and they also provide the support to national systems, including WHO, and through the education, networking, and scientific seminars and contribution to the development of standards definition. It also helps in the lower middle income countries to develop the hemovigilance program in their countries. The International Hemovigilance Network, or IHN, again developed the ISTARE. ISTARE is the International Surveillance of Transfusion-Associated Reactions and Events. It is an online database to collect, analyze, and share data for purpose of quality assurance and benchmarking. On the website of ISTARE, you can go and you can see the adverse transfusion reaction of all over the world, which are the part of the International Hemovigilance Network. And the time to time, they publish their data and they develop a guidelines to improve the hemovigilance program all over the world. Like in recent publication, adverse reaction following transfusion blood in focus on some rare reactions. Before that, there is the IHN database for the surveillance and event in donors and recipient blood technical issues and results. Then this complication of blood donations reported through hemovigilance systems. Then it's comparing the transfusion reaction of analysis of 7-year data of the ISTARE hemovigilance. And the IHN database for the surveillance of adverse transfusion reaction and events in donor and recipients, again the technical issues and reasons. So for the time to time, they are developing the guidelines or they are analyzing the data of the reported to the international hemovigilance networks, and they publish these data. Then there is the Society, International Society of Blood Transfusions, that also have the separate working parties of the hemovigilance working party. That society also collaborate with the other organizations like IHN, WHO, and other national and international groups, and they also help in developing the guidelines and policies. Like in the website of the Hemovigilance Working Party, you can find many definitions, updated definitions, as well as the policy or the revised surveillance data on the websites. Then the World Health Organization, or WHO. WHO then took the initiative to develop a guideline or guide to establish a national hemovigilance system. It is a complete guide which guides you how to establish a hemovigilance system in your country, and they develop an aid like WHO aid memory for Ministry of the Health to develop a national hemovigilance system. This categorized into the majorly 4 points: what are the leadership and governance help, and how they can help in the developing the hemovigilance network. Then what is the role of the organization and coordinations, then hemovigilance in donation and provision of blood products, and hemovigilance in clinical transfusion. So it is a completely comprehensive guide books which helps in the developing the hemovigilance network, especially in the lower middle income countries where it is currently not available. Then IHN and the other organization come up with a Notify library. It was a Notify project initially, then further it made a Notify library. It is a comprehensive library in which you can get all the publications related to the hemovigilance. It is a free library. You do not need any kind of the login ID or the password for you cannot, no need of any kind of the username or password for this library. You can easily get all kind of the data like recipient related, the adverse event, donor related adverse event, fetus and offspring, and the risk of the harm, as well as the many other informations or the guidelines are available in this library and free access for the all. Then finally in 2012, December 2012, the Indian Hemovigilance Network is the came up as a hemovigilance program of the India. Initially, it came as the recipient program only, and then in 2015, the donor hemovigilance program also came up and launched. The National Coordinating Center for this hemovigilance program of India is the National Institute of Biologicals. Currently, as available data, the recipient program had the 1,448 blood centers participant in that one, while the donor program have 1,150 centers, 57 blood centers who are participated in the Indian hemovigilance networks. Like you all might know that Indian Hemovigilance Network had two kinds of the reporting forms, adverse reporting forms for the recipient adverse events as well as the adverse blood donor reporting form. Both have updated right now. Initial first version, they got a little lesser amount of the data and they faced some difficulties in the analysis of the data. So they updated their forms. They also have the guidance document for both the recipient adverse event as well as the donor adverse event on their websites, which guide you how to report the data in the hemovigilance program of the India. HVPI Hemovigilance Program of the India also publishing their data time to time. Initially, they published about the recipient hemovigilance, 2 publications related to the recipient hemovigilance, while 1 publication related to the donor hemovigilance. And recently, they put their summary report of 2018-19 data of the recipient hemovigilance also in their websites. The recent survey by the ISBT, they did the survey in the lower middle income country to know the status of the hemovigilance in their countries, and they found almost in the 24 countries participating in this survey, and they found 72%, almost 73% of the country had the hemovigilance program in their countries, and in that 73%, 77% have both donor and hemovigilance program, while 23% have only recipient program in their countries. So what are the contributors of the hemovigilance? The primary contributors are the patient or blood donors or community organization from where we need to get the data, from where we need to ask about the adverse reactions. Then the blood centers who analyze this adverse reaction and finally made a diagnosis and imputability of the adverse reaction. Then hospitals and laboratories in the supportive cares. Then national and regional hemovigilance system which collect all the data of that national and finally analyze. And Ministry of the Health is helpful for the final prepare the report and as well as the running the program of the hemovigilance in the countries. Then what are the impact of the hemovigilance? Since almost 30 years of the hemovigilance in the world, so there are the many remarkable impact or remarkable improvements were found through the hemovigilance in the world. Mainly, many case studies or the many publications are available from the initial hemovigilance program like France or the Brazil. They highlighted how the hemovigilance system have prevented major transfusion-related events and saved lives and improved overall technical qualities. if we go through the evidence-based impact of the hemovigilance, we found the many publications related to the prevention of the TRALI through the hemovigilance, then prevention of the TACO, prevention of the septic transfusion reactions, other TTIDs, then prevention of donor adverse reactions, then development of the severity gradient tools and educational impacts. If we go one by one, the TRALI, we all know in 2003, the serious hazard of transfusion short recommended based on their data that moved to the male donors for the fresh frozen plasma and suspension of the platelet pools and preferential recruitment of the male apheresis platelet for the prevention of the TRALI. If you want to recruit the female platelet donor, you have to screen for the HLA or HNA antibody and retest it after the pregnancies. So there are many publications related to this. They found it is very effectively, like this is very nice publication of the 10-year experience of the TRALI mitigations and measuring their progress. They found that in 2007 to 2017, in 2007, there was almost 3 per 1 lakh components they found TRALI, but while after implementation, the male-only plasma or other measuring units, they found 0.6 per 10 lakh in 2017. So it was a significant improvement of the TRALI after the recommendation of the hemovigilance to use a male-only plasma in this case. The another impact is prevention of the TACO. In this, it is a kind of the indirect impact. In the TACO prevention, the hemovigilance data identified the risk donors or risk patients in which the TACO can be happens. Like one very good clinical trials, TADPOL clinical trials, it's registered in the clinical trial registries. They identified the major patient factors which can lead to the TACO based on the hemovigilance data, like cardiac disease, patient with chronic renal failure, or patient with extreme ages and positive fluid balance, and many other factors like the rapid flow, low body weight, hypoalbuminemia. All these factors can lead to the TACO. So these risk factors were identified based on the hemovigilance data reported to their countries as well as the international hemovigilance networks. Then another important invention of the hemovigilance or impact of the hemovigilance is the prevention of the septic transfusion reactions. They found that many of the septic transfusion reactions reported in the various countries as well as the international hemovigilance networks. So the common factor was there that the skin preparation was not good, as well as the mostly skin commensals which can lead to the septic transfusion reactions into the patients. So they develop a guidelines like improved skin preparation, sample diversion pouch, and bacterial screening of the TTI, the introduction of the pathogen reduction platelets also. In this also, these very nice publications in 2011, like use of hemovigilance data to evaluate the effectiveness of the diversion and bacterial detections. In this, they found that the diversion pouch significantly reduced the incidence of the septic transfusion reactions after getting the hemovigilance data. Then other TTIs like emerging or re-emerging viruses, which are identified when they report into the hemovigilance network, like West Nile virus, Zika virus, or the Creutzfeldt-Jakob disease. When they reported this data into the hemovigilance network, they developed the guidelines and they developed further testing, like net testing for this kind of the infections and prevent these infections into the recipients. Then another impact is the prevention of the donor adverse reactions. In this also, the hemovigilance data identified the risk factors in the donors, what kind of the donors had the higher prevalence of the adverse reaction, like vasovagal reaction in the female donors or young donors or first-time donors. These kind of the donors were identified through the hemovigilance data, and they developed guidelines that how can we reduce this kind of the adverse reaction in these donors. Similarly, in our national blood donor vigilance program of the India, we also found that the young donors and female donors had more VVR compared to the older age and the male donors. Older age and the male donors. And based on this, we also recommended that the improved donor questionnaire and examination about the history of medicated tap allergy or bleeding and coagulation disorder. Use the measure to reduce the young and first-time blood donor anxiety so we can prevent the vasovagal reaction in them. Then improve the phlebotomy techniques that improve post-donation care and vigilance and early identification and management of the first reaction to prevent the second reactions. Again, the hemovigilance program in the worldwide have the educational impact. The many kind of the educational seminars are conducted through the hemovigilance, like International Hemovigilance Networks, IHN, and the ISBT conducting regularly many seminars for the prevention and the increase the reporting of the hemovigilance. So this is the major impact of the hemovigilance also. Then development of the severity grading tool. It was developed by the AABB, American Association of the Blood Bank, initially known. Now it is the Association for Advanced Blood and Biotherapy. In association with the ISBT, IHN, and the EBA, they developed the severity grading tool for the donor adverse reactions, how to prevent the severity of the donor adverse reaction, how we can treat this donor adverse reaction. This is also kind of the impact of the hemovigilance program. So the current status and future direction of the hemovigilance is that as of 2024, the hemovigilance system are widely implemented in developed as well as the many increasingly adapting in the developing regions. The challenges remain particularly ensuring the consistent reporting and integration into the national healthcare systems, and future of the hemovigilance in improving data integration, expanding coverage in the low resource settings, and incorporating new technologies such as artificial intelligence in predictive analytics of the further enhancement of the sector. So thank you so much. There is no right and wrong approach to the hemovigilance, but yes, you have to report whatever you found in your blood center and your center. Thank you so much.
Thank you. I think so. That was a very comprehensive lecture on hemovigilance. It made us aware of so many issues which hemovigilance covers. And just a little comment, I think so we've done an excellent work, is because hemovigilance is a very vast procedure and it has started a few years back, about 10 to 12 years back. And still many are incorporating into it, and it has really improved practices from the clinician side of view, because which was never very really possible from the blood bankers side. And still one major issue what we relieve is because in Delhi you have corporates, but like in UP, the private sector goes into small nursing homes, going to various small blood banks, supplying to various nursing homes. So over there the hemovigilance area is still untouched because the feedback doesn't happen. But I hope so we'll find out ways to incorporate them also.
Yes, ma'am. There is many standalone blood banks in the country, so there is quite difficult for them to go to all the hospitals and collect the data for that.
Let me say that it is a brilliant presentation. All I'd like to add is that we as blood bankers are governed by all kinds of vigilance. This was hemovigilance to take care of the adverse donor and transfusion reactions. Then we are governed by pharmacovigilance, because all our blood components are either Indian pharmacopoeia or British pharmacopoeia. So we are governed by pharmacovigilance as far as the blood component is concerned.
Yes, sir.
And as regards our stem cells, and we are governed by biovigilance. So all kinds of vigilance are there that we are governed with.
Yes, sir. All system in place, but the reporting should be there.
Yes.
That is most important.
The other thing is when it comes to imputability and severity of a reaction, it is always better that when we get to know that there has been a reaction due to transfusion in the ward, ICU or wherever, it is a good practice that we should go ourselves and see the patient, and it is good for us to sort of decide the imputability in consultation with the clinician. Yes. Rather than the form coming to us after a few hours or the next day, then we look at the form and then you have not seen the patient, and then you are trying to decide the imputability, whether it is definite, probable, possible, unlikely or excluded. Sitting in the ward, sitting in the department, we can't do that unless we have seen the patient at the bedside.
Yes, sir.
So as far as possible, I think it should be a good practice that we go there and see the patient.
There are many publications related to the active hemovigilance versus the passive hemovigilance. And they found that active hemovigilance is more effective compared to the passive hemovigilance. In active hemovigilance, after every transfusion, we have to go to the ward and assess the patient about any kind of the transfusion reactions.
Recently in our hospital, we had made a subcommittee under Hospital Transfusion Committee. All the reactions seen in that particular month are being discussed with the clinicians and along with the administration and blood bank staff. And whatever corrective action has been taken, we are imparting to the administration to follow in the hospital. So this can be done. The reactions should be discussed, and the outcome should be communicated to the clinicians.
Yes, sir.
Thank you, Dr. Pali.
Thank you so much.
So, yeah, please.
So very nice presentation. So just want to share, no questions, just want to share the practice which we are following in our hospital. So we have got a dedicated software called as Hemovigil. So what we are doing, any patient who requires blood transfusion, we are tying a wristband actually which has got 6 barcodes, and we are using digital transportation boxes. So this box will open with the same barcode which is there on the patient's wristband. So whenever nursing are sending the box along with the issue slip, they are locking it box, and we are keeping the blood components in that and locking it with the same ID. Once it reaches to the transfusion site, now we have linked this Hemovigil software with the blood bank management software. So nursing will log in through their own ID. They will check all the details starting from the patient's verification details, and they will press the button of acceptance. Then they will pass it to the doctor. Doctor will log in through their own ID and press the button of verification. Only when the acceptance and verification has been done, then a blood transfusion feedback form will appear, which the nursing team has to fill in real time. And whether they started within 30 minutes, whether the transfusion is completed in 4 hours, daily report is being generated by the IT team in the morning, next day. So we can track all the blood transfusions, who has done the acceptance, who has done the verification, whether the blood component was started within 30 minutes, whether it was finished within 4 hours. So it has really helped us in tracking that. Yeah, thank you.
Yeah, I agree with you. This Hemovigil system is a very good, excellent, like we use the box also and send it to the patient. It is logged. It will only open at the right place when it goes to the right patient. So it's a good practice. Yeah.
Thank you very much, and very nice presentation, Dr. Gopal. I would also like to share my experience how we are practicing that, in a way, active-passive, you can say, hemovigilance, not exactly active, not exactly passive. We don't go to the bedside, but whenever there is a reaction form coming to our back to the blood bank, we ask for the patient file. The patient file comes back and we check for all the requirements, whether the order was placed, whether the sticker was there, whether all the documentation has been done or not. So the basic requirements of the hemovigilance we check for in the file. And if we find that the patient was having already in, having some cardiac overload problem and the transfusion was given, and then we are also able to check for the cold chain part, that when the blood was issued and actually when the transfusion was started. So that part also we are able to check in the patient record as well. And we then go back to the doctor, we talk to them once again and coordinate with them that, okay, was this the condition? So we have been able to find TACO in many cases. There was a patient of rheumatoid heart disease, this rheumatic disease, and it was a gynae case. And we were able to find out once we got the file back, and we found that, okay, yes, it was a TACO, and how they managed it later on. So similarly, we are able to find those things when we coordinate back to the doctor. There was a case in ICU where the patient had a reaction, and we were able to find out that, okay, the blood issued from our center or from our blood bank was slightly on the later date, not very fresh, after say around 20 days old or 25 days old. And the patient was in ICU and already having a high potassium level. So such things we are able to find out, and we can connect back to them and guide them as well. And what sir suggested, I think Dr. Bharat Singh, is very nice, having a small subgroup which is dealing with discussion of the adverse transfusion reaction back to the clinician is a very fantastic idea. Thank you, sir, for that.
Thank you, ma'am, for your inputs. Sir, I just a humble request. Should we not have a consensus for having a hemovigil nurse, like from the NBTC side or from the drug controller side? Because anyways, the transfusions are followed, so we are doing so cumbersome jobs, we are having meetings, and rather than that, we should now think of having a hemovigil nurse. It should be compulsorily done in all the setups. I feel so.
Yeah, I think so. That's a very good idea. But we've got DBTT students, diploma in blood transfusion students, whom we send on the clinical rounds, and then they monitor and help those patients. So use whatever manpower we have and we can join. That is what the suggestion.
Actually, I would like to say that it's been a difficult task to get the counselor on board for the corporate hospitals and the private hospitals. And on top of it, adding another manpower is a big challenge. I don't know how we tell them, because all over the hospital, one hemovigilance nurse or person won't suffice. So it has to be more than one. So how is it possible to add those more manpower in a private sector? It's very difficult.
Maybe you can double or train more resource, the manpower you have.
So our technicians can go, they do the hemovigilance. One of our technicians in the evening duty goes for doing an audit of the files post-transfusion within the last 24 hours. and checks whether all the requirements which are needed as a part, they check it and document it. We document it that way, and one person is there.
Okay, coming to the...
Can I?
Yeah, I said coming...
Yes. Can I say, sir? What I was trying to say, what Dr. Tulika and Dr. Sangeeta Agarwal, if I am correctly identifying her, we are on the same page that utilizing the manpower or the resources given by any organization. So this is what we are doing for the hemovigilance nurse, that whosoever is assigned nurse on duty, ANS round the clock, doing the hemovigilance nurse. And the same way for the counselor. Rightly pointed out by Dr. Sangeeta that getting resource person, a dedicated resource person for any delegated duty is really difficult, be it a government sector, be it a private sector. Though there is a scope in NABH standards for the hemovigilance nurse, and now it is becoming compulsory that we need to enroll ourselves for the HVPI program as per the NABH standards. Thank you, sir. Over to you.
Okay, ma'am. Now it's my proud privilege to welcome the last speaker of this session, Dr. Hemchand Pandey. He is additional professor and head, AIMS, New Delhi. He has got 44 publications, 3 book chapters to his credit. Besides, he is the assistant editor, DGHS Technical Manual, 3rd edition. He is a peer reviewer for various journals. He is a member of ISTM, ISBT, ASFA, and AABB. And he is a member of the ISBT Working Party on TTI. So, Dr. Pandey, the stage is yours, please. Yes, presentation. He will be speaking on transfusion-associated graft versus host disease.
Yeah, so good afternoon, everyone. Thank you to the organizers for calling me here, and good afternoon, chairperson. So I've been given a little unusual topic, transfusion-associated graft versus host disease. So unusual in the sense that we are not concerned except for the prevention part. Most of the time, diagnosis would be made by the clinicians, and that too, they are missing it a lot of time. That I would be discussing that. So first of all, I don't have a conflict of interest as far as this topic is concerned. It's one of the rarest complications, I would say, of transfusion, or maybe not rare, but less recognized and less reported complication of transfusion. The incidence of this reaction is unknown, but if we go to the literature would point it to at around 0.1 to 1% at the in risk individuals. I'm not saying for whole population. For at-risk individuals, it used to be in 1980s around 0.1 to 1%. However, it has decreased over time, maybe because we have realized the risk factors, maybe because there are preventive strategies available. So that has reduced the incidence. And if we see, take the example of Japan. I'm sorry for that mistyping. It's 1981 to 1986. The incidence in Japan was 0.15%. And if we see the recent publications from 2000 to 2001, there were no cases reported from Japan. So the incidence of this reaction has decreased over time. Now, this is one of the meta-analysis which was done in 2015. In that, if you see the cases which were reported from the time the publications have started till 2013. So if you can see the rate of reactions or the TAGVHD cases were the highest from Japan, followed by other countries. You can see in India there were around 12 cases reported till 2013 in whole of the literature. So it's quite rare complication. And there were 56 cases from different countries. You can see their names in the lower part of the slide, where less than 6 cases were reported for each country. Now, if we see over years, 17 cases were reported in the from 1966 to 1979. So you can see that over years, first they increased. After 2000, they have decreased to around 66. If one wants to see the meta-analysis, they can scan this QR code and that will take them to the publication. Now, what this disease is actually. So, when a person is transfused with the blood, expectedly or unexpectedly, lymphocytes will be transfused along with most of the blood components. And most of these lymphocytes are viable, except for the frozen products or some of the other products. Most of the products will have viable T lymphocytes. But if a normal person, these viable T lymphocytes are actually destroyed by the immune system of the recipient. So in a normal individual. So this will not have any kind of TAGVST. However, if an individual who is immunosuppressed or there is a partial HLA matching. So in this case, the recipient will not recognize or will not mount an immune response to the donor T lymphocytes, but the donor T lymphocytes take an upper hand and they will attack the tissue of the recipient, and that would result in TAGVST. So most of the time, when one look at the kind of tissues which are involved, they are mostly which express the MHC class II antigens, and they are basically bone marrow, skin and liver. So these three are the major organs which are involved in TAGVST. The viable T lymphocytes will actually attack them, and that will result in pancytopenia, skin rash and liver dysfunction. Now, which blood components are involved? As I said, almost all the components which we transfuse are actually involved, except maybe fresh frozen plasma, because the process of freeze-thaw will destroy these T lymphocytes and they don't remain viable. So one can look at almost all the components which we are transfusing are carrying viable T lymphocytes and which can proliferate and cause TAGVST. So who is susceptible? Firstly, people who are immunosuppressed, because their immunity is suppressed and they cannot mount an immune response against the transfused T lymphocytes. So the transfused T lymphocytes gain an upper hand and will cause this particular transfusion reaction. So if we see, there are some of the diagnoses where we can find TAGVSD, like the people with congenital T cell deficiencies, like the severe combined immunodeficiency. Then hematological malignancies, a number of malignancies one can see. Then the recipient of HSCTs, so they can have a graft versus host disease as well as TAGVSD. So I'll come to the differentiation part later. Then autologous stem cell harvest can also have this, aplastic anemia in patients who are receiving ATG. Then some newer drugs like anti-CD52, then some immunosuppressive drugs, especially fludarabine. Luckily, steroids have not been implicated in a number of, in none of the cases, though they are immunosuppressive, but they have not been implicated in TAGVSD. Then IUT, intrauterine transfusions, exchange transfusions, and neonatal alloimmune thrombocytopenia have also been known to have also been people or the patients where this particular problem may occur if preventive strategies are not used. Then it is not only immunosuppressed but immunocompetent individual also who can develop TAGVSD. Why? Especially when the population is ethnically homogeneous. So this ethnically homogeneous population is mostly observed in Japan, from where you can see that most of the cases were reported. But there is a part, element of consanguinity also. If a patient is consanguineous, it is seen that the population becomes more HLA compliant or HLA homogeneous, and in these populations also TAGVSD has been known to occur. Then if the donations from the family members or first degree relatives is directed towards the recipient, then also this particular complication is known to occur. So in these cases, the transfusion recipient is heterozygous for an HLA type for which the donor is homozygous. So donor will recognize the extra haplotype as the foreign and mount an immune response, whereas recipient will not be able to mount an immune response towards the donor lymphocytes. So even in immunocompetent individual, this particular reaction has been known to occur. So this is again graph from the same meta-analysis. You can see that they actually tried to see in these cases what was the diagnosis in the patients who developed TAGVSD. So one can see that apart from the reasons I mentioned, they found that in majority of the patients, almost 60% of the patients who developed TAGVSD, they had no indication for irradiation. So very little is known about this disease, who can develop and who cannot develop. Earlier it was known that only it will develop the severe variety and these people will not survive. Most of the people who develop this will not survive. But recently it has been said that it might have a spectrum. Some patients do survive, as we'll see. So a lot of these patients who were predisposed or who were susceptible developed, but there were a major group, which did not have any indication for irradiation, and they also developed this. So again, which are the tissues? I have already mentioned that hematopoietic cells are involved, so it leads to pancytopenia. Skin cells are involved, it leads to erythrodermic rashes. Then intestinal epithelium is involved, mainly leading to diarrhea, and liver may be involved, which will lead to hepatomegaly as well as abnormal liver function tests. So this is a picture where a patient developed rashes in his fingers, and this is erythroderma with descaling in a patient in the back who developed TAG-VSD. Now, what is the clinical presentation of this TAG-VSD? So it is a very less known disease because the symptoms will develop from 1 to 198 days. So in some of the patients who were studied in that meta-analysis, they took around 198 days to manifest their symptoms. So at that point of time, even the patient would have forgotten that he was transfused. It's almost 6 to 7 months of time period. So, but the good point is that IQR is 8 to 14. So 75% of these patients will present at 14th day. So if we are vigilant or the clinicians are trained to identify these patients, most of these cases will be caught on time and they may be saved from a certain death. So average of 4 of the 7 clinical features. So these are the 7 clinical features or symptoms which were observed in most of the patients who developed TAG-VSD. So you can see that rash is the most common symptom in 80%, and rash is a quite visible symptom, and it's a very generalized rash. So it is easy to realize this if DD of TAG-VSD kept in cases of rashes in a patient who has received transfusion. So most of the patients in that particular meta-analysis, till 2013, those cases who were reported, at least 4 clinical symptoms out of these 7 clinical symptoms were present in a patient. Only one patient has all of those 7 signs. Rest of them have at least 4 symptoms. And the lethality in most of the cases were observed due to bone marrow aplasia. So it is the bone marrow which led to the death of these patients. And now, when we try to say that this patient has developed TAG-VSD, one has to keep certain DD in mind. So aplastic anemia is one of the DDs because it presents with pancytopenia similar to TAG-VSD. However, it can be differentiated by the fact that aplastic anemia patients will receive transfusion after pancytopenia is developed, whereas TAG-VSD, pancytopenia will occur after transfusion. Before transfusion, there will not be pancytopenia unless the patient has some hematological problems. Then infection can be one of the DDs because in most of the infection, pancytopenia is usually observed. Like even in dengue, we might see that there is some element of pancytopenia in some of the patients. Then a lot of these infections will develop skin lesions in the form of rashes. So there are a lot of infections which may lead to it, such as some notable are viruses like HIV, HCV, HBV, parvovirus, B19. Then some of the bacterial and fungal infections, especially leptospira, is known to present like TAG-VSD. So in a patient who is transfused and presenting like leptospirosis may be kept in a DD for TAG-VSD also. Then these cases mostly can be differentiated by serological testing for infection. So to arrive at TAG-VSD, one has to first rule out these infections because they are more common as compared to TAG-VSD. And then maybe a skin biopsy will help if the patient has skin rashes, because most of these patients will have skin rashes. So skin biopsy is usually diagnostic. Then drug reactions may also present like this. Most of the drug reactions actually result in erythrodermic rashes and may lead to pancytopenia also. Again, there is a temporal relationship to drugs. So the patient would have taken the drug and then the rashes and other changes would have occurred. So the history is very important when we want to diagnose TAG-VSD, and skin biopsy subsequently will be able to clinch the diagnosis. Then liver failure is another diagnosis which is kept in the DD for TAGVSD. So in liver failure, often there is no skin rash or patient will not have pancytopenia in most of the liver failure cases. Then GVSD may be associated with HSCT also. So we have to differentiate it from TAGVSD. Usually when it is GVSD, it will not result in bone marrow aplasia. Whereas if it is TAGVSD, it will result in bone marrow aplasia. Again, the chimerism studies will show that the T lymphocytes, the duality of the T lymphocyte, one type of clone is derived from the donor cells, not from the harvest, which was transfused, which was given to the patient. Now coming to the diagnostic evaluation. So we have to keep the DD in mind and then go for diagnostic evaluation. So the first thing which we do for all the patient is that high level of suspicion. Secondly, we'll do CBC for these patients. We'll eliminate other causes. Here our role comes, because once a clinician suspects that TAGVSD has developed, then they have to communicate to the transfusion facility. Firstly, to know what component was transfused. So if a patient has been transfused FFP, they can actually rule out the diagnosis of TAGVSD. But if a patient has been transfused with other components, then yes, they have to keep TAGVSD in the differential diagnosis. Apart from that, suppose we have irradiated, then there is less chance that the patient has developed TAGVSD and they can focus on other things. So here a communication to transfusion medicine is important if a diagnosis of TAGVSD has to be made. Then we have to go to lab test. So CBC and peripheral smear is important. As I have already discussed in the differential diagnosis, that peripheral smear and CBC would help in differentiating from other causes. Then LFT and RFT is important to see if the patient has deranged LFT and to focus on the diagnosis. Then pancytopenia. So usually in viral serology, pancytopenia will be there, but viral serology will help in clinching the diagnosis if it is viral. Otherwise, one can rule out viral and focus on TAGVSD. Similarly, a diarrhea, mainly diarrhea stool examination is done to rule out infectious causes. So once we have ruled out most of the things, we can say that yes, transfusion may be implicated and go for specific investigation. Then a skin biopsy may be ordered, where you can see that this is bone marrow evaluation. So bone marrow evaluation is mainly done to check for cellularity as well as the presence of abnormal cells. So cellularity, most of the time TAGVSD will be hypocellular. There will be gross hypocellularity along with the lymphocytic lymphohistiocytic infiltrates will be observed. So as a transfusion, mostly we will not be doing this, but we may be able to guide the clinician that they should go and do this and then focus on these particular signs and symptoms. Then a skin biopsy is mostly easy to do and it is diagnostic in cases of TAGVSD. There you can find vacuolization of the basal layers. You can see some of the vacuoles in the basal layer and then histiocytic infiltrate and satellite dyskeratosis. So satellite dyskeratosis is supposed to be confirmatory for TAGVSD when a skin biopsy is done. Then liver biopsy is the another investigation which may be ordered, though this is not quite commonly done in these cases as they are pancytopenic and they may land up with other complications of liver biopsy. So liver biopsy will have pronounced, mostly the bile ducts are involved in cases of TAGVSD. And you can see nuclear pleomorphism, cytoplasmic vacuolization and other findings which are diagnostic to the TAGVSD. Now, based on these findings, if one wants to confirm the diagnosis of TAGVSD, National Health and Safety Network USA has given a case definition for TAGVSD. So those 7 of the symptoms are included in the case definition. If a patient has at least 4 of those symptoms as well as the characteristic histological appearance on skin or liver biopsy, when the symptoms have occurred between 2 days to 6 weeks after transfusion, then one can say that yes, this is a case of TAGVSD. However, if skin biopsy is not done or skin biopsy is negative, then also one can say that it is a probable diagnosis. One cannot definitively say, but we can have temporal relation with transfusion components which were transfused, and we can say that yes, this may be a case of TAGVSD. Finally, one has to demonstrate chimerism of white blood cells which will be considered as definitive proof. So one has to find the donor type WBCs in the recipient of the transfusion to say that it is a confirmed diagnosis of TAG-VSD. Now, what treatment is given? So mostly number of treatments have been tried with very little success. One can see that most of them are ineffective except the HSCT. If HSCT is done timely, then some of these patients can be saved. However, it is very easy to say that HSCT can be done on time. That is because the diagnosis is done quite late, and once the diagnosis is done, to find a donor, to make the donor ready, and then to do the HSCT will take time. So most of these patients will not survive till that time. So I have tried to get that from that meta-analysis data of those patients who were dead and survived, and what therapies were actually done for those patients. So you can see that in the patients who survived and who died, a lot of therapies were done, like immunosuppression, steroids, cyclosporine, IVIG, ATG, and other kind of therapies, including bone marrow transplant. So only when the bone marrow transplant was done, 5 patients survived in case, 3 patients survived out of 29, and 5 patients survived out of 312 patients who died. So bone marrow transplant was considered, was found to be quite clinically significant in causing survival of these patients. Rest of those immunosuppressive therapies were not found to be significantly different in these two groups. So HSCT is something which may save these patients, but it is quite difficult to do HSCT on time in these patients. Now, what is the prognosis when somebody is diagnosed to have TAG-VSD? So prognosis is not good. I think till 2000 it used to be considered that if you develop TAG-VSD, the patient will definitely die. There is no chance that patient will be saved. However, in recent times, the critical care has become quite improved, and a lot of patients have been reported to survive these kind of transfusion reactions. So in most of the time, when we see that meta-analysis, only 8% of the patients have survived till 2013, since publications have started. And death have occurred with a median of around 24 days. The likelihood of survival was higher in younger patients, patients who received leuko-reduced blood, than patients who received products which were stored for longer. Because if in leuko-reduced blood, the dose of leukocytes would be quite less, so the severity of the reaction was not that high. Secondly, when the storage period was high, the viable cells, number of viable cells was less, and so it was hypothesized that because of these, the chances of survival are high in these patients. However, in other patients, the survival rate is quite low. Now, how do we prevent it? So, as a transfusion practitioner, our role comes in prevention, because this is the very good example of the saying that prevention is better than cure. So here our role comes. Prevention is of primary importance in this particular transfusion reaction. Irradiating leukocytes is quite important, because irradiation of these leukocytes will make them non-viable, and because of the non-viable RBC or T cells will not be able to proliferate and cause this particular infection. So to irradiate, specific irradiators come. You can see either it could be a radioactive source or it could be a X-ray radiator, and if it is not there, people have LINAC, then they can use linear accelerators also, although that is a little difficult thing to standardize and to adopt in a routine way. Then we can say that pathogen inactivation has also been considered to be preventive in most of the times. However, for RBCs, there is no pathogen inactivation currently in practice. So platelets and plasma components may be pathogen inactivated, and that may also lead to prevention of TAG-VSD. Though there are no human studies, only animal studies have been done, and they have been found that yes, it can prevent TAG-VSD in animals. And leukoreduction has also been discussed to prevent. However, it is questionable effectiveness as far as prevention of TAG-VSD is concerned. I will show you in the next slide. There are cases where these are some of the cases which are reported to hemovigilance system in UK and France. So they have this was compiled by the Dutch Hemovigilance program. They have tried to see that after introduction of leukoreduction, how many patients actually developed TAGVSD after leukoreduced blood products were transfused. So you can see most of these patients have received. So there were around from United Kingdom, France, Italy. So different countries' data they have analyzed, and they have found that patients who have received non-leukoreduced but LD RBCs, they still develop TAGVSD. So LD leukodepletion or leukoreduction is not going to effectively prevent TAGVSD, though it may reduce the severity. So in at-risk individuals, leukoreduction should not be attempted if irradiation is not there. Now, these are the guidelines for irradiation. So one has to understand that they are for at-risk, as well as there is a duration associated with most of these indications. Like, I'll give you an example of recipient of autologous HSCTs. So they should receive all the blood products which are irradiated, but not just at the time of transplant. So they have to receive irradiated blood products, which should be started 7 days prior to HSCT, and depending on which country we are using, some says indefinitely they should be getting irradiated products. Some say that they should get for 3 months to 6 months of time period after HSCT is done. So for different indications, there are specific time periods also for which the person should receive irradiated products. Like for intrauterine transfusion, once the delivery has occurred, the neonate or the child should receive for next 6 months irradiated products. So irradiation is not only required at the time of IUT, but for the next 6 months after the delivery of the child. So we have to be very clear when we are giving irradiated products, because there are cases where the childs have developed TAGVSD because they were not given irradiated products after delivery. So there were some amendments in these guidelines. BCSH guidelines are the most extensive if one has to follow for irradiated blood products. So in 2020, they amended their guidelines. So their guidelines have now for allogenic HSCT, they say that for 1 year after the last medication, person has to receive irradiated blood products. Similarly, for auto HSCT, 6 months after the transplant has been done. So we have to give irradiated products for such a long period of time. And for fludarabine and other T-cell immunosuppressive treatments, we have to give for at least 6 months after the therapy has been stopped. Previously, it was indefinitely for fludarabine. Now, BCSH has amended these guidelines in 2020 that only for 6 months they should be getting irradiated products. After that, they should not be getting irradiated products. So because this I have put in the presentation because I only showed you in meta-analysis that there were 60% of people who did not have any indication for irradiation, still they developed TAGVSD. So should we irradiate all the units and give to the patients, or should we have selective irradiation protocols? So in countries where, like in Japan, they have universal irradiation of blood products. However, in our country, it may not be very feasible because if you are irradiating, the life of the RBC will decrease, inventory-related problems will come. Then there is a increase in potassium, reduced self-life, hemolysis will increase. So there are certain complications which may increase once we are universally irradiating. It may again be challenging as far as manpower is there and time of the blood product. If you are irradiating all the blood products, the timing of issue of the product will also increase. So it is technically challenging, as well as there are a lot of complications which may arise if universal irradiation is done. So in countries like ours, we can go for selective irradiation. Selective irradiation in the sense that it may we can have hybrid kind of protocols where universal irradiation is done for some of the groups, like for neonates or very low birth neonates or people who are receiving IUTs, and selective for adults such as depending on the indications which are there in those guidelines. So depending on the institute to institute, one can have a hybrid protocol. So like for us, whenever there is a hematology patient or oncology patient, we'll be giving irradiated blood to them, because many a time their diagnosis would not have been reached and they might already be on immunosuppressive therapy. So it depends on the kind of patient one is getting, one can adopt different kind of strategies. So to end, I would summarize that this is one of the rarest complications, which is very difficult to identify and to arrive at. However, suspicion is something which is important in this, and early identification will lead to saving a lot of lives who develop this complication. Prevention is better than cure, and irradiation is very effective in preventing this complication. And identification of at-risk individuals and giving them irradiated products will actually prevent this complication from happening in a lot of patients. Thank you.
Brilliant presentation, Dr. Pandey. Very comprehensive. You have covered every aspect of the GVSD, as well as for other organ transplants where the GVSD is possible. We as blood bankers have to ensure that someone who is receiving irradiated component, how can we be sure that every time we are able to give that irradiated component to the same patient who needs it? Because at times what happens, if we are dependent on the request form for irradiated component, at times the request will be marked as yes. At times when the staff gets changed, they will forget to tick mark that the patient requires irradiated component, and non-irradiated can go to the patient, which will defeat the very purpose. So even if you put this stamp that irradiated product is required, but human error can always happen. If the patient is in the BMT, bone marrow transplant unit, the staff knows it. But if the patient gets transferred to ICU for ICU care, the staff there, they do not know the importance of irradiation. And they may send the request without ticking the irradiated column or putting the stamp. So how can we as blood bankers ensure that the patient receives the irradiated component, even if to cover up the mistakes of the staff in the ward or ICU?
For some indication, we already know, like for transplant, we know that this patient is scheduled for transplant. So as a rule, when we are aware that this patient is for transplant, we'll inform our staff that whenever any product is to be issued, it has to be irradiated. So we ensure that. We had a case where after some 5 or 6 years of undergoing renal transplant, the clinician asked us that you are not giving irradiated products. So we have, we'll scan the barcode and the record will be saved in our irradiator. So we went there, we checked that yes, what all blood products were issued to them. We showed them that yes, they are irradiated. So we ensure that whenever the diagnosis is told, especially where scheduled things are being done. Otherwise, it is quite difficult, sir.
So what we do is, because it involves cost, as per drug controller, you can charge 1,000 rupees for irradiated product. So you cannot put it, give irradiated product unless you speak to the concerned clinician. Yes. So what we do is we pick up the phone, speak to the clinician that is it required, because it seems that the staff has missed tick marking the irradiated product. Because you have to take the clinician into confidence because it involves money. Yes. When it comes to corporate hospital. So that is one. Secondly, we had applied for irradiated components for platelets, red cells as additional sort of for licensing purposes. The licensing authority have approved all the things except irradiated components. So they said not approved. Just because we don't have in-house blood irradiator, but we have got in-house hospital linear accelerator, but they have rejected. We applied for 23 components and procedures additional, except barring the irradiated components, everything has got approved. The license has come. But the reason is not known why they have not accepted the irradiation product.
Maybe, sir, they need to see the SOP.
They need an in-house irradiator.
They need an in-house irradiator.
That is what they need.
Yeah, they can.
Sir, yes. Can I say?
Everything was submitted. Everything was there. So we have applied again.
So it depends upon the drug controller also. But yes. I know the radiotherapy is involved. Even if the radiator is installed in the blood bank, yes, the radiotherapy is hands in glove. They are completely
The radiation safety officer will always
be involved.
The
radiation oncology
yes.
is involved.
Yes.
So hopefully that should work it out. And I think so it's a gradual process. What Dr. Hemchandra is saying, we are also going through the same procedure, yes, trying to convince people. But again, it doesn't happen overnight. And people are understanding. Some hemato-oncology people are very receptive. They understand very easily.
Problem is most of these patients would be sick. So if they develop this complication also, nobody realizes they will anyway be going to die in under 6 months or so. Most of them
don't even recognize the complication.
Yes, that is so they are not even bothered about that this complication is occurring and it may save life. So,
Dr. Anil Gupta.
Thank you very much, Dr. Pandey. So, particularly for the new needs, for the first 6 months of the life, if they have been transfused with irradiated blood, then patient is going to be exposed to multiple donor exposure. We cannot preserve a single dedicated unit. And second thing, there are chances of the hyperkalemia, and we cannot keep all the units
yes, I know.
for a longer time. And there is a multiple unit of waste there. So we are advocating a single dedicated unit for the stable patient in units has to be given. But in case if we are providing, and if it is selectively selective, donor unit can be preserved for the first or second degree.
It's not audible here.
Yeah. We can specifically selectively selective for the blood transfusion from the first or second degree donors for the unit?
That is your policy. See, I am not giving you those guidelines. They are from BCSH or other international societies.
Okay. Because fear of the new.
That is the recommendation. See, I am not saying you follow that recommendation. It is up to you. They are all recommendation and guidelines. They are based on observation that when the patients have received IUTs and if within 6 months, if non-irradiated blood has been transfused, some of those patients have developed this complication. Based on that only, they have recommended. So earlier there was a recommendation that very low birth weight neonates receive irradiated blood products. So they have now gone away with that recommendation because they have realized that they do not develop TAGVSD. Okay. We consider them as immunosuppressed, but they are not. So even in very low birth weight neonates, now they are not recommending irradiation of blood product if you go to BCSH guidelines.
Okay, thank you. So, yeah. And we can discuss later on because yes, I think so everyone is waiting for the lunch now.
Yes, sir.
Yes, sir. In our setup, in Fortis Gurgaon, we are, as a policy, irradiating all our platelets because we do it at night.
Even we do that.
All the platelets in the inventory, they are irradiated at night so that at least, maximum utilization is of RTPs, yes, which is exposing them. And PRBC we do on request. And if we know that this patient is ongoing patient for a treatment because that patient's requests keep on coming for weeks, then we ask and confirm and give it after irradiating only. So that way we are not giving platelets without irradiation to even normal, non-requiring patients as well.
No, even we do the same thing, ma'am, that we will irradiate all platelets, but for RBCs, whenever they request, we will do that. Whenever it is being issued, we don't irradiate and keep those.
Also as a policy, as Dr. Anil, we do not take first blood relations for SDPs. We swap the SDP with some other patient's product and inform the family that we are not going to, give the same product.
We are irradiating 100% platelets, so that does not matter.
No, but the thing is, SDP sometimes is given immediately after preparation and there may not be time for irradiation as well.
No. Okay. That may be chance, but yes.
Sadhana, any comments?
No, thank you, sir. Thank you, sir.
Okay. Thank you, Pandey.
Thank you.
So we conclude this session.
Thank you so much to all the speakers. Well, the sessions were not only informative, but also inspiring, and we are so grateful to all of you for sharing depth of knowledge with us. Now we'll request our session chairs to felicitate our speakers, and we will invite on stage Dr. Nidhi Bhatnagar. Ma'am is here to receive a memento as an immense token of respect and regard on behalf of Manipal Hospitals, Gurugram. May I request Dr. Gopal Patidar to kindly come on stage and receive the token of appreciation from our session chairs. join me in welcoming Dr. Hemchandra Pandey on the stage. It's time to honor our session chairs. We will begin with Dr. Tulika Chandra. Dr. Anil Khetrapal. Now Dr. Bharat Singh. Can we please hear a huge round of applause as we have successfully completed our session 2. And now it's a request to each one of you, let's disperse for lunch, and a good spread is waiting for all of you in the pre-function area. And we will request you to reconvene right after 30 minutes to start the session 3rd. Thank you so much. Let's network over lunch. Happy luncheon networking. On the count of 3, you have to clap a little and you have to do a oh like that. Okay? Works? All right. So on the count of 3. And then the same goes for the gentlemen. 1, 2, 3. Go, ladies. Yay! And now over to the gents. 1, 2, 3. Well, this tells that they have eaten something special in lunch. Now, ladies and gentlemen, it's time to begin our session 3rd. And for session 3rd, we are going to welcome the chairpersons on the stage. To take over the stage, please join me welcoming Dr. Poonam Srivastav, Dr. Nidhi Bhatnagar, Dr. Anju Verma, Dr. Mrinalini Chaturvedi. Let me tell you that this session is fully women empowered in terms of chairpersons. So please welcome all of them with a huge round of applause. Come on. And on behalf of Manipal Hospital, Gurugram, Dr. Sood is right there to felicitate our chairpersons with a floral bouquet. Dr. Poonam Srivastav, she is Chief Advisor, Lions Blood Center, Regional Blood Transfusion Center, RBTC, Northwest Delhi. She is the alumnus of Medical College, Prayagraj. She has a vast experience of establishing and working in government and NGO blood centers. She has been a member of ISBTI, ISTM, AATM, III, DMA, HISI, and has given several presentations and has published a lots of national, international conferences and journals. Dr. Nidhi Bhatnagar, she is the professor and head BJ Medical College, Ahmedabad. She is the NAB accessor for blood banks. Over 40 centers she has assessed as a PG teacher. Reviewer, editorial board for national international journals, member of technical resource group, NBTC, invited as a faculty for national international congresses, conducted many training programs for doctors, technicians, nurses and counselors. And she has also published a lot of papers and publications. Dr. Anju Verma, senior consultant and head, Rainbow Children's Hospital, New Delhi. She has more than 33 years of very rich experience in transfusion medicine, presented a number of papers at both national and international conferences. She's a member of Indian Society of Blood Transfusion and Immunohematology, Indian Society of Transfusion Medicine, Asian Association of Transfusion Medicine, and she is certified assessor at NAB for blood banks in India. Dr. Mrinalini Chaturvedi. She is the medical director, Cryo Viva, India. An experienced healthcare administrator, she has set up the first licensed hybrid cord blood bank in North India at Gurgaon in September 2006. She has steered the organization to attain a leadership and premier position in the stem cell industry with international and national accreditations. Has established cellular therapy services in India, Singapore and Thailand, certified in advanced stem cell culture and biobanking technologies at University of Utah and Da Vinci Biosciences, CA in the USA. Included in top 10 key opinion leaders worldwide in cord blood bank industry. She's been a volunteer international ambassador for AABB cellular therapy session, has delivered invited lectures at national international conferences, and has also researched articles published in international journals. Let's welcome all of them, and now we are going to begin our session 3rd. Over to you, ma'am.
Good afternoon, everyone. We are going to start our session, which is going to be very interesting. I invite Dr. Tulika Chandra, who needs no introduction. She is professor and head, Department of Transfusion Medicine, King George Medical University, Lucknow.
She is president of UP chapter of ISBTI, and she has published several national and international publications. She has also published book and book chapter, reviewer of many journals. She has delivered numerous guest lectures, organized many CMEs, seminars and conferences, conducted many training programs. She is technical expert of State Blood Transfusion Council, expert in many inspections of state blood banks, received many awards, and the first one to start NAT testing in UP and pathogen reduction in Asia. She has established the first plasma bank in Uttar Pradesh. Welcome, Dr. Tulika.
Thank you, Dr. Anju, for the introduction. And first of all, I would like to thank the organizers, the Manipal team and Dr. Rashmi Sood, who have taken the pains to establish such a wonderful CME and connected all the Delhi people together under one forum. So the topic today on which I'm going to speak is granulocytopheresis, that is when, how, and why. Somehow, we are not doing much. We've done few cases, but not much. But still, it's interesting, you know, because this is an area where we need to proceed. Blood banking has to proceed by leaps and bounds. It cannot remain static at one place. So unless we explore new areas and also gain experiences from people, some people who are doing it, so that it spreads far and wide. So first of all, I think so you all know what is a granulocyte, neutrophil, eosinophil, basophil, but we're really talking about the neutrophil because that is the most abundant. That is the majority of the decision, that is the neutrophils, and that is why when we talk about the granulocytes, we are mainly talking about the neutrophils, that is the polymorphonuclear neutrophils. And I think so this is the physiology which you all know is that how this works, so the neutrophils works and what is the factors, and that's why they're used and we need it. What is the need? So when we talk about granulocytopheresis, I don't know how many of you are doing it. I know Dr. Khetrapal is doing it, Dr. Sangeeta. Okay, 3-4 people who are doing it, Dr. Kamini. So that's great. I think so most of you can share your experiences also because my topic is mainly going to be theoretical because it's an area which we're not doing it hands-on that much. We've done only about 3-4 cases of granulocytopheresis. And so granulocytopheresis, it produces a product of concentrated neutrophils using apheresis technology. And they're used to treat neutropenic patients with infections which are not responding to antibiotics. So our main stakeholder in the clinical department is the clinical hematology department. And you know, just now what was happening is that they find the patient, then they say, well, they find the donor, and then they say, well, this donor needs granulocytopheresis. One thing we've tried to establish, see, apheresis is also being shifted to the clinicians, which is wrong. We are licensed to conduct the apheresis. The apheresis license is given to the blood banks. It cannot be given to a clinician. And somehow because of the ignorance or maybe because of lack of persuasion, the stem cell pheresis, the granulocyte pheresis, the clinicians are taking over and excluding the blood banks. So just now we need to have our holes into this area so we can retain this area which is legally ours. So that's why we need to go and discuss on this topic. I think so that's the relevance. We should realize it's not theirs, it's ours, and we have to be a part of it. So again, all machines, I think so, don't have granulocytopheresis capabilities. So we need to select the ones which have the best results. And what happens, the donors will be screened for a physical examination and the medical history that we take for a regular donor. And the initial blood test will be done to check for the eligibility. And now you realize these people are going to donate granulocytes, so their TLC counts will not be within normal range. It's going to be really high. And most of the time, it goes against that upper limit in the cell counter, and we are not able to see it also. So it has to be done in a systematic manner. And I went through the literature, and there were very varied opinions about how many times a person can donate granulocytes. So I just discussed with Dr. Khetrapal, and he said there are no regular guidelines till yet, because when there's a new area, the guidelines are not decided. There are areas where a person thinks this can be done, this cannot be done, based on our experiences. So we are in the area of that formative stage. We really don't know what is right, but again, we've got cases, a case in which the same granulocyte donor, I think so, one of my residents is over there, it was the same donor who had 2 sessions of granulocyte apheresis within a period of, I think so, few days. So that is feasible. Again, the decision is with the clinical hematology department. But this is the time we need to go ahead, understand things, and gradually take it over from them. So at least we are given the credit of our work, instead of they using us just as a technician or a blood banker. And white blood cells are collected through the apheresis machine. And the apheresis procedure, as you know, it lasts for about 2 hours. And you know, the basic, what we do is we just do the procedure, because according to the norms laid down by the protocols or the recommended guidelines, and give the product to the clinicians, go and transfuse it. So now I think so we should go one step ahead. Let's see, we are going to give it to a patient. First of all, we should know all the details of the patient, whom we are going to transfuse for what. And again, our aim is to give him a proper therapeutic granulocyte dose, so he ultimately benefits. And we should be the people giving inputs, how to do it the best. Because the maximum they can put is a GCSF and dexamethasone. They can prime the patient, donor with him. But ultimately, we have the settings in our machine. So we have to take an initiative somewhere. Because what happens is, usually the clinicians do this, they pre-medicate them about 12 hours before with GCSF, as well as about 4 hours, 12 hours again with dexamethasone, and again at 4 hours. And the purpose of this is the release of marginated granulocytes from the spleen and major blood vessels. And this increases the peripheral blood granulocyte count before donation. And so higher peripheral granulocyte count results in a larger granulocyte collection. And basically that is our aim. We want to give a good concentrated dose of granulocyte to the patient so that he benefits, and the number of frequency of the granulocyte apheresis donations decrease accordingly. The pre-medication, the dosage of it is GCSF is 5 to 10 microgram per kilogram, which is given subcutaneously 12 hours before the collection procedure. And corticosteroids are usually given as prednisone or dexamethasone. And the latter is given as a dose of 8 to 12 milligram, depending upon the donor's weight, at intervals of 4 and 12 hours before the collection procedure. And we can give a uniform dose of 450 microgram of GCSF coupled with 8 milligram of dexamethasone. Both are given 12 hours before collection, and it has been shown to be as effective as larger combined doses. Again, when we do this procedure, the major issue is the contamination with RBC, because the density of the granulocytes and the RBCs are quite nearby. They're not as different as the platelets and the plasma. So we have to remove the RBC contamination, and due to many issues, because we may find an ABO-compatible donor, we may not find an ABO-compatible donor, because the RBCs in the granulocyte products must be compatible with the recipient to avoid the possibility of acute hemolytic transfusion reaction, and we really don't want it. So we need something to sediment the RBC and remove it from the granulocyte preparations, and that is why HETA starch is used. That is why the HETA starch, it is used because it is a Rolex-inducing agent, and it is widely used because it yields higher granulocyte results, and it is less rapidly cleared from the body, and it collects in the extravascular space, so there's a side effects such as headache, edema, fluid retention. And so in repeat donors who donate regularly, we'll try decreasing the dose of these HETA starch as compared to those who donate or a single time well that it is, because regular donors will have more accumulation and they'll have more severe side effects, and the agreeable and the consent will decrease and they will get demotivated. And usually the granulocyte apheresis donors are prescribed small doses of corticosteroids, and this affects the mobilization and improves the pre-collection. And again, uncontrolled hypertension, diabetic mellitus, and peptic ulcer disease. We should always screen them before conducting the process of granulocyte apheresis. This is, I'm talking about the donors, because giving them these medications will aggravate the disease, and we don't want any problems during the procedure. So maybe it's our responsibility, no matter what the clinicians say, to go ahead and know whether they are suffering from this disease. And then the counseling should occur. We should tell the donors that because of these medications, they may have headache, elation, sleeplessness, or nausea after injection. It's not due to the apheresis procedure. Because that is the most natural tendency. When you have this, you blame, I had this procedure, and that's why I have all these problems. And the more common side effects of GCSF are bone, joint ache or pain, muscular ache or headache, and the pain is usually mild to moderate and generally relieved by NSAIDs. I'm just telling you about these complications just to say, well, these are because of these medications, not due to the apheresis, as usually the donors correlated with the apheresis, and they complain that it's because of the apheresis and they have a problems and they did not do the procedure well and so on. And really the reports of rash, nausea, infection at the injection site, allergic reactions, worsening of pre-existing inflammatory and immunological disorder symptoms in patients with underlying coronary artery disease, low platelets, blood clotting, and so on. But no long-term side effects of GCSF in normal donors have been reported till date. They're all temporary. So the challenges of granulocytopheresis is these products should be administered at least daily to an adult patient to achieve a physiological dose. And this must be repeated for a number of days. And then you realize doing every day and finding a donor every day or having the same donor every day is a very difficult task. It is not really possible, and that's why the requirement, it creates a serious logistic problems. We have so much problems in finding a same group SDP donor, in whom the eligibility criteria is much easier as compared to that. So then you can realize a granulocytopheresis donor, it's so difficult to find one, and having it every day for the same patient is another logistic problems, and that's why maybe it's not so popular as it should be, because it's not being practiced all over because of these logistic issues. And again, the cost involved is also there. And another thing is we are giving better antibiotic therapy because it's mainly given for the immunosuppressed patients. We want to give them the granulocytopheresis. And because of the new development of new antibiotics, maybe they can control the infection better. And that is why, which is easy to get as compared to the granulocytopheresis donors. And that's why maybe the functionality of this therapy has decreased. Again, when I say we'll talk about the granulocyte transfusion, this is from the clinical viewpoint because that is one thing we were talking about our procedure. The next thing is let's see about the patient also. Which patient needs it? So that we can also be a part of the system where the decision is taken to transfuse a patient as well as the side effects are noted. So this is called the granulocyte transfusion, and it is done usually in the cases of neutropenia, which you all realize why. Because the challenges, again I said, the stimulation with the mobilizing agents and the time consumed in donation is much more for a granulocytopheresis donor. An ABO-compatible donor is very difficult to find, and the removal of red blood cells before transfusion overcomes these obstacles. But again, if you have a little contamination in the procedure, it can cause acute hemolytic reaction in the patient. So we really have to be careful about it. So therapeutic granulocyte transfusion is indicated for patients who fulfill all the following criteria. Severe neutropenia, which is defined as ANC less than 0.5 into 10 to the power 9 per liter, due to congenital or acquired bone marrow failure syndromes, and those who are receiving active treatment in an attempt to achieve the disease remission. See, we do it only in cases in where there's a hope. Just having a neutropenia doesn't mean they need a granulocyte transfusion. Proven or highly probable fungal or bacterial infection, which is not responsive to the antimicrobial therapy which is available. And another case in where neutrophil recovery is expected in the near future. If there's a hope that they're going to have neutrophil recovery, we are giving the granulocyte infusion as a temporary measure to combat the infection. And maybe when the recovery happens, they have their own granulocytes, the patient has its own granulocytes and takes over. And again, patients with known congenital disorder of neutrophil function. The contraindications are, it should not be given for therapeutic use where there's a bone marrow failure when neutrophil recovery is not anticipated. Now, you know, this is a case of pancytopenia and there is no chance it will recover. There's no use of giving granulocyte transfusion because it cannot be done on a regular basis because of those challenges and logistics problems. So you should have an aim in order to benefit the patient. If there's a sepsis, but in the absence of either neutropenia or no neutrophil dysfunction, there's an infection, and you don't want to give neutrophils to combat that infection, so means there's some other cause, a granulocyte transfusion is not required. Pyrexia of unknown origin, and viral infection in the absence of additional approval on highly probable fungal or bacterial infection, which is unresponsive to appropriate antimicrobial therapy. These are contraindications of granulocyte transfusion. So the modern therapeutic granulocyte transfusion, the indications are at least 400 milligram GCSF is given subcutaneously, plus 8 milligram dexamethasone given orally to the donor approximately 12 hours before the leukapheresis is begun. And HETA starch is infused throughout the process of leukapheresis at a ratio of 1 part starch to 13 parts starch to donor blood. And processing of 8 to 10 liters of donor blood, wherein the granulocytes are collected by the centrifugation methods, which we all know about. Again, the granulocytes which we obtain are stored at 22 plus minus 2 degrees centigrade, ideally without agitation. That is one thing we know, because there's a lot of confusion how to store them, where to do them. And once when we started this granulocyte transfusion, in fact, I was also confused why should we store them and whether we will retrieve them. But somehow we came to this consensus. And granulocytes, they must be irradiated to prevent transfusion-associated graft versus host disease, which Haim talked about just now, because that's the optimal way if you have the facility. And all testing for mandatory microbiological tests must be completed before granulocytes are issued. We do those HIV, the markers and everything. They're not exempted because it's a donor and it's doing a granulocyte transfusion. And the granulocytes expire at midnight the day following donation. That is, the shelf life is only for 24 hours. So it has to be done where it is really needed. Now, when we talk about the compatibility of these granulocytes, they should be ABO compatible with the recipient's plasma and cross-match compatible by immediate spin. We don't need a detailed cross-match. We just need a minimal cross-match for these granulocytes of the blood with the donor. And ABO compatible for the ABO antibodies in the donor against recipient antigens. Why? Because we don't want a rejection. That is a low titer for anti-A or B if the group O granulocytes are provided for A, B, or AB recipients. And the Rh negative granulocyte should ideally be provided for Rh negative people of childbearing potential. Again, a very difficult prospect, as you all realize, finding an Rh negative donor, and that also ABO compatible, and especially for a woman who's of a childbearing age group. That is the recommended one. And more extensive matching is not required. And those who are CMV negative, ideally we should be provided for recipients who are at risk for CMV negative disease. And the dosages, like again, 2 into 10 to the power 10 polymorphonuclear neutrophils per dose with corticosteroid stimulation, 4 to 8 into 10 to the power 10 per dose with corticosteroid plus GCSF. And it should never be less than 1 into 10 to the power 10 neutrophils per dose. And transfusions are continued daily until the infection has resolved. You control the infection, now stop the transfusion. Let the person's independent immune system take over it and maintain their own leukocytes, or until the PMN levels rises about 0.5 into 10 to the power 9 per liter. And average dose of pediatric age group is about 8 into 10 to the power 8 polymorphonuclear neutrophils per kg body weight. How to do the administration is, the larger number of cells transfused results in higher increments, which is very common. Obviously, if you give a larger number of cells, you do lose some in between, but then the increments are always better. But we have to be clear that they are not HLA alloimmunization, because then our whole exercise, it loses its interest. And it should be transfused as soon as possible within 6 hours, even though its shelf life is 24 hours, but the transfusion should be done within 6 hours. And it should be transfused to a standard red cell giving set over 1 to 2 hours. And infusion should be given until one of the following events. We've achieved this aim. We have a clear evidence of endogenous recovery. We know that the person's immune body has taken over, and now itself has its own neutrophil count, and we now need not give him those granulocyte transfusion. The infection has resolved, and the clinical deterioration, despite a minimum of 3 days of transfusion, that means he's not responding to that granulocyte transfusion. So why give him again and again? And severe reactions occur to these granulocyte transfusion, then we have to stop them and not give them again. And granulocyte concentrates who are collected from healthy donors who are not stimulated with corticosteroids will contain only about 10 to the power 9 and 10 to the power 10 polymorphonuclear neutrophils. That is about 1% of the healthy marrow output. But if they are stimulated and given the 2 drugs, obviously their quantity will increase. And now talking about the HLA compatibility, that is another issue we have to keep into mind, because the patients with evidence of alloimmunization should receive granulocyte transfusion from donors selected to be leukocyte compatible by HLA matching. That is important. We'll discuss why, because they found that these polymorphonuclear neutrophils who fail to reach sites of infection in 78% of alloimmunized patients. Now realize that whereas localization of these neutrophils was normal in non-alloimmunized patients. So the whole purpose of that our exercise is lost. And similar findings were reported where there were reduced recovery and circulating half-life in some alloimmunized patients. Irradiation of the products is very essential in the presence of HLA identical or haplo-identical, which we've already discussed. And again, we talked about the challenges. Infections continue to cause significant morbidity and mortality in patients with neutropenia. We are all aware at some point of time, maybe in our relatives, friends, we've lost people, we faced challenges where patients had neutropenia and could not be controlled, and who have undergone intensive chemotherapy and hematopoietic stem cell transplantation. Cancer is so common nowadays, and the side effects of chemotherapy are equally common. And they're not unheard of or not diagnosed as previously they were. And in such cases, granulocyte transfusion comes to rescue. Meanwhile, patients develop immunity preemptive granulocyte transfusions are successful in preventing post-hematopoietic stem cell complications. And the short shelf life creates an urgency because of the need to recruit a donor every time a transfusion is planned. I think so that's a major issue we have. ABO-incompatible donors can thereby be safely accepted by using the techniques where we do it separately and find there is no contamination. Because the biggest challenge, which I think so, is because of these transfusions, is that finding a donor who's appropriate and getting the granulocyte transfusions done, donations done at regular intervals. And the conclusion is, it is it's indicated mainly in neutropenic patients following intensive chemotherapy. ABO-compatible transfusions are preferred, and they should have an adequate polymorphonuclear neutrophils because they're exposed to the risk, but let them get the maximum benefit they have. And again, we need to do more RCTs to establish the general effectiveness of granulocyte transfusion, especially since we are in the process of discovering more and more potent antibiotics with time. So that's why I think so it has not gained that much popularity all over the system because of these challenges. But again, we need not think it's not doable because some people are doing it. And I think so this is a good area for our branch to go into because a person who is doing it clinically may not have that much time or orientation to get into it. But if you get into it and get clinical inputs and give them clinical inputs or your inputs, because they are dependent on you, and maybe we may take these regime forwards and develop a new modality in our transfusion medicine. Thank you.
Thank you, Dr. Tulika. Very comprehensive talk. I think you've covered everything, and there are challenges, but let's see how we can. Any questions? Yes, Doctor.
I think you have covered it very well, extremely well. As regards the dose is concerned, like we have to have the adequate dose all the time, and it should be close to like 4 to 5 into 10 to the power of 10 per yield. We can also calculate the dose as per kg body weight also. And that dose will be as 10 to the power of 8 if we are giving as per kg body weight. Besides therapeutic use of granulocytes, even prophylactic use of granulocytes is there. Like when we are dealing with a case of delayed engraftment of neutrophils. In that case, this could be given in addition to GCSF. Granulocyte transfusion could also be given to expedite the engraftment, neutrophil engraftment. That could also be. In an emergency, when donors are not available, we can also resort to the Buffy coat-derived granulocyte concentrate, in which case we expect a dose of 1 into 10 to the power 9 per bag of the Buffy coat. So in case if we are collecting 8 to 9 bags, we can expect a dose of close to 1 to 10 to the power 10. So that should meet the criteria. In that case, we have to have the same group donor or compatible donor who is AHG cross-matched. The irradiation is done, and we are not doing pooling, but we are issuing it separately, giving numbers of each bag. And that's how we are doing it.
So I think so these inputs are very important from Dr. Khetrapal's point of view, because we have to find a way out for everything. And he's given a very good way out that we can use the Buffy-coated leukocytes and then give it and measure it in an individual way. In that we can retain the sanctity of the blood bank, benefit the patient, as well as be a part of this therapy. And prophylactic transfusions, maybe we can use it also in the cases of entrapment, so we can rope in more departments also.
And as regards the like other departments taking over apheresis, like I am a part of the credentialing and privileging committee at the hospital. So all the specialists like oncologists, hemato-oncologists, they are all trained, most of them are trained at AIMS, and they all have undergone sort of apheresis. They have done apheresis. And when they join the hospital, they want apheresis to be done by them. So being a member of that committee, I put my foot down that this is against the law, will not permit that. So it is accepted. So we don't allow them to sort of use.
So the take-home message is, please retain the apheresis with you. Otherwise, the clinicians will take it and we will not be able to fight it.
Just one question, Dr. Tulika. Very wonderful presentation, comprehensive. What are the experience in neutropenia due to sepsis?
Basically, we've done this granulocyte transfusions in transplant cases, the bone marrow transplant cases. And they did not have sepsis. So what I understand is, if sepsis, which is respondable, it is not responding to antibiotic or nothing, and only then we can give it to them. If the sepsis is there and there is no neutropenia, then there is no indication.
No indication.
Then there is no indication of granulocyte
neutropenia with chances that the own bone marrow of the patient will.
Yeah, because we need to give that much neutrophils in order to combat that infection, which is present.
I don't know whether Dr. Khetrapal has this experience.
In case of febrile neutropenia, where the patient has got sepsis, in fact, that is the indication for giving granulocytes. That we have tried the best of antibiotics, the best of antifungals, still the absolute neutrophil count is less than 500 per microliter. In that case, yes, we can try giving a granulocyte.
And I think this will be a growing indication, sir.
Yes, yes.
Yeah.
Thank you.
Thank you, Dr. Tulika. So I invite our next speaker for this session, Dr. Amardeep Pathak. He's consultant and head Department of Transfusion Medicine, Rajiv Gandhi Cancer Institute and Research Center, Delhi. He has 12 years of experience, 18 publications, special interests in the field of apheresis and therapeutic apheresis, peripheral blood stem cell collections, granulocyte collections. He's Chairman's Appreciation Award on the 21st Foundation Day. He received award for outstanding performance on the 20th Foundation Day also of the Institute. Over to you, Dr. Amardeep. He's joining online.
Yes, and Dr. Rashmi for the invitation. The given topic to me is LDL apheresis. It's all about LDL apheresis. Sharing option is not there.
Can someone help? He's not able to share. No, you click on the green button.
Yeah, I'm clicking there.
Not here. I mean on the green button. Share button. Niche.
Yeah, I'm clicking on share only, but the presentation is not there.
Not the arrow, just on the green button. Do you have his presentation?
No, I'm sharing with my...
No, this is something else has been shared. You open the presentation first and then you come back on this. You can close this. This is something else has been shared. Dr. Amardeep, can you close this?
Yeah.
Just click on the green button. Green button. No, 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 no. No, no. Share green button.
No, I think it
Yes,
is there.
yes, yes. Now you can put it on full screen. Yes. It's visible.
Yeah. Okay.
Yes.
Sorry for the interruption. So start with LDL Apheresis. I planned my talk in these headlines. So the background about the therapeutic apheresis and the familial hypercholesterolemia. The few slides about genetic pathogenesis and the clinical consequences. About LDL apheresis, about definition, guideline recommendations, and their types. Few slides about LDL apheresis in children, and the LDL apheresis safety and the cost, and finally the conclusion about the topic. Let's start with therapeutic apheresis. It started way back in 1952. First time for the treatment of multiple myeloma and the hyperviscosity patient. Now it's modified to therapeutic plasma exchange. And the first long-term plasmapheresis was reported in 1980 for the hypercholesterolemia in 2 patients by Kane Center colleagues. Since then, the technically sophisticated machines are there with safety and efficacious technology to allow the procedure safe, easy, and their improvement in these apheresis machine allowed faster, convenient to the technical staff and the safety for the patient. Dependent upon the machine we are using and the development like less extracorporeal volume, priming of the tube with the fluids, close monitoring of the patient, it made possible to use the therapeutic apheresis in children as well. So now, it is established therapy for the pediatric neurology, nephrology, hemato-oncology, intensive care medicine, and the gastroenterology. From last 10 years, therapeutic apheresis also has been increasingly used for the treatment option of pediatric lipid disorders. LDL apheresis provides safe and effective means of treatment in familial hypercholesterolemia. It also has a role in preventing progression of coronary artery disease in both heterozygous and other serious dyslipidemias, which is intolerant to conventional drug therapy. LDL apheresis involve either based on these methods are based on absorption or precipitation. In each of the technique or the method, the first they separate plasma from the other cells. More recently, a direct method of the LDL apheresis are discovered. They directly absorb the LDL cholesterol and the lipoprotein from the blood using polyacrylate columns. All methods are similarly efficient. Either they use weekly or bi-weekly to lower the LDL cholesterol and the lipoprotein without harming the beneficial cholesterol. But yes, their economical constraints restrict the use of LDL apheresis treatment of familial hypercholesterolemia because it required lifelong treatment. A few slides about familial hypercholesterolemia. It is a genetic autosomal dominant disorder, which caused by several mutations in the LDL receptor genes and several other genes, which if there is a reduced number of LDL gene or absence of functional LDL receptor, that result in impaired hepatic clearance of circulating LDL cholesterol, which finally lead to a higher level of LDL cholesterol in bloodstream. It's also characterized by a deposition in the tendon, arterial wall, early onset of atherosclerotic and premature cardiac death. It occurs in 2 forms, heterozygous and homozygous. Out of 2 heterozygous, familial hypercholesterolemia is a more common in general population. There are 2 accepted clinical diagnostic criteria First is the Simon Broom from the United Kingdom, and the second is Dutch Lipid Network criteria from the Netherlands. These criteria are including cholesterol level, the clinical history, the physical science, and the family history. The definitive diagnosis can be made on the basis of DNA-based mutation screening. Coming to genetic pathogenesis of familial hypercholesterolemia, the LDLR gene is the important one, accompanying with the other genes. If there is dysfunctioning or no functioning of the LDLR gene, its activity is gone down and finally lead to familial hypercholesterolemia. The main metabolism of the lipid happens in liver. So the other genes tend to collaborate with the LDR gene. They block their activity. So statins or other gene inhibitor remove the binding nature of the other genes. So more and more LDL cholesterol we can recycle, and LDL apheresis can be beneficial to the patient. All patients who are having these kind of a mutation display findings like very high LDL plasma concentration, fat deposits in typical locations like tendons, we known as xanthomas, around the eyes, known as xanthelasma. Elevated LDL is mainly responsible for vascular disease and premature coronary artery disease. Early detection is very important, so the early treatment can start in the childhood only. In general, clinical consequences of the coronary artery disease is not manifested until the adulthood, but the children with severe familial hypercholesterolemia can present early with a symptom of endothelial dysfunction or thickening of the arterial wall. Currently, statins are used for the treatment of familial hypercholesterolemia either alone or with other medicines, but if there is complete lack of LDLR or receptor gene or receptor dysfunction, statins have no effect at all. These are the few guidelines and recommendation. This one is from the Heart UK working group for the apheresis, LDL apheresis. The indications are homozygous familial hypercholesterolemia, a compound heterozygous familial cholesterolemia with other lipid disorder, or heterozygous FH with coronary artery disease or refractory to conventional drug therapy. Threshold is for homozygous or the compound heterozygous is if LDL cholesterol is more than 350 mg per dl. In heterozygous FH, the LDL cholesterol is more than 190 mg per dl with ineffective drug therapy or refractory to drug therapy with coronary disease. Frequency can be weekly or bi-weekly. The main target should be reduce the LDL cholesterol by the 60%. American Society of Apheresis, almost same indication, but the threshold for homozygous familial hypercholesterolemia in unresponsive drug therapies, LDL cholesterol should be more than 500. In heterozygous, it should be more than 300 without coronary vascular disease. If there is existing coronary vascular disease, the LDL cholesterol should be 200 mg per dl. Again, it can be bi-weekly or thrice weekly. Target reduction is more than 60%. Same Japanese national guidelines, homozygous with children 4 to 6 years old, treatment refractory to conventional drug therapy. It's used as a first line drug treatment of choice for the children 4 to 6 years of age, along with statins. Frequency again weekly or bi-weekly. Now coming to LDL apheresis, it's alternative to plasma exchange, but it is more selective, and it only remove LDL cholesterol or other atherogenic lipoprotein and saving the beneficial protein and beneficial cholesterol. In 1975, Dr. Paul Newman from the Quebec, Canada, was the first scientist to develop and clinically apply this method for the LDL cholesterol elimination with the principle of LDL binds to negatively charged heparin. There are several commercially available methods for the LDL apheresis based on immunoabsorption, dextran sulfate absorption, LDL hemoperfusion, membrane differential filtration, and heparin-induced extracorporeal LDL precipitation. We will discuss a little bit in a detail, but by and large, heparin-induced extracorporeal LDL precipitation is the most commonly used method. Again, this is the same methods of the table. This slide is very exhaustive, containing various retrospective and prospective studies. The gist for this slide is they have measured the outcome on the basis of laboratory and clinically. On an average, by laboratory outcome, after the apheresis, the mean reduction of lipoprotein or the lipoproteins or the LDL cholesterol, they have gone down to 70%, and clinically they measure the major adverse coronary event after the apheresis treatment. They have gone down to, on an average, 80% in each of their studies. Similar to plasma exchange, familial hypercholesterolemia patients require lifelong therapy. The LDL apheresis is encouraged to start as early as possible, usually start at the age of 5 or 6 years of age, before the establishment of the atherosclerotic or any CAD lesions. Frequency, it can be weekly, bi-weekly, or dependent upon the level of LDL-C, cholesterol, and severity of the coronary artery disease. Typically, in heterozygous FH, patient require every or bi-weekly treatment. In homozygous, it requires every 7 days. The frequency of LDL apheresis mainly based on two factors: acute reduction of LDL cholesterol and the time average LDL cholesterol concentration. Both can be measured, and the LDL cholesterol can be measured by pre and post treatment difference, and the TST is based on the treatment frequency and rate of rebound of LDL cholesterol treatment in between. Generally, TAC is more insightful because it reported less frequently. LDL apheresis should be used in conjunction with other lipid-lowering statins or medication with the dietary therapy, because it reduces the plasma cholesterol level so efficiently, slow the post-treatment rebound of the cholesterol, and prolong the interval between the LDL apheresis sessions. So less or less LDL apheresis session can be done for the patient. To start with double filtration LDL apheresis, in this procedure there are two types of membrane. The primary membrane separate the plasma from the cells, and the secondary membrane remove the macromolecule like LDL cholesterol and the lipoprotein, but the pore size limitation is there. It is less selective. The disadvantage of this method, it is less selective, because apart from LDL cholesterol and other lipoprotein, is also reduce the large beneficial plasma protein like HDL, like IgM or fibrinogen. The one more disadvantage is the secondary membranes is tend to clog, so less plasma recycle, or the plasma volume is less to be treated. Now a newer cascade flow system is there, and it is beneficial in preserving the HDL and other immunoglobulins. This procedure is currently used in most of the German children dialysis centers in the LDL apheresis. The second, immunoaffinity adsorption based LDL apheresis is using dextran sulfate. After being plasma removed from the cells, plasma is passed over the column containing the negatively charged this dextran sulfate, and all positively charged lipoprotein, VLDL, LDL get selectively removed with this method. The disadvantage of this method is it activates the coagulation system and increase the bradykinin level. So patient on S inhibitor is not suitable for this method, and it is contraindicated in them. The another immunoaffinity based absorption is the Therasol LDL system by Miltenyi Biotech. It uses saffrose beads instead of dextran sulfate, and the process is same. The negatively charged saffrose removes the positively charged LDL, VLDL, and lipoproteins. Again, the disadvantage, this leaching of sorbent from the column, it produces a febrile or anaphylactic reaction, and again, it's again contraindicated with the ACE inhibitor. The most commonly used method is heparin-induced extracorporeal LDL precipitation method. Again, plasma removed, and then this plasma is combined with the heparin and acetate buffer to lower the pH of the plasma. And then this plasma, this heparin makes the complex with the LDL and lipoprotein. And after adding the buffer, it can be absorbed from the plasma. There is no indication, no contraindication for ACE inhibitor. This system has a three component: a plasma securer system, the HELP filter of set of 4, first only single use system, and helpline system. This is the pictorial depiction of the HELP process. Again, the plasma removed from the blood, the cells gone down to the patient. The mixture of sodium acetate buffer for the lowering of the pH, lipoprotein with the complex made with the heparin, and this columns later can be discarded. The residual heparin is removed from the LDL-free plasma by the heparin absorber, and finally the buffer we can use for the physiological stable the condition, and by the ultrafiltration can be done to correct the volume. The direct absorption of the lipoprotein use immunoaffinity system or the columns as a polyacrylamide immobilized beads. Again, this negatively charged ligand lead to activation of bradykinin and rapidly broke down by the ACE inhibitor, and it is contraindicated to this kind of a patient. The few slides about the lipid apheresis in the children, both homozygous and compound heterozygous forms are indication for the lipid apheresis in the children. In children, mainly the full defect of the LDL receptor genes are there. It is used with a drug therapy as a first line treatment. The target is the LDL cholesterol should be less than 135 per milligram per dl. But a few children can achieve those targets because of delay in diagnosis and lack of monitoring and treatment for the underlying reason. Early treatment is the key. Screening should be done as early as 2 years of age, having with the point in considering a family member present with the FH, a plasma cholesterol level is more than or equal to 310 in adult and 230 in child, and the presentation of premature coronary heart disease, tendinopathies, and sudden premature cardiac death. So these are the fat deposition before the treatment of LDL apheresis, and now after apheresis the deposition you can see it's gone. Same with the fat deposition is nil, and this is before treatment and this is after treatment. The specific technical requirement in LDL apheresis in children, mostly like other apheresis what we are doing in our centers, or all of you can correlate with this. The peripheral lines are not suitable because we need a high blood flow for the procedure. So because and one more thing is important, that they require a long-term apheresis. So AV fistula and a double lumen central venous catheter should be used as a vascular access for LDL apheresis. Extracorporeal volume should be taken into account when we are planning LDL apheresis in the small child. Depending upon the machine what we are using, it can be ranged between 100 to 400 ml. adult patient can easily tolerate the transient volume, but the children cannot that much tolerate the volume loss. Anticoagulation, the sodium citrate is the best because it's exclusive effect of extracorporeal circuit, so it's not a systemic bleeding or systemic complication is there, but transient hypocalcemia is there, so we can counter by the IV calcium or the oral calcium we can give. Another anticoagulation can be achieved by heparin, but it has a systemic complication and risk of bleeding after the procedure. Coming to safety, in general, it is well tolerated and safe procedure. Most common side effects are hypertension and nausea, vomiting, serious kind of hypertension and allergic, and there are few cases reported regarding the vascular side complications like central line infection, puncture difficulties, technical problem, and other vascular access. Coming to cost, yes, it's a costly procedure and typically range between $1,600 to $2,700 across the countries in the world. Study says Germany and France having the lowest LDL apheresis cost, and United States having the highest maximum cost of almost $4,400. In considering this mind, indicate that annual LDL apheresis treatment cost are substantial because it requires frequent sitting. Coming to summary, to conclude this talk, it's a very well established and well tolerated and safe procedure for blood purification in adults as well as in the children. Effective treatment of familial hypercholesterolemia should be started as early as possible in the life. The choice of drug treatment as well as the intensity and frequency of LDL apheresis depend on the underlying mutation like LDL receptor mutation or other gene mutation, and must be modified until the optimal result has been achieved. Due to the very time-consuming therapy, it must be chosen in a way that creates as little stress as possible for the patient, especially in the children, and psychosocial support must be offered. Thank you.
Thank you for that very insightful presentation on LDL apheresis. Especially in a country like ours, where hypercholesterolemia is becoming a huge problem, this seems to really impact the morbidity and mortality in these patients. And you brought out the challenges in management, especially in pediatric patients. So I think, except for the cost, this is a very good modality and brings a lot of hope in treatment of these patients. Thank you for that wonderful presentation. I think
Thank you, ma'am.
Questions. Dr. Nidhi has to leave because she has a flight. So you want to say something?
No, thank you. It was a very nice talk, and I'm sorry I
Thank
have
you,
to
ma'am.
leave, but it was, thank you, Dr. Rashmi. It was indeed a pleasure coming all the way. It was from Ahmedabad. It has really been fruitful. So please continue.
We would like to acknowledge and would like to give our heartfelt gratitude to Dr. Nidhi Bhatnagar. She prepares for her depart now. Thank you so much, ma'am, for taking out your precious time and being a part of the CME. That too in the Janmashtami week. So, ladies and gentlemen, please put your hands together for Dr. Nidhi Bhatnagar. She has been a fantastic speaker and an amazing moderator. Most welcome.
So I think I'll open the house to the any questions, please.
I'll just
Dr.
like to
Amardeep
add.
is with us. Dr. Amardeep.
I'm there.
I'll just like to add, we have done this LDL apheresis procedure at our hospital using EvaFlux filter, 5820. So with excellent results. the serum, this total cholesterol was more than 600 milligrams, 700. So with one procedure, it came down to almost 50%.
That's fine.
Yeah, so this was EvaFlex 5820. It's a double filtration,
Yes,
like casket filtration.
Yes, sir. It has a fantastic result. Yes, sir.
Thank you.
So how often did you need to do it, Dr. Kejriwal?
It depends, like once a week. And these patients...
Most commonly is weekly only.
Weekly only. So these patients go to the cardiologist basically because they have got some kind of coronary artery disease. So there, if you have got tie-up with the cardiologist that any such case of a high cholesterol level, familial homozygosity, such patients should be referred to us for the removing of doing the LDL apheresis.
Yes.
How long they have to undergo this? How long
It's
they
a
have to undergo this treatment? Such cases?
Doesn't require
It's a
money.
lifelong.
It's lifelong, like. Okay. But some patients are lost to follow up, or they come from abroad, they have to go back. Then you have to tell them that they should be under constant follow-up for procedures if required, along with the medical treatment that they have to continue.
Thank you.
Thank you, Dr. Amardeep, for
Thank
that
you, ma'am.
wonderful presentation. And we'll now proceed with the next talk.
Yeah,
But
thank you.
Good to know so much about LDL apheresis and where we can refer the patients to. So the next talk is on evidence-based advanced apheresis technologies by Dr. Abhishek. Dr. Abhishek B. is an additional professor and head, JIPMER, Pondicherry. He has authored a book, Manual for Immunohematology and Transfusion Reactions, which is in 2 volumes. A recipient of many awards, he has been awarded the ISTM Young Scientist Award in 2019, the H.T. Shourie Award, ISBTI 2021, and the Harold Gunson Fellowship Award, ISBT 2021. Good to be an author at such a young age, so we welcome Dr. Abhishek to start his talk.
Thank you, chairpersons, and thank you, the organizers. So the topic given to me is specialized apheresis and their evidence base. Just by the outlook, the topic looks very broad, vast, but concise. When we talk about evidence, how does the evidence-based medicine, I have just shown this one on the 3. It's a 3-pronged, this one, where you have the clinical judgment, you have relevant scientific evidence, and also you take into consideration patients' values and preferences whenever you undertake a procedure or embark on a therapeutic intervention in a patient. Okay, so when we talk about apheresis, we broadly divide them into the donor apheresis, where we generally do it to collect some product, type of a product specialized, or the therapeutic apheresis, where you actually do to remove a pathogenic substance or a component from a patient to give him therapeutic benefit. And usually in that case, the product is discarded, whereas in these cases, the product is actually utilized for some other patient. Okay, so broadly, donor apheresis is based on what we actually collect, can be classified into erythrocytopheresis, the leukocytopheresis, the platelet pheresis, and the plasma pheresis, the main 4 components of the blood. In the erythrocytopheresis, we can have multi-component collection where we collect RBCs along with other products like plasma or a platelet or a double plasma and things like that. Or also, especially when we are doing exchange transfusion or collecting a blood from a rare donor, we can also go for a double dose RBCs, which will give you more amount of RBCs within a single collection. With regard to the plasma pheresis, usually it is done in 2 ways. It is either called the infrequent collection, where we do whenever there is a need for a particular type of plasma, like a COVID convalescent plasma or even AAB plasma when required for a usage in massive transfusion protocol, or the frequent collection that is usually done by the fractionation centers, where usually it is called the source plasma, where the donor is generally a paid one and he regularly comes for donation and the plasma is collected. Coming to the platelets, we have single donor platelets and a step ahead, which is called the HLA compatible platelets, especially when the patient has severe refractoriness and not able to get a proper increment. So then we try to choose the donors who are HLA compatible with them and try to collect the platelets from them. So that is HLA compatible platelets. And whenever we do that, it's better we always collect it with apheresis, because if we collect it with the random donor platelets, we know that this donor will not be usable for another 3 to 4 months. Whereas in platelets, it gives a window of opportunity where you can collect almost 6 equivalent doses of RDPs with single collection, and it can be repeated as frequently as twice a week. And coming to the leukocytopheresis, which is booming with a variety of horizon granulocyte concentrates, Madam has already spoken about it. Then we have the peripheral blood stem cells, which we generally use for hematopoietic stem cell transplantation. Then we have the donor lymphocyte infusion, that is when the engraftment failure, or when we want to do a tandem transplant or something, we give the lymphocytes alone from the donor and give it to the patient. And also, now lymphocytes are being extracted for the purpose of cellular therapy, which includes CAR-T, immunotherapies, regenerative medicine, and even gene therapies. So in all these instances, the lymphocytes are collected and separated or sorted based on the particular need, and then they are either engineered or minimally manipulated to get the product of your choice, which can help you in treating a patient. So that is about donor apheresis. And coming to the, among that, since granulocyte is covered, I just touch upon peripheral blood stem cell collection. So whenever we collect anything from apheresis, the two principles that are used are centrifugation and the filtration. So now, when we talk about the centrifugation, the principle is the specific gravity of the component. So if you can see in the middle part there, or the last one, the various components of the blood, that is plasma, the platelets, lymphocytes, each of them have a specific density, they have a specific gravity which is unique to them. So we harvest that based on those specific gravities, and when we give a centrifugation, they separate out based on the specific gravities, heavier being at the bottom and the lighter ones at the top of them. In the filtration method, they basically harness the diameter or the size of the particles. So platelets are the smallest one. Of course, plasma is a liquid, and then followed by red cell, lymphocytes, and granulocytes. So you have various filters which are specifically designed with a particular sieve space or the hollowness, and based on that they get separated and you harvest them. So that last one you see is the each one of them, including the neutrophils and the metamelocytes, all have a slightly different specific gravity and which can be harnessed when you want to collect them in particular. These are the various equipments. They have got into various kinds of transformation way back from 1940s, where they started with the Latham bowl, where the blood used to fill into the bowl and centrifuge. And nowadays we have moved on to what is called the belt or the spooling technologies. The one below is from the Terumo or the Optia, and the one above is from the Fresenius. So there is a belt which goes around the spool, and the centrifugation happens in the spool. These are the various equipments available for various apheresis procedures. So this is basically COPE spectra. Again, the machine is almost removed from the market, where you can see the product on the left side. And the only thing was there, when we collect the monocyte, we have to use that indicator chart to collect where exactly we are going to collect the products from. And now with advanced artificial intelligence and all, the machine does it itself, and we don't have to keep regularly looking for which portion we are collecting. So that is shown on the right side. If you see the manages the interference, interface for these products is managed by the AI or the laser technology, and it automatically removes the products. So this is just an inside figure to show how the belt works. This is the cross section of the belt. You can see that the middle portion, the one in the inside is the plasma, and the heaviest on the outside is the packed red cells. So in between, you have that buffy coat layer which contains platelet, lymphocyte, and granules. And based on that, that particular layer alone is collected in the apheresis machine. So coming to the modalities of the therapeutic apheresis, we broadly classify them into cytopheresis and plasmapheresis. Cytopheresis is where you remove the cellular substance which is the pathogenic problem there. So if you remove erythrocytes, as in sickle cell anemia, it becomes erythrocytopheresis. If it is leukapheresis, as we do in the blast crisis and leukostasis and other things, it becomes leukapheresis. And essential thrombocytosis, we do thrombocytopheresis. So we just remove that part of the cellular component which is the causing the disease or the pathogenesis. Coming to the plasmapheresis, therapeutic plasma exchange is done where wholesome plasma is removed off and replaced with the donor plasma. And there is also selective plasmapheresis where you actually remove only the part of the plasma that is having the pathogenic substance, and the rest of the plasma is given back. So the advantage here is you don't have to replace the patient who is undergoing the process with plasma at all, and we can manage most of the time with crystalloid colloids and albumin and things like that. So when we come to selective this one, we have something called as double filtration plasmapheresis and the cryofiltration. And we also have, this is just the filtration and the centrifugation based. And next generation, we also have what is adsorptive therapies, where is plasma is actually allowed to flow through some substances which can capture the pathogenic substance and retain it within the machine, and the same plasma is given back to the recipient. So that is one part of the thing that Dr. Amardeep was talking in the previous. So you have, one is called the direct hemoperfusion, wherein the blood as such is run over the charcoal or the this one. That's why it is called hemoperfusion. In the second one, actually you first, it's a two-step procedure where we first separate out the plasma, and plasma alone is exposed to the filter so that the harmful effects or the cytopathic changes that can happen in the platelets or the RBCs can be reduced. So we'll just go through each one of them. Before that, I will tell you, before embarking on a therapeutic plasma exchange, what evidence or guidelines do we have? So many societies usually generally give guidelines on what can be used in particular disease and not. But most popular one is given by the ASFA. The reason is it's more extensive, and they take into consideration the whole set of indications and do a thorough work over 2 to 3 years to come out with the guidelines. The recent one that we have is the ASFA 2023 guidelines. So what they do is they use something called as the grade system, that is grading of recommendations, assessment, development, evaluation for the evidence that can be followed for to decision making in apheresis. So they have various grades like grade 1A, 1B, 1C, and also 2A, 2BC. So how they do that? 1A is strong recommendation which has a high quality evidence. So there are two things. One is recommendation and the other is the quality of evidence. So what is recommendation is on the last type, that is implication, can apply to most patients in most circumstances without reservation. So that is what the recommendation says. And coming to the quality of evidence, that comes from the methodological quality of the evidence that they have used. For example, if it is an RCTs without any important limitations or overwhelming evidence from the observational studies itself, we all know that it's not possible to do RCTs in every case. And most of these are dire emergencies or the decision that is mostly based on desperacy rather than on the need. So good observational studies also have given the things. So like that, we categorize them into those with moderate recommendation and quality of evidence and things like that. So low quality of evidence would be something that has only observation studies or a case series. Then you have grade 2, that is basically a weak recommendation. So what does it say is, best action may differ depending on the circumstances or patients or the societal values. And when you have the quality of evidence also is low, other alternatives may be equally reasonable, and we should try to consider them before embarking into this journey. So when there are no guidelines and whenever your clinician requires you or requests you to do a plasmapheresis for a patient, like I recently was talking to Dr. Haim, he was telling, we have tried everything, Haim, can you try this? That's a general thing we also get. So in those cases, how do you make a decision? There is something called as McLeod criteria for evaluation of apheresis efficacy. So you consider 3 things. One is plausible pathogenesis. What is the pathogenesis of the disease that we are talking? Do we know the pathogenesis? Is it an established pathogenesis? Okay, for example, TTP or an autoimmune disorder where we know that anti-nuclear antibody is the cause of this. So is there a plausible pathogenesis already existing? The second one is better blood. That is, if you remove that blood from the patient, which is known to have a pathogenic substance, with a better blood, that is from the donor, will that get corrected? Then if your answer is yes, then go to the third one, per care patients. What is per care patients? The patients, so you know a disease about its pathogenesis. We know that if we replace this component, either a plasma or RBC with a other one, it will help. Now what is this help? This help is not mere alteration in the laboratory's values, but clinical advantage or efficacy in the patient. For example, whenever we talk about TTP, we say, has the LDH decreased or has the platelet count gone up? These are the things that we usually follow. But platelet count has definitely gone up. Say yesterday PTTP, the patient count was 30,000. We did an exchange and today it is 52,000. Fantastic results. But is it clinically significant? If the patient is going to bleed irrespective of whether his count is 30,000 and 52,000, you did not make any life better for that patient. So this is how we have to think when we make a decision on the therapeutic plasma exchange or any type of. So keep these 3 things in mind. Many times we get requests for poisonings which we have not heard of, or even sepsis. Okay? So think of these things in those terms and try to get an answer out of your experience and from the, of course, from brainstorming among your colleagues who have experience and know things about that. So we'll go into each of them. What is double filtration apheresis? So it's basically called as membrane differential or a cascade filtration plasmapheresis. In contrast to the apheresis where it's centrifuged or filtered and the plasma is removed, here actually first the whole blood from the patient is sent into the plasma separator where the entire plasma comes out. And now this plasma goes into the second one, which is called as the plasma component separator. And here we all know that when we talk about plasma, there are as large particles as fibrinogen, which are around 7,000 Armstrong, and smaller ones also, immunoglobulins, which are much larger, IgM, and IgGs, which are smaller, and all these things. Based on that, we can target a particular filter and separate them. That's why it is called as double filtration plasmapheresis, where plasma is first removed in the step 1, and in a second phase, based on the size or inflow or outflow, we can still segregate the things in the plasma and do the exchange. So when we talk about plasma exchange, there are 2 types of immunoabsorption. That is, one is non-specific immunoabsorption. That means to say, all the components, like we all know that antibodies, which are IgGs, which are the problematic, these filters will remove the entire IgG, like IgG1, G2, G3, everything. Okay? Things like that, M, A, E. So that is non-specific. You are not specifically extracting any particular section, subsection of the immunoglobulin, but in general everything. Okay? So there are various types of columns made of staphylococcus protein, peptides and things like that. We can also remember Dr. Amardeep showing this, and that is on the remarks. So when we talk about this non-specific immunoadsorption, one is cost. Obviously, these are very costly. The other thing is there are something called as regenerating filters and non-regenerating filters. So what is regenerating filter means? Every time the plasma passes through this filter, before the next site of plasma comes, the filter regenerates itself. That means to say, whatever it has absorbed onto the surface, it has a mechanism to remove them off. So that is called as regeneration of the filter. In non-regenerative filters, once the absorption happens, the filter has to be changed. So whenever you are making a decision of this type, take into consideration of what is the kind of pathogenesis, what is the substance that I am going to remove off, and what is the filter I want to use. In selective absorption, what happens? You particularly target a specific antibody, like anti-dsDNA or something like that, okay? Or an anti-CCP protein, or even a cryoglobulin, something like that. So here, the selective extraction of the pathological plasma constitutes in a way that minimizes the sacrifice of the entire healthy plasma proteins, which includes coagulation, the albumin, and all these, okay? And obviously, it is more efficient treatment of disorders with lesser theoretical iatrogenic coagulopathy, which is generally associated with the plasma exchange. So I will talk about this one condition because it is known that this dilated cardiomyopathy is the leading cause of heart transplantation worldwide. Around 67% of the heart transplant is because of this dilated cardiomyopathy. So it's a cardiac disorder in which left ventricle is dilated and exhibits impaired contraction. Okay? And this is basically a idiopathic familial post-viral or alcohol, and it is a autoimmune disorder where the body develops antibodies against the cardiac myocytes. So it is one condition where these adsorptive filters, they usually remove the autoantibodies which are directed against the cardiac myosin heavy chain or the myocardial beta-1 adrenergic receptors. Okay? And these are all IgG3 subclass. So if you use this selective absorption, we can just remove that particular segment. Apheresis can also be used in diagnostic purposes, like isolation of a blood component for disease prognosis, and is typically applied in hematology and cancer research, which we want only that particular and remove those cells and use it for the study. Okay? And we also know that nowadays with viral immunotherapies, where if you remove immune cells like anti-EBV or anti-CMV T cells and you grow them in culture and give it back to the patient, and all this kind of things can be done with the apheresis. So for example, circulating cancer cells are collected from the peripheral blood of cancer patient without requiring a biopsy. We all know that, especially hematogenically spread cancers and all, we have micrometastasis in the blood which can be extracted by apheresis. And of course, it removes, especially like something like mediastinal tumors and all, where diagnostic biopsy it can be very lethal or associated with derail comorbidities and other things. Then one specialized thing which have attracted people, which is called as photopheresis. So what is photopheresis is, basically it's a therapeutic procedure wherein a buffy coat is separated from the patient blood and treated extracorporeally, that is outside the body, with a photoactive component, usually a psoralen, and exposed to the ultraviolet light, and subsequently this product is infused back to the patient as shown there. So you have step 1 where white blood are collected, then you add psoralen and you expose to the UVA this one and give it back to the patient. It has an interesting history as to how this started. That is the river Nile, and way back thousands of years ago in Egyptian civilization, people were treated with vitiligo they were asked to go and eat, that is called as the Ami majus, a plant which was grown on the banks of the river Nile. They were supposed to eat the leaves of this plant and have to lie on the banks of the river completely exposed to the sunlight. And that was treating vitiligo. So this act as, it has a component which is actually soralen, and this was dated back thousands of years ago, and that is how people came to the, that is how the history for photoapheresis goes. So as of today, only few indications are there which are evidence-based. One is the cutaneous T-cell lymphoma, or what we call as the mycosis fungoides. And, and the other one indication is chronic GVHD in a post-heart and lung transplantation. So what this does is treatment induces apoptosis of the malignant cells, which are phagocytosed by antigen-presenting cells following the reinfusion, and it stimulates monocyte differentiation to myeloid dendritic cells with a Th1 phenotype that launch a cytotoxic response against the malignant clone. So that is how the whole benefit of the photopheresis works. So what are the advantages of ECP when compared to the systemic therapy? Relative lack of immune suppression, because there is no chemotherapy agent at all. The soralin is just a photoactivator which acts on the cell that's outside the body, and many a times you can remove this soralin which is unused by washing. And lower risk of infections, obviously, because again the immunosuppression is cut short. So duration of cycles, it is said that 2 days of one cycle every 2 to 4 weeks is required. The median time for maximal response is about 5 to 6 months. So this should be kept in mind whenever you get a request for photopheresis. Clinicians, once they, because patient has to spend a lot of money, and the next thing comes is when to expect a benefit out of that. So to patient to really get a benefit, we may have to wait for almost 5 to 6 months, and some patients may take as long as 10 months to respond. So it's very important you liaise with your clinician when you embark on such journeys. When maximum response is achieved with ECP, it can be reduced to one cycle every 6 to 12 weeks, and subsequent discontinuation of the process if no relapses occur. This is after that 6 months. And if it recurs, they can be reinstituted to once or twice monthly, and so on. And if there is no response or the disease progresses even after 3 months of ECP alone, a combination or an alternative agent should be considered. Then I told about graft versus host disease, how it helps. Again, the treated lymphocytes, when they return back to the patient, they increase the dendritic cell differentiation, downregulate the autoreactive B cells, and alters the T helper subset population, and helps in lymphocyte homing the antigenic display on their surface. And also switch from pro-inflammatory to an anti-inflammatory cytokine production happens, and there is generation of the regulatory T cells. So that is how it is beneficial in the GVHD-induced post-cardiac or lung transplantation. So in acute GVHD, a 2 to 3 treatments weekly until response obtained, which is minimum of 8 weeks. And chronic GVHD, we should do one cycle weekly or every other week for up to 3 months. And then, if responding, taper to one cycle per month as per the clinical response. There are other diseases for which this has been tried: inflammatory bowel disease, nephrogenic systemic fibrosis, pemphigus vulgaris, psoriasis, systemic sclerosis, and things like that. But even in heart, liver transplantation, but the evidence is generally weak. Then another specialized that we generally talk about is rheopheresis. Rheo means the viscosity of the blood. So these are diseases wherein the blood or the flow of the blood is altered in those people, and that is the cause of the various problems. And there are various diseases we have heard of when we are surgery, Burger's disease and all that. But as of now, one evidence-based indication for rheopheresis as of today is what is known as the age-related macular degeneration, or the wet subside. So what it does is it removes high molecular weight molecules like fibrinogen, LDL, alpha-2 microglobulin, LDL cholesterol, IgM, fibronectin, and all that, which may impair the retinal microcirculation because of the viscosity of the blood. So it reduces the viscosity and thereby reduces the erythrocyte aggregation and improves the retinal pigment epithelium perfusion and function. It has been tried in peripheral vascular diseases or also in what is known as the sudden sensorineural hearing loss. So same improvement of inner circulation, inner ear microcirculation happens, and hair cell function improves by acute reduction of this fibrinogen or the cholesterol level. So that is how Apheresis works. Then there is cryofiltration. We know that there is this condition where the cryoproteins or cryoglobulinemia, which are generally cryoglobulins and cryofibrinogen, form in the plasma, which are thick, and they causes the stasis, and this can be treated with what is the specialized apheresis. The only difference here is, since these are cryoglobulins and once they are exposed to cold, they coagulate or coagulum. So you will have a warmer disease as shown there, okay, and that warming helps the plasma to go back to the patient. And the cooling system, actually once you warm, these cryoglobulins disappear. So there is no way of extracting them out of the plasma. So here, first you have a cooling system where it cools the plasma so that the cryoglobulins form, and that is removed, and the plasma is heated and returned back to the patient. So this cryogel, which is the precipitated fibrinogen and fibrin degradation product, at a temperature of 2 degrees is extracted, and we can also use it in cold disease, cold agglutinin disease, and also been used for treatment of rheumatoid arthritis, ulcerative colitis, and HLA antibody and ABO incompatibility in kidney transplantation. Then there are other things like this is called AN69 based Apheresis membrane. So the difference is the membrane. For example, if you see the outline of that, you can see the first layer, which is polycryonitrile copolymer, which has a negative charge. So it will absorb cytotoxin, which are obviously positive charge. Then you have the second layer, which will have something else, and it will absorb the endotoxin. And the third layer will have a heparin, and which has an antithrombotic role. So these are all modifications of the specialized apheresis which we use to use them in various conditions. So where do we use that? In patients with sepsis or septic shock, it helps by reducing lactate levels, SOFA score, and also removes the concentration of endotoxin. Because in many times we know sepsis and all, we have multi-organ failure because of multiple organisms. There could be a swarm of bacteria which are both gram-negative as well as gram-positive. So it may be difficult with one type of filter to remove that. So you have specialized where they can act both on exotoxins and endotoxins. Then something called as coupled plasma filtration absorption, wherein again they have a hemofilter, and there is a media sorb which actually allow you to absorb the toxins, okay, based on the resin that is used. Then you have the molecular adsorption, wherein here a neutral macroporous adsorption resin is used, and it can specifically absorb things like bilirubin. We know a lot of things like we do exchange transfusion, many times it is to remove the bilirubin as well. So these kind of things can actually just remove the bilirubin, or you can use in even the HBV-induced chronic liver failure, and it acts as a bridge to the liver transplantation. And we all know that expanding role of apheresis in especially the liver transplant and liver institutes, and these are all things that are coming and we can use them. Then there is also molecular adsorbent recirculatory system, which is generally used for fulminant viral hepatitis or drug-induced ALF, where you can remove the drug where there is no other effective mechanism or an antidote available for that. So this is just a description of selective immunoabsorption. I have told you that means they selectively remove one subset of the immunoglobulin. If it is ABO specific, they just remove ABO antibodies, so that we know we use it in ABO incompatible renal transplantation. Then there are IgE specific immunoabsorption, which can just remove IgE products, which is generally used for atopic dermatitis and severe allergic asthma, can lead to up to 86% of reduction. And beta-2 microglobulin columns have been used especially for dialysis related amyloidosis. And the advantage is they can be simultaneously used with dialysis. Many times we get a request from the nephrologist saying that patient is on dialysis, but we need you to do an plasma exchange. So we can do that. I will end it there. Thank you. These are my references.
Dr. Abhishek, a wonderful and lucid talk. Very well presented. Any questions, please?
I must compliment you on bringing out all the recent advances and exciting, applications of this field. And in fact, you were mentioning ASFA 23. New indications have come out, and I think these new indications are really going to impact biotherapies also. Wonderful talk.
Excellent presentation. I think you have covered from A to Z of apheresis. Nothing is left. There are few trials, like when it comes to cases of acute liver failure or acute and chronic liver failure, where people have tried MARS system, molecular absorbent recirculating system. Even Prometheus has been tried, but these results are not good. So the people have switched over to the other methods of like immunoadsorption column using glycosorb or vitrosorb column for removing the antibodies. So excellent.
It's always nice to know what have been tried and failed also, sir. Yeah. Otherwise, we will be reinventing the wheel and doing the same
So Mars has been tried, Prometheus has been tried, but it has failed. So it's not recommended. Thank you.
But I must say that this is the time when we should not give apheresis in the hands of clinicians. We are sitting on a very big opportunity of bringing clinical improvements.
Well, very lucid presentations. Well, what we have actually, once we say evidence-based, and what is applicable, what we have done practically in our settings, well, we have used the columns. We have done, for example, ABO group transplants. We have done for the hypercholesterolemia. We have done, well, as Dr. Kritpalji mentioned, that we used the Mars. And in the ICU setting, the people have used the column for the severe sepsis. But the advantage is what they are, this thing. Some of the things what we have found, group comparative transplants and other, we have found. There is an evidence, it has helped, we have done. The procedures. Some of the things where it has not, well, it's still on the trial basis going on. And actually, well, people like you, those who are young, well, I think this is a field where we can explore the things. And this needs to be done on the regular basis. And I think in the coming days, the things may change for the transfusion medicine.
So the most of these patients, multiple modes of therapies will be going on. It's very difficult to tell which actually benefits the patient. So that is an...
This practically what happens is, because basically there is a need to have an interface between the clinicians and the transfusion medicine people. But unfortunately, I have seen the transfusion medicine people do not interact with the clinicians. Practically, you need to get involved. In there is an CME program happening in every hospital. When there is a medicine clinical meeting, the transfusion medicine people should also get involved. Go and listen their lectures, what they are talking about, and well, you will learn what they're, where you can throw light. Yes, you will feel that there is something where you can help them, and that is how you can penetrate into there, and they can take your help. And that is what is needed in the coming days, but it is lacking presently. Well, I don't know what are the things, why we are not going, and nobody stops you. You should interact with them. I was regularly going in any clinical meeting, for example, like HELP syndrome. We have practically got involved with them and told them that we can help you. And these are some of the things what you can do only once you have a interaction with the clinician. Otherwise, you will not be able to. You have to, sometimes in case they know, yes, there is something what transfusion will, then only, otherwise they will not come.
So good inputs there from our seniors, as always. And now I think we should close the session for the next one to start. Thank you.
Thank you so much for such a productive and engaging session. Dr. Abhishek, we will now felicitate you. Can we request our chairpersons to felicitate Dr. Abhishek B with a memento? Can we now request Dr. Sood to felicitate our chairpersons for the last session, which is session 3rd, but there are 2 panel discussions. Dr. Anju Verma. And Dr. Mrinalini Chaturvedi. Gentlemen, let's get ready because now the first panel discussion will take place on the stage, and it is all about legal implications related to transfusion medicine. And the moderator for the session is Dr. Gopal Patidar. Let's welcome sir. A warm welcome, sir. Sir is the additional professor for Department of Transfusion Medicine, AIIMS, New Delhi, and has been awarded with Dr. Harold Gunson Fellowship by ISBT at Taiwan, Award of Excellence, 45th Virtual Annual National Conference of ISBTI 2020, Young Scientist Award, 9th Trans MedCon 2021 by ISTM, and all right, over to you, and let's make this panel discussion memorable. These are the speakers' bios.
Thank you so much for kind introductions. And again, thank you to Dr. Rashmi. So in this panel discussion, our first panelist are Dr. Colonel Satish Kumar. He is a senior consultant and head of department at Med Super Specialty Hospital, Dwarka. He is recognized professor of immunohematology and transfusion medicine. Dr. Satish, sir. And our second panelist is Dr. Kamini Khilan. She is vice chairperson, Department of Transfusion Medicine at Sir Gangaram Hospital, New Delhi. She is also vice chair of hemoglobinopathy subgroup of International Society of Blood Transfusion. Welcome, Dr. Kamini. And our third panelist is Dr. Anil Gupta. He is a professor at NC Medical College, Haryana. He has 13 publications in international journal, 9 chapters in books, and chairperson of SIG PBM of Indian Society of Transfusion Medicine. Welcome, Dr. Anil, sir. So I welcome my panelists. Our panel discussion is mainly on the legal issues related to the transfusion medicines. So can I have slides, please? Okay. So we will discuss about mainly the various legal issues related to donor, as well as transfusion-transmitted infectious diseases, and the clinical transfusion medicines. So first we start with the donor-related issues. So my first question is to Dr. Satish Kumar, sir. What are the potential legal issues if a blood donor experiences severe vasovagal reactions after leaving the blood donation centers?
So the blood donation center all the staff, including the medical officer, there is a duty of care towards the donor. So duty of care does not end with the donation process only. It includes the post-donation also. So when we talk about having a severe vasovagal reaction after leaving the donation area, so that indirectly implies there has been a negligence in the duty of care. And it could be due to either the post-donation counseling has not taken place, there has been a negligence in the observation of the donor for any symptoms of vasovagals which might have arisen, or the duration of observation was too less. The donor has gone off in a hurry without following the instructions. So if these things are documented, it comes under, basically it can be proved under negligence. There has been a negligence in the blood center for not performing the care of the donor.
Yeah, sir. So, sir, I want to say that before leaving the donor should have signed in the register before that he is well and he is able to go to the home.
Basically, the important thing is the duration of stay post-donation.
Yeah, yeah. Sir,
Normally, all these working people, they come, they say कि office में late हो रहा है, इतने बजे meeting है. So we also develop a soft corner कि चलो donate कर दिया है. So let him move out. So
yeah,
that
at least they should take the proper time to rest and post-donation in area.
And even it's very surprising to note, later on we come to know, even people are driving two-wheelers and four-wheelers just after donation. So these instructions should be there in the post-donation counseling, what we give, what are the precautions they should take after donation of blood.
Yeah, thank you. Thank you so much, sir. So our next question is Dr. Anil Gupta, sir. So what are the legal implications if blood is collected from the minor donors like under 18 years and who concealed their age during the screening process? Sir.
Yeah, thank you, Dr. Patidar, and thank you, Dr. Rasmi, for inviting me for this topic. Basically, there are different minimum age in different countries. In India, it is the 18 years, completion of the 18 years. In UK and US, it is the 17 years. So basically, we are bound to Drugs and Cosmetics Act of India. According to the sections as criteria of blood donation or selection of the eligible blood donation, the age has to be 18. She or he should have completed the 18 years of the age. There are different types of the offenses which has been described in under section 18A of the Drugs and Cosmetics Act. And in these sections, under section 6, any drug or cosmetic in contravention of any of the provision of this chapter or any rule made there under, that means Drugs and Cosmetics Act is being offended by any blood center, licensed blood center, then it is a punishable offense. So basically, it is the liability is of blood center to bleed blood from eligible donor. So basically, you have to cross-check, you have to verify, and if you are satisfied that at the certain age, like 18, whether it is really 17 or 18, you have to check either by asking about Aadhaar card or any other document which you are feeling comfortable. And what are the punitive actions if something is going to happen? It all depends on the, to be very frank, there are lots of power which has been vested with the Drugs Controller Department, with the drug inspector, which you, if you have a coordination, then they can give you warning, they can suspend the license, or they can they can cancel the license, depending on the severity and depending on the grievances which they supposed to have taken place in this blood bank or according to the blood bank. So basically, suspense under this part, there is a punitive action under section 16 of the Drugs and Cosmetics Act, and they can, if the manufacturer or authorized agent or importer fails to comply with any of the conditions as per the drug licensing authority, then they can suspend or cancel. Before their suspension or cancel, they have to ask in writing the explanation. And they are satisfied, this probably they will give you a warning, otherwise they have full authority to suspend or cancel license of the blood bank for a period or for as fit necessary. So if like there was a question from one of my colleagues yesterday that this is the question when eligible donor has not completed the age 18. But what happens if he is a minor or she is a minor and after donation something went wrong to that particular donor? Then who will be responsible? Because he or she has concealed the fact. So basically once he has given the donor, and that types of the activity will come under the definition of the law of tort. There is a civil liability, but there is a law of tort. In this law of tort, this is a noun by definition. This is the area of the law that deals with the wrongful action of the individual or a entity by which there is an injury to another individual. This is a nutshell. So tort liability is basically, it's a legal term, tort, and it can be the tort liability if there is injury to someone, which may be intentional, like, or it may be negligent act, like we have not asked the actual age, but we have not confirmed. So this is the negligent act. So we are responsible for the tort liability, and if he or she, or if his parent or her parent can claim the compensation according to the court of law, in the court of the law, according to the tort liability. So this, depending on the offenses, this can be reimbursed, the punishment by the court or award from the court can be of the reimbursement of the property or loss of the property. They can award medical expenses. They can award for the suffering of the pain, or they can award any other punitive action. So these are probably, I have taken from the various sources all the action which can be held. Thank you very much.
Thank you, sir. So it's a liability of the blood center to confirm the age of the donor before proceeding for the blood donation. And it's especially in the donors which are near to 18, this problem is commonly come that like they told that we have just 1 month latch or 1 day's latch of the 18 years. At that time, this liability happens.
I think it has to be perfect.
Yeah, thank you so much, sir. So our next area is the transfusion-transmitted infectious disease. In this first question is to Dr. Kamini. So if your blood center typically perform nucleic acid amplification testing as an additional safety measurement, and due to unforeseen circumstances, you do not have that sufficient amount of the blood, and you procure the blood from the another blood centers, which does not perform the NAT testing, but conduct another mandatory test like serological testing, ELISA or chemiluminescence. What are the legal implications of issuing non-tested blood to patient of your hospital?
Thank you, Dr. Gopal, and thank you, Dr. Rashmi, for this panel. This is a common problem which is arising with many of the blood banks. We are having a higher end specificity of blood available with us. We are doing NAT test. And since that particular blood group is not available, we may be sending it out to some other blood bank for getting the blood for that patient. Ideally, ideal situation would say that you should try and get the blood from whichever center which is providing you the same level of the blood. Suppose I have another center nearby which is giving me the same type of testing which is available with my center, so that there is no discrepancy in the type of blood that I am providing. But suppose that is not available, then what? So as per the law, clear testing, if it is done, or the 4th generation ELISA, if it is done, then you can definitely use the blood for that patient. That will not be a problem at all. But as far as your ethical concerns are there, or to consider that the patient should be informed, because if we go into the legal implications of the things, we find that there are 3-4 things under which a blood bank is made liable, and one of them is communication, information sharing. So for that purpose, as what we do normally in such cases is to inform the clinician as well as to inform the patient's relative. We tell them that this is the situation, the blood particular tested to that level is not available, and we make it a point to get a consent written either on the request form or separately on a consent, so that we have made them aware that basic testing will be done, but this level of the blood testing is currently not available due to this particular reason. So if they consent to it, they have a right to information. So that information is passed on. If they are okay with it, then we go ahead with procuring that type of blood and we issue it to the patient. That's what we are doing. Thank you.
Yeah, thank you, ma'am. So you already answered the next question also, that do we have to explicitly communicate with the patient as well as the relatives and taken the consent from them before they issue the blood? Thank you, ma'am. So my next question is to Dr. Satish, sir. What legal complications could arise if a recipient reports the contracting HCV infection 10 years after undergoing the therapeutic plasma exchange, and during that procedure he received 10 units of the fresh frozen plasmas?
Basically, I think these screening significance has come in after the latest, I think, Supreme Court decision which has come, in which heavy compensation was slapped. So basically, see, 10 years post-therapeutic plasma. Now the cause for the HCV has to be established. Now all records are kept for generally 5 years as per the licensing authorities, whether it is donor registration or whether it is the screening status. So 10 years is too long a period to take into cognizance ki how many units of plasma was given. Secondly, were this plasma implicated? What was the mode of testing of plasma at that point of time? Whether it was an older generation or let's say a rapid method by which it might have been overlooked, the benefit of doubt remains. But finally what happens, ki there is a stretch of this thing filing a complaint. So beyond 10 years, by and large, complaint is not adjusted. So second is what the lawyers call a discovery rule. Ki once the patient is discovered to have HCV positive, they take it as a day zero. So all those things technically it is covered in the informed consent which the donor signs. Ki the blood will be tested for these things. If anything turns out to be positive, you will be intimated, called, counseled, and you are told that this is a screening test, you have to go for a confirmatory test. So 10 years, this is more of a fear factor which is coming in. Infectious reports, we should keep it now for 10 years and not for 5 years to safeguard our interest. Finally, the lawyers, they have a twist and turn to everything, so they can twist your case whichever way they like. But 10 years is too long a period to hold the data at any blood center. That's my call.
Yeah, sir, like means you want to say that we are liable till 5 years when it is required the data as per the Drug and Cosmetic Acts. After 5 years, it could be returned or not returned. Yeah, thank you, sir. So the next question is to Dr. Anil Gupta, sir. So what are the legal ramifications of notifying a blood donors about HIV reactive results that falls within a gray zone area?
Thank you, sir. As per national standards for the blood center, as per the national standards for the blood center, in clause 8.3.3.5 and 6, my donated blood and plasma, my blood will be tested for hepatitis B, C, malaria, and other things. I would like to be informed about any abnormal test done on my donated blood. And I understand that screening tests are not diagnostic and may yield false positive results. If someone is in gray zone and blood bank thinks it may be positive, it may be negative, then it has to be informed. Because if prospective donor has given the consent that in case of the abnormal result, it has to be informed. And if blood center is thinking that this is the abnormal, gray zone is the abnormal, then it should also be provided the information to that particular donor. Second thing, the way of the information to particular donor has to be telephonically be called personally. They should not be declared on phone. They should be called in the blood center, and after counseling has to be informed properly. This is the indeterminate test result. Need to be a fresh sample which has to be retested, and if it is found positive, then he or she should be referred at appropriate space, like a pathologist or for the syphilis center. And for ICTC, like if you continuous asking for the to come back to the blood bank for 3 consecutive weeks with proper documentation, and if he is not coming back to the blood center for fresh sample, then you can refer as a gray zone to, if it is more than the cutoff value, to the ICTC for the further necessary action. This is my.
Yeah, thank you, sir. So you want to say that we are also liable to inform the donors if it comes under the gray zone areas?
Yeah, because we are thinking it may be
Yeah, it could be the positive in the future science. Yeah, thank you so much, sir. So our next area is the clinical transfusion area. So again, my first question is to Dr. Kamini ma'am. So what are the legal implications of issuing best match or least incompatible blood in the following scenario, like PRBC for patients with irregular antibodies or who are alloimmunized?
Okay, again, this is, as such, I would say is not a very big a legal implication, because most of the times, best match is the route for transfusion if you're not finding a match for the patient. So normally, this kind of thing doesn't go into much of a legal implication, but what is important is, again, the information sharing with the patient or with the physician. That's the question. We normally inform the physician. Physician will write maybe on a separate slip or on an issue slip to issue the best match. But we do remember that there is something called a consent where the patient is signing. So whether that particular thing should be mentioned on the patient consent or not, and whether the physician has informed the patient that the quality of the blood which is available is not fully matched, whether that type of consent should be taken on that consent form to protect ourselves from, again, the breach of information pass on, which can be a part of the legality. So ideally, according to me and according to the safety rules, not only the physician, but the consent which we are getting filled from the patient should also have a sign of the patient which says that, yes, best match is the best answer at the moment, which we normally also inform the risks and the benefits involved as part of the consent. So that should be taken to safeguard ourselves. That's
yeah, thank you, ma'am. So then in the following other scenarios like non-group specific platelet transfusion or PAS additive platelet apheresis.
Again, these are some things which are commonly followed. Non-group specific platelets being issued in oncology patients or in other patients. PAS is now being used, so non-group specific platelets are being provided. So again, here it's an open question. If anybody has any solution to this thing or is actually following some kind of policy which could bring about, make us away from that kind of legality, or whether it is really required. This question has been raised for that purpose. If anybody has an answer to this, we're most welcome to answer that. If anybody is following any kind of...
It is safe. Well, you don't need to keep, but it is being done all over the world. So there's nothing wrong.
Nothing wrong. It's internationally, it's a very common practice to use a non-group used platelet.
So ideally we should, it's not necessary that we should take a consent for non-group specific platelets or no information is required to be given to them.
I think in the informed consent, what?
That's what. So in the consent, when we are issuing or when we are taking a consent, whether we should take a consent with respect to that non-group specific is being issued, which we normally don't take.
We are doing it. We are doing it. Yeah, so it should be.
In India, it is not mentioned anywhere that you can use the PAS additive solutions. It's FDA approved, yes, in US. It's not come out, sir, your information.
So
you are ahead of that.
Use of PAS is allowed, but the use of information to be given to the patient, I think a consent as informing the patient that it is a non-group specific. I feel it is on the safer side.
Ma'am, as far as non-group specific platelet transfusion is concerned, we have got it endorsed in the patient informed consent form as well as in the SOP to that effect. So at both places it is mentioned.
I totally agree. But what happens is even we have to issue an A negative blood, suppose to an A positive patient. The doctors themselves are not ready right now.
There is apprehension in
There is an
clinicians
apprehension in
actually.
taking a negative blood for a positive group patient. Yes. That's what. Every hospital, we have physicians like this, but still we at our center have found certain cases where A negative blood was issued. So, I mean, just giving an example, A negative, but it was issued and it was returned back saying that. So after that, what we started was, before we are issuing a negative blood, we are taking the physician into confidence. We are informing the physician that there is no harm in issuing or getting a negative blood transfused to an A positive patient. So we are just putting it on record on the request form that so-and-so doctor has been informed. And we also write telephonically informed. That's not an issue. But we record it and sign and put their name and sign my name that I have informed. Yeah. Has to. Yes.
Yes, ma'am. So it's a quite varied practice in various hospitals in different hospitals.
So it is good to document. That's important.
Yeah,
and as far as you are giving anything beyond the normal and non-group specific pass, as ma'am is saying, I think we should definitely document with respect to the consent. Yeah, no. So Dr. Ketappa, do we have to take a separate approval for that pass? No, from the drug control as a product.
Yeah, we need to take.
As a product, if we have to use it, then we have to take a separate license for pass platelets. So that's.
Yeah, SOP should be there.
That you are doing, but whether the patient information and doctor information, between doctor, no? So at least on the form, at the doctor level, the information should be there and that should be documented somewhere.
See, I've got one thing to say. When we go to the bank to get loan, you have to sign 10 pages in small letters. You don't know what you are signing, but you are doing it. Similarly, when it comes to consent, informed consent, it should be mentioned even in small letters somewhere that you can give, if need be, you will be giving group non-specific blood, but it will be compatible. Somewhere write it down in the consent form. No harm in mentioning that.
No, but sir, that should be informed actually properly.
No,
not you are hiddenly taking the consent from anywhere.
No, it is not like that. See, your SOP mentions it, your consent form mentions it.
Yeah.
And you are not doing any harm to the patient.
Sir, in our organization, we have taken consent for PASS during Apheresis procedure. And last 2 years, we are using PASS for entire SGPC and pool plated also.
Okay.
And
thank you so much. So next question is to Dr. Satish Kumar, sir.
Not taking license. For liquid depletion, we have license, all this, pool plated also, but PASS, we don't.
PASS separately, currently they are not given license, yeah. So, Dr. Satish, sir, in the event of unavailability of specific blood group or product, who is the responsible for arranging it and what are the consequences if any, it cannot be obtained?
So I think this question, most of process remains the same. That first of all, you look within yourself, in your own inventory, whether the donor is available or not. You look around for the other blood centers if anybody is having, or you look into the family members if it is a rare blood group, if they know someone. Secondly, whether it is for elective procedure or it is emergency procedure. If it is for elective procedure, you have to talk to clinician if blood is not available. This procedure should be deferred for some time till the time blood arrangement is made. If it is emergency, then even if the O negative principle does not exist, then I think the relatives needs to be told that no blood is available. Otherwise, the least is that least incompatible blood if we can issue to save the life of the patient, that we can think of. So I won't take much of a time.
Yeah, thank you so much, sir. So in the continuation of the next question, if you do not have that specific blood group or rare blood group units, then you ask from across the India and for 6 to 12 hours between blood centers, what are the ethical and legal consideration should be taken into account in these things?
Thank you. This is commonly seen especially in the Bombay O group. So basically, as per the national standards, as per clause 8.17, transportation has to be done in controlled manner between 2 to 10 degrees centigrade temperature in thermal box, and the temperature, there should be a way to monitor the temperature throughout the journey from one blood center to another blood center. Either you can put a battery-operated data logger which can continuously record, and if data logger is not available, then you have to record just before the dispatching the blood. And at the time of receiving the second blood center, and then it has to measure. If this temperature is under control, then this can be used. Otherwise, it is probably as per the legal requirement cannot be used. Few things has also been kept in the mind when transferring one unit or number of the units from one center to another center for a long distance. Then one is the temperature thermal injury has to be prevented by preventing the thermal, by using the thermal box. Another most common injury is the physical injury, which may lead to hemolysis of the red blood cells. So this has to be taken care during transportation. There should not be unnecessary jerking during the transportation. And once if it is going through the flight, then it should not be put in the baggage section. It has to be kept in the cabin section, and preferably in the lap of the recipient. So it will not have jerks from the floors and other vibrations. Thank you very much.
Thank you so much, sir. So my last question is to Dr. Kamini again. The transfusion of administration record with the proper patient monitoring are essential component of a hemovigilance system. What are the legal implications if such records are not maintained in hospital-associated blood centers and in standalone blood centers?
Again, this is one of the, legal implications are there, but to which extent, that is very important. Because as part of our NABH accreditation or as part of our drug controller requirement, we are maintaining the records as part of the vein-to-vein transfusion. So at the end of the physician end, or you can say the patient end, we are recording it. But suppose we are not recording the administration records properly, then is there any legal implication to the blood bank? Again, this is definitely there. So but hospital-based blood center, we can look into it. But what is the legal implication for a standalone blood center, if anybody can throw light on it? Because I could not find any specific answer to this, because there is no... So if...
So standalone blood banks, once they issue it, it's the responsibility of the hospital receiving the blood and the clinician, because it's a patient-specific blood which you have asked. So the responsibility for this transfusion administration lies with the clinician, not with the standalone blood bank which is issuing it.
Yeah, right, sir. With the standalone blood bank, it's liability till the day I have issued the blood. And after the issue in the blood, it's a liability of the hospital where they are issued.
Even within the hospital, if you are associated with the hospital,
is a liability of the
then we have a liability because we are part of the hemovigilance system. So there we have to take care of that part.
Can I add something, sir?
Administration rates, duration, those things you are not controlling. So finally, documentation, you have to ensure it is done. but liability does not remain on the blood.
Like in morning, it was discussing that the empty blood bed, they are taken back into the blood centers and they are autoclaving that things. So, but some of the blood centers are doing that since that practice also. So, yeah. Yeah. So thank you so much, panelists, for the nice discussion.
Thank you, sir.
Thank you.
Thank you so much.
That was a very inquisitive session. Ladies and gentlemen, now we will request our moderator, Dr. Gopal Patidar, to kindly come on stage and hand over the mementos to all the panelists. We have with us Dr. Satish Kumar. Now may I request Dr. Kamini Kilan to kindly come ahead. And Dr. Anil Gupta. Dr. Sood will felicitate our moderator of the session, Dr. Gopal Patidar. Let us all get ready for the panel discussion too. It's all about improving transfusion, reaction, reporting in the hospital. And the moderator for the session is Dr. Hem Chandra Pandey, Additional Professor and Head, AIIMS, New Delhi.
So, good evening, everyone. Those who are still present with us. Will not take too much time. I have with me the panelist, Dr. Sangeeta Agrawal. She is Director, Head of the Department, Fortis Memorial Research Institute, Gurgaon. And I think Dr. Amit is not there. Huh? Okay. नहीं सर वो मेरे हाथ में भी but okay. So I think Dr. Amit was supposed to join online, but he's not here. Anyway, if he is there, he is Additional Director and Head Transfusion Medicine, Fortis Escort Heart Institute. And Dr. Abhinav, the third panelist is Dr. Abhinav Verma. He is Principal Consultant, Head of Department Transfusion Medicine, Max Super Specialty Hospital, Vaisali, Ghaziabad. So I'll not go into further details, and I'll welcome the panelist here. So can you project the slides, please? Yeah. Okay, Dr. Amit has joined online. Hello, Dr. Amit. Yeah. Can you project the slides, please? Yeah. Next, please. So, as we all know that a blood transfusion reaction can be any untoward reaction towards transfusion. So, we are regularly reporting to our hospitals as well as to the Hemovigilance program of India these adverse transfusion reaction. You can see that their incidence was reported to be around 0.84%. This is 8.4 per 10,000 blood product. That would come to around 0.084. So, although almost every 2 or 3 days we have one adverse transfusion reaction reported, but when we see the actual data from whole India, it is quite less. So there is something missing and we need to improve upon that. Can you just go ahead? So this is from the HPPI data. You can see that most of the transfusion reactions are very, very few. Although in my own experience, we see that only the severe transfusion reactions are reported. The milder ones are usually not reported. The day before, one of our gynae patients, they consulted me saying, कि sir उसको leukodepleted product दे दो. मैंने कहा why? Sir उसको reaction हो रही है. मैंने कहा तो you have not reported to us. We don't know किस तरह की reaction हो रही है. So then they started telling that the patient had this and this and that. So 2 or 3 times he had. So we require leukodepleted products now. So that means there is something missing and we are missing a lot of transfusion reactions which is not contributing to our data. So in this context, we will be going from the transfusion reaction to how we can improve upon those transfusion reactions. So the first question will be towards Dr. Abhinav. Dr. Abhinav, is there a time frame to define these adverse transfusion reactions? Because anything which is related to blood transfusion is considered a transfusion reaction. And if yes, can you please elaborate upon them? So next slide, please.
Good evening, all. So yes, there is a time frame to define transfusion reactions. As you can see in the slide, they are acute transfusion reactions which occur within minutes, and usually 90% of the transfusion reactions occur within the first 15 minutes. That's why first 15 minutes monitoring is very, very important, essential, either by the nursing staff or the doctor in the transfusion area, to 24 hours of transfusion. And it could be like acute hemolytic transfusion reactions, acute allergic or anaphylactic reactions. Then there can be delayed transfusion reactions which usually occur from 24 hours to, it could be 30 days later, and usually present 2 weeks, could be delayed hemolytic transfusion reactions. And then there are very late transfusion reactions like iron overload, or it could be transfusion-transmitted infections such as hepatitis B and C, which might take months to years to manifest. Thank you.
So there are transfusion reactions which may happen quite late, like TTIs.
True.
So in the hemovigilance program, which I have shown the figure, there were some TTIs, transfusion-transmitted malarias, which were described, although we have not got any report of transfusion-transmitted HIVs, HBVs. Though in newspapers, we do get such kind of reports. So the next question is to Dr. Sangeeta, ma'am. Ma'am, why one should be reporting transfusion reaction? They are being managed by clinicians, and they usually monitor them. They do whatever needs to be done for that particular transfusion. So what do we get as a blood transfusion expert from these transfusion reactions? And is it mandatory to report these transfusion reactions? Can you go to the next slide?
Okay. So reporting a transfusion reaction as such is not mandatory.
Next slide.
It is a voluntary thing in India especially. So why do we need to report ATRs is because it helps us in enhancing the safety of the blood products and blood bank supply. And if a reaction we are able to work on the reaction and find out the causes and the plausible reasons which were there and where was the problem. So identifying those is very important when we are giving blood. And this helps in, like, for example, we were showing the HPPI data and all. This defines what is there and what needs to be improved in our system, whether from the blood bank side or from the transfusionist side, whether they are using the right processes and systems are in place. Then also it helps in epidemiological surveillance, control and prevention of adverse transfusion events in future. Then when we have a focused reporting and communication with the clinicians about this in the hospitals, and it's an appropriate investigations and management for the future transfusions by the clinicians. They also know that where they need to improve. Then hemovigilance system, as such, you know, it helps in elucidating the transfusion practices. It helps in the research which we are doing for the new identifying new hazards or new things which we are not reporting, having in our literature, and it helps in improving the patient outcomes as well.
Yes, I fully agree with you, ma'am. They are both helpful at institutional level as well as national level. So we may be thinking that we are only getting these kind of reactions, but if we see the national data, some reaction might be very high. So that actually helps in identifying which are more, and maybe we could look for the reasons for them. So the third question is towards Dr. Amit, who has joined us online. So Dr. Amit, who is responsible for this reporting and whom to report these transfusion reaction? Is it the responsibility of clinicians or only the blood bankers?
Thanks for the question. Blood transfusion requirement is collective responsibility of the blood bank also and as the clinician side also. But transfusion is carried out at the bedside. So concerned nursing station as well as doctor on duty is responsible for managing the blood transfusion and accordingly manage the transfusion reaction also, and to report the transfusion reaction if it happens to the blood bank in a preset format along with the blood sample, urine sample and blood bag along with the transfusion reaction form. It has to be reported to the blood bank in a timely manner as soon as possible.
Okay, so actually the current responsibility lies with blood bank. So whatever the clinicians are reporting to us, we have to report it to the Hemovigilance Program of India. Though the onus should lie on both of the clinician as well as blood bankers. If any other panelists have to add anything to this?
Actually, sometimes the clinicians report very vague signs, symptoms or very vague scenarios of the patient, and it has been happening in our setup also. And as per whatever reactions they are giving and sending the TAR sheet, we work on it and we don't find anything wrong. But the reactions keep on happening repeatedly in some of the units and with some of the teams. So I have been telling them that you need to check your side whether your nurses, your team is doing the correct, or they are adding some medicine or using the same line or using some fluids which were not acceptable during that and causing the reaction.
Sometimes they are reporting something which does not correlate.
Exactly.
We get a lot of such reaction.
Right.
They would write that the symptom was dyspnea and the pre and post transfusion respiratory rate will be 16. So,
So
this is mainly because
for example,
I think
for us, we are using 100% leukodepletion, but they have a common practice of adding fever as one of the component in the sign symptom. And in those cases, I tend to get the sheet of the file of the patient, and I check the vital sheet, which is different from the transfusion record sheet, and there the vitals are okay and no fever, but here they have mentioned fever. So I asked them, how could you just put in fever just because?
So maybe this is because the onus of reporting is on the blood bankers. They have no responsibility.
Monitoring of vitals is also equally important.
Yes.
And our respiratory rate and everything is okay, but they're just
I think we can actually communicate to them about what are the benefits of these transfusion reactions. So my next question is to you, ma'am. What are the benefits of reporting these transfusion reaction? So can you give some of the examples? There are some examples world over, ma'am.
I'll take this question.
Okay. Yeah, okay. I'm sorry. This is to Dr.
No problem.
Yes.
So reporting transfusion reaction is very crucial. It helps firstly in identifying what is the main reason behind the transfusion reaction, categorizing it, and it thus helps in proper management of the patient. So thus helps in patient safety. It also helps in improving the blood safety because it helps in identifying what is the flaw in the process, whether the transfusion, for example, was started within 30 minutes, whether there was delay in stopping the transfusion or the transfusion carried out beyond 4 hours, for example, at what temperature it was kept out, whether the cold chain was maintained or not. Even at the blood center point also it's very important that whether the proper storage was done or not, whether the proper cultures were done or not, it could be contaminated also. So it helps also improving the quality control at various levels, not only in the blood center, but also in the transfusion site. And at the same time, it also helps in identifying the gray area so that we can focus especially on the training and education, maybe of the nursing staff, if they're not handling the blood products properly, especially the GDAs who don't, for example, they take the blood from the blood center, but they don't give at the transfusion site, for example, within 30 minutes, and they are being given multiple tasks. So it's very important to tell them the importance of starting the transfusion at proper time, that is within 30 minutes, completing the transfusion time at proper time, and also a regulatory compliance also. For example, if most of the blood centers are NABH, so they have made it mandatory that we have to comply with the National Hemovigilance Program of India, and it has been also recently included in the Drug and Cosmetic Act that every blood center who's having a reaction has to report the transfusion reactions. Yes. So in that way, it helps in improving the patient safety, blood safety, quality control, and as well as the regulatory compliance.
It definitely have a lot of benefits. Yes. One very glaring example is Trali. When short came, actually they found out that Trali is because of plasma by looking at the whole short data. True. So that's one example which we know. Even transfusion transmitted bacterial infections were identified to be mainly because of platelet components. So these are some of the examples, and by this bigger data, maybe at institutional level we have very small picture. But if we look at national level through HVPI, we may have. So there are certain benefits apart from what you said. There are long-term benefits also. Some unrecognized reaction may be recognized that, like I have heard a few cases of transfusion, post-transfusion seizures. Yeah. There are few case reports in thalassemia patients. So
the TAD was recently added as a...
Yes, ma'am. So it definitely, reporting definitely gives some benefits. So ma'am, the next question is to you. What is the existing mechanism to report the transfusion reactions? How we are reporting it currently?
So in a hospital setup, whenever a reaction is happening, transfusion reaction is identified at the bedside, the blood center is informed and contacted, and we get the form and the blood samples of the patient. A urine sample for investigation, and the blood bank officer is supposed to scrutinize that form, and the investigations are carried out, and it is worked upon whether what could be the probable cause. Now, these reactions, these reports are then shared with the clinical team to understand where it was, whether there was some gap between in the blood bank side, or there was nothing which was identified. And then we inform and put all the details on the Hemovigilance Program of India. And so that's
yes, and I think the whole process is voluntary in our country. So, Dr. Amit, can you tell me if there are any other mechanisms followed in any in other countries? We have a voluntary system. So, are there any other systems? If yes, can you just elaborate on them and how they differ from our country?
Patient hemovigilance is followed in many countries. As per ISBT data, country follow hemovigilance and they require reporting. Reporting varies from country to country. Some countries require reporting only of serious reactions, some only of fatalities. This depends upon the country profile, country own discretion. As this has been discussed, in our country it is voluntary. So it has decided based on the threshold and capacity to receive and work out on the reports. So in some countries, only fatalities are reported, in some serious reaction, and in some all. In our country, as per NABH hospital guidelines, we try to follow all transfusion reactions, eventful and uneventful. They are supposed to be reported to the blood bank in a timely manner.
Thank you, Dr. Amit.
So I think like in India, it's not voluntary, but in country like France, which has made it mandatory to have it done.
Yes, ma'am. And in some of those countries, even near-miss errors are actually included in the hemovigilance program, so that they understand where they went wrong, which has not resulted in any error, in any adverse events, and they can improve upon that. So we are only reporting what is happening. Which was prevented is not being reported in our country currently. So the next question is to Dr. Abhinav. What are the limitations in current, although some of them we have discussed, but what are the limitations in the current reporting system?
The previous slide or the next slide?
Next slide. Yeah. Next one, please.
So definitely there are limitations of current reporting. One and the foremost I'll say is underreporting. So for example, if the patient is having mild fever or pain, so they will either think that it's because of the underlying drug or the patient is having pre-symptoms of that, so they will not report it. At times, they will do delay in the reporting, especially for the reactions which are in the night time because of the limitations of the staff. So they will say that we'll report in the morning. So there is delayed reporting. Then there is insufficient follow-up also. For example, they have sent the culture of the patient, but they are not, for example, they are following it up, that what was the culture, whether it was positive, negative, what was it, whether. So that is also important. And then there is a lack of standardization. For example, I have also mentioned in my presentation that there has to be proper grading, there has to be proper reason what was the transfusion, why was the transfusion reaction mild, moderate or severe. So lack of standardization is also helps in identifying the root cause actually. If it is not done, so it's very, very difficult actually if it is not standardized, the transfusion reaction not standardized. So these are some of the common reasons where there is limitations in remoting. So the best thing is to teach awareness and take again and again sessions for the nursing staff, especially for the clinicians, that whatever, if any reaction happens actually, so please don't think that it is due to the underlying drug therapy or any symptom, just report it to the blood center so that we can work it out and we can find out whether it is a reaction, whether it's an incident or what.
Okay, ma'am, you have to add anything?
My next question will be somewhat follow-up
Yeah,
of this.
if you would ask me, the form is so exhaustive, that is one of the biggest limitation. It asks so many questions, sometimes not even required for some of those transfusion reactions. So, but it's fine. So next question is to ma'am. What are your suggestions to improve the present reporting system? It may be to other panelists also, if they have some other suggestions.
So I think, first of all, we need to make the reporting system in a more simpler format, because sometimes filling up those forms and all becomes a more cumbersome job for the nurses and all, or doctors on duty who are heavy on work on that particular time. And a second very important thing is they first need to know, is it a reaction, or is it something related to the transfusion, or is this something not related to the transfusion, so they are not able to pinpoint what kind of reaction are we supposed to.
Ma'am, but we only say that anything which is during the transfusion should be reported, because we have an imputability to it. So,
right. So,
yes.
but the thing is, sometimes that's what I'm saying. So they're not able to report,
Yeah.
believing that it may be related to the patient condition, and
Yes.
they don't consider it
They
to be
don't
a
report it.
transfusion
Yes,
reaction.
ma'am.
So,
So
that
this
is
has to
the-
be educated,
Yes,
yeah.
and they sometimes ignore that. As you said that you didn't get the transfusion reaction because they were not able to pin.
Initially the reactions are milder, so they won't report.
Yes.
But when it became regular, then they will say, yes, there is some problem.
Exactly,
Yes.
because it's repeatedly happening.
And adding to that, we should monitor each and every transfusion feedback form. So for example, we are having an issue register, and in front of that only we are having a column of transfusion feedback forms. So we track each and every form actually. So once the blood component is issued, the transfusion feedback form should be filled in the system so that we can monitor whether the vitals were okay, for example, pre-transfusion, during transfusion and post-transfusion, because they will mention all the things in that. So monitoring of the transfusion feedback form also helps in improving the reporting
So would
system.
having a hemovigilance nurse
True.
be helpful, like it was
Yes.
being discussed in the previous one?
The important thing is having a non-punitive and a non-judgmental approach
Yes.
for these kind of reportings, because sometimes people start, okay, that means the blood bank either is not functioning properly, it is not giving proper blood, or the transfusion site is not managing things properly. So people are afraid and having those kind of apprehensions. So and they want to put the thing on the blood bank only, that the blood may have some problem, you check your blood, it is causing these issues. So they also don't want to take this thing and follow up and all. That one hesitation is in that aspect. And as we are talking about sensitizing the importance of
Yes,
reporting is very important.
So how can we involve the clinical staff in this reporting system? This is to Dr. Amit. Because as we can see, they play a very important part in reporting of the transfusion reaction. And if they understand the importance, they would be more involved, and we might improve this reporting. So how can we involve the clinical staff in reporting?
Sir, frankly speaking, clinical staff is having the key role in identifying the transfusion reaction, managing the transfusion reactions, and then reporting the transfusion reaction. And for them, like Madam is saying, training the clinicians as well as clinical staff is the major pivotal role in managing the transfusion reaction, because they play a role in identification of the blood unit and patient identification. They help to prevent near miss events, monitoring vitals, blood transfusion, managing identification of transfusion reaction, managing of transfusion reactions, reporting to the blood center along with the samples for further evaluation, and they act as very important link between a TM specialist and a clinician to manage the transfusion reaction as well as the patient. Most of the time, clinicians are not involved. This is the clinical staff which is involved at all levels for the blood center, all activities.
So I would like to add, because whenever we are having a transfusion hospital transfusion committee, we need to discuss the type of reactions which are being seen, yes, and which are the areas which are most commonly having those episodes, and what could be the probable cause, maybe what side was it. Yes. So it will help them in realizing that there is something needs to be done. If it is not just a basic allergic reaction, if it is more beyond it, then they need to understand what
so STCs are a very good platform where we can try to have more participation from the clinical people. Yeah. It would also help in identifying which areas require more education and clinical people to be involved with us. Yeah. So maybe you rightly said STCs are a very good mean, because if somewhat is reporting more reaction, it could be actually stressed on to improve from that, and we can find out what issues are there and we can correct them. True. So I think maybe the last question that do you think delayed transfusion reaction or near miss errors should also be included in our reporting? We are not, although we are not able to report the actual reactions from happening, but sometimes like irradiated blood. Yes. So we get a lot of requests where our technical staff would realize that this patient might require irradiation. The doctors would not mention it.
The most common problem is WBIT, which is a near miss in most of the places.
That is another one. Yes.
That is a major cause.
So, do you think they should be reported, or?
Yes, it should be, because it is, I think, the sample taken correction has to be happening from the bedside. If they are not informed and they are not involved and it is not reported, they will not understand the seriousness of the situation. Because we have had few cases of WBIT, couple of cases in last 3-4 years, and the nurses would not agree that they had not taken the wrong sample or they were this thing.
There are so many reasons, ma'am. We have a lot of WBITs, I will tell you.
But what I would say, it happened there, because it happened, and what is the, like in the morning we were discussing how and the samples to be taken, 2 samples to be sent at 2 different times. If they are collecting sample in 2-3 tubes at one time and sending that same sample throughout the day.
Yeah, deviation from SOPs are the commonest one. The things which is but the reasons behind those deviations are very, very interesting. We have one of our pediatric resident, when we asked why he has not labeled and collected samples in the morning, he did not wanted to do the phlebotomy on a child again and again. So his intention was not wrong, but the deviation would have harmed the child too much. Yeah. So I would say yes, all of us agree that even these near miss errors should be reported. There is a lot to be done to connect to the clinical staff, because the actual reporting is being done by them, not by us. We are just collecting that data, investigating and reporting it to HPPI. The actual reporting is being done by the clinical staff. And they have to be sensitized that even a smaller reaction may be occurring very quite frequently, and if not reporting, they are missing out, and maybe that may be preventable.
Yes, definitely. It helps on proper management also later.
Yes. So if you have any final comments, we would just wrap this up. So if you have any panelist or anyone else would have, how we can improve upon these reporting things.
I think everybody has had enough of transfusion reactions.
So most important thing is reporting. Yeah.
Yes, and clinical staff has to be involved.
Yes.
So one is, I think, hemovigilance nurse would do good. But again, practical aspect of that has to be thought about. In a hospital like ours, where we have some 10 buildings spread around, and every floor has some 10 wards, so having so many nurses would be
number of transfusions per day is very high. So how to manage that all process is very
Secondly,
difficult.
that NABH criteria, where one has to report no transfusion reactions also.
Yes.
So the clinical staff is already overburdened. So that also we have to actually, if we want to improve, we have to consider that also.
Yeah.
That whenever there is no report, we should consider
the
no
reporting
transfusion.
is the tip of the iceberg in every setup.
Yes.
What is reporting is happening is just as a tip of the iceberg, which is much more below.
Yes.
So if we look at actual things, there may be more reactions happening in all the setups.
Yes.
And I believe that in such CMEs, more clinical participation should be there. So, because such a nice CME is here.
No, I was really hoping that some clinician would be.
Yeah.
So,
yeah, definitely.
मेरा डॉक्टर अभिनव when called me, तो I said कि कोई clinician भी है तो ज़्यादा अच्छा लगेगा. But anyway, it was a good discussion. I hope कि थोड़ा बहुत हम लोगों को clinical departments के साथ relation improve करने की ज़रूरत है, so that they report even the minor reactions. So anyone else want to actually add anything? Already we are very late though. Thank you.
Thank you so much for a crisp session, Dr. Pandey, and it was moderated really well. Now, ladies and gentlemen, let's begin the felicitation of our last but not the least panel discussion. We will firstly felicitate Dr. Sangeeta Agrawal. Give me some energy, everybody. Yes. Now, Dr. Abhinav Verma. Will felicitate the moderator of the session, Dr. Hem Chandra Pandey. And now let me please invite Dr. Rashmi Sood on the dais to deliver the vote of thanks.
Good evening, everyone. I thank Manipal Gurugram, Atom, the organizing team, the chairpersons, the speakers, the panelists, our wonderful guests and delegates for making this event a grand success. Our respected chairpersons, our speakers, our panelists deserve special recognition for accepting my invitation. Sincere thanks to Dr. Megha ma'am for constant guidance and support. Our team Manipal has been constantly putting a great deal of effort. Thank you, Naveen sir, Dr. Megha, my sincere gratitude for allowing this event to happen today. Finally, I thank the hosts for giving me the opportunity to represent them. Thank you so much.
Thank you so much, Dr. Rashmi. As we draw close to the evening, the pre-function area is all set with a lid of tea and snacks. Please, while walking out of the venue, do not forget to collect your goodie bags also. Please have tea and snacks. And we are really very, very thankful for your time, your unwavering commitment and dedication to today's event. Thank you so much.